You can start, ma'am.
Good morning, everyone. Myself, Dr. Bhagyashri Deshpande, along with Dr. Rashmi Ajmera and Dr. Rupali Patskor, welcome you all on behalf of IMA Akola and APMPA, the Association of Practicing Microbiologists and Pathologists of Akola, on an interesting CME, COVID-19 Myths Decoded. As we all know, we are facing COVID-19 pandemic since 2019. We have already faced first and second waves, and third wave is at its peak. Still, there are few myths and doubts about COVID-19, and we exactly don't know how the disease is and how the disease will progress. This is a small attempt to clear the doubts and myths of everyone through this webinar. We are very fortunate to have the stalwarts of this here for this CME. Now I request APMPA President Dr. Ajay Junjunwala sir to inaugurate today's CME and say a few words regarding this CME. Now I hand over mic to sir. Dr. Ajay Junjunwala, President APMPA.
Am I visible to all? Hello.
Yes, you are.
Respected and dear doctors. First of all, I welcome you all to today's online webinar, COVID-19 Myths Decoded, on behalf of APMPA, the Association of Practicing Microbiologists and Pathologists of Akola, and IMA Akola. It's over 2 years now since this pandemic has begun. Medical fraternity is fighting really hard to contain this pandemic. But during the course of this pandemic, a lot of bizarre remedies have been tried, like chloroquine, doxycycline, ivermectin, methylene blue, and plasma therapy, etc., which later proved to be ineffective or counterproductive. So we need to contemplate on scientific research data and formulate a sound scientific policy and a protocol to manage COVID patients and contain the third wave. Today, we have organized this webinar to discuss different dimensions of COVID management, right from epidemiology to investigations to treatment and vaccinations. The list of speakers participating in today's webinar have done some very significant and invaluable contributions in the COVID management over last 2 years. Dr. Anita Matthew, Dr. Kedar Toraskar, and Dr. Mukund Ashtaputre. They are working as a frontline warriors, tirelessly and with dedication, and saved thousands of lives over last 2 years. Dr. Sudipto Roy and Dr. Anand Kaude, they have done research, development, and clinical trials of different COVID vaccinations over last 2 years. And Dr. Pradyot Garge has done a lot of homework and communications to point out a fallacy in the role of D-dimer in the management of COVID patients. I'm confident that today's webinar will definitely give us a better insight and perspective in the management of COVID patients. So enjoy today's academic feast. I welcome you once again and thank you all. Thank you.
Thank you, Dr. Ajay Junjunwala sir, for inaugurating our CME. Myself, Dr. Rashmi Ajmera. I am practicing pathologist at Akola since 7 years. So without wasting much time, we will proceed to our first lecture. Our guest speaker is Dr. Sudipto Roy. Dr. Roy is a Deputy Director of Division of Infectious and Communicable Diseases at ICMR, New Delhi. He is a part of New Clinical Studies and Trial Unit at ICMR. He is also a part of modeling. He is also a part of modeling team for COVID-19 scenario. So now I hand over the mic to Chairperson
Dr. Nitin Veragade, sir. Dr. Veragade, sir, is a physician, scientist, and global health professional. He has done immense work for a health organization, Vaccine for All. And Dr. Shailendra Mundara, sir, he is a consultant pathologist and immunologist. He has also done great work in immunology and also received many awards for that. Presently, he is working as a director of Dhruv Pathology and Molecular Diagnostic Lab. So I will request chairperson to proceed forward, CME.
Sure. Thank you, Dr. Rupali. Am I audible?
Yes, sir.
Okay. So thank you very much. Today's CME is very important. As you know that since last 2 years, we've been battling this COVID-19 pandemic. And in a way that there is a lot of misinformation, what has been labeled as infodemic by WHO, which is happening all throughout the world. And that's why this CME, appropriately titled as COVID-19 Myths Decoded, will give you the academic twist of authentic data, authentic information, and what to believe and what not to believe. So I believe that initial session and initial talk on epidemiology of COVID-19 by Dr. Sudipto Roy is very apt and very appropriate. He is from ICMR, and ICMR is spearheading this effort of COVID-19 pandemic response in India, as well as contributing to international strategies as well. So without spending a lot of time, along with my fellow co-chair, Dr. Shailendra Mundara, I invite Dr. Sudipto Roy. Before going to Dr. Sudipto Roy's presentation, I hand over to Dr. Shailendra for a few words, and then we can start the lecture. Thank you. Dr. Shailendra. Dr. Shailendra, you are on mute. Yeah.
Yes, it's a great topic to have for discussion on this Sunday morning, and looking forward to the words of wisdom by our esteemed speaker. Thank you.
Dr. Roy, please.
Yeah, good morning. Good morning to all my respected colleagues and seniors and friends. Thank you, first of all, for inviting me for this this CME. And as it's already been introduced, said that, even though we are almost 2 years into the pandemic, actually more than 2 years into the pandemic, if you see, there may be still some questions regarding the COVID-19 disease, the SARS-CoV-2 virus, organism, etc. Right? So it's probably a good time now to kind of just talk about some of the basics of COVID-19 and especially the epidemiology part, the organism, the part, the infectious, etc. And so that, and then we can take it on, take it on to the remaining, the other sessions that are also equally important as far as removing the myths of COVID-19 go. So thank you all. So what I'm going to do is I'm just going to talk today. I won't have, I've deliberately not put in any slides because I thought epidemiology probably is better understood through a dialogue rather than just putting up some slides and then our interest gets attention gets diverted to something on the slide, and then the discussion that we probably don't pay much attention to. So what I'll do is I'll just speak about the epidemiology. I think most of you probably know about the epidemiology of SARS-CoV-2. However, it'll be good to just touch upon some of the basics and look at some of the recent developments in the epidemiology and basically in the understanding of the virus, understanding of the disease and what's happening currently, not in globally as well as in India. And then, of course, I think if time permits, we'll probably have a few questions at the end of the session. I'm happy to try to answer them. If not, maybe at the end of during the panel discussion, at the end, towards the end of the whole CMA session, of course, we can again go back to some of the questions that probably may remain unanswered. So, without any more further delay, I'll just start I'll start with the basic virology, not too much in detail, but the basic virology regarding SARS-CoV-2 virus. So, as all of us know, it is the SARS-CoV-2 virus, which is the causative organism for the COVID-19 infection, is a coronavirus, which coronavirus is basically envelope positive stranded RNA viruses. And there's a whole big family of coronavirus. Coronavirus is something which is not new for us, right? I mean, if you remember the 2009, 2010 SARS that we had, it's a type of coronavirus. Then there was another in 2002, 2003, there was another pandemic. Then there was a pandemic in the Middle Eastern part of the world, which is known as the MERS. So coronaviruses are not new to us. I mean, human beings have been facing epidemics and pandemics due to coronavirus over the last many decades. Unfortunately, the current coronavirus pandemic, that is a COVID-19 pandemic, has increased much more than what had been there before. The one significant topic or one point that I would just like to point out here is that the host receptor for the SARS-CoV-2 cell entry is an angiotensin converting enzyme, right? I mean, that's the receptor. Now, this is important because this has implications for diagnosis. This has implications for treatment, most importantly for treatment. So I mean, of course, there are much more detailed mechanisms of receptor binding and then their absorption, etc. But we won't get into that. I just wanted to highlight this fact that this ACE2 inhibitor, ACE2 converting enzyme 2 is the binding receptor for SARS-CoV-2, and which has implications for treatment. Now, like any other virus and like any other coronavirus, there are different variants. Okay, there are different variants, or what is commonly now known, as most of you would probably know, as VOC, or variants of concern. I mean, actually, there are hundreds of mutations, right? I mean, ever since the COVID-19 pandemic started in December 2019, and the first case was detected in China, as all of us know, in Wuhan, China. Since then, there have been hundreds of mutations. There have been many variants that have emerged, but not all are cause diseases, or not all cause illnesses. Only a few of them develop the ability to infect human beings more rapidly, and not only that, cause tissue damage, cell damage, and cause illnesses and diseases. Hence, these variants are mutants, we can say. They are known as variants of concern. And I'll just briefly touch upon the main variants of concerns that we've had till date, globally as well as in India. And as you probably all know, that the variants of concerns are designated by WHO based on the Greek alphabet, system that they have. So if we look at the most important in terms of causing illness, causing widespread pandemic, it was the Delta, right? Or the technically it's the B16172 lineage. The Delta lineage was first identified in India in December 2020, and then since has been the most prevalent across the world until the emergence of the Omicron variant, which I'll talk about after this. Now, before Delta, there were Alpha, Beta, etc. However, the Delta was the first, one which was so widely transmissible and which was also much more pathogenic than the previous Alpha, Beta, and other lineages. In fact, in studies from the United Kingdom, it was seen that the secondary household infection rate associated with Delta was as high as 14%. That is the attack rate. Secondary attack rate by Delta was 14% as compared to only 9% for Alpha, which was there previously. There is some data, some of which is unpublished, there are references, unpublished, some of it published, which suggests that upper respiratory viral RNA levels are higher at diagnosis and remain higher for the Delta variant as compared to other variants or the previous variants. Thus, this shows that the infecting amount of the RNA of the virus, the infecting viral amount or material that is there, was or is still, not just was, it's still much higher for Delta as compared to the previous ones, Alpha, Beta, etc. And hence, this probably is one of the reasons why Delta was so highly transmissible. Along with that, and unfortunately, the more important issue with or the problem challenge with Delta was that infection with Delta was associated with a higher risk of severe disease and hospitalization. I think now most of us, in our practice, we would have realized that mild infections of COVID-19 do not bother us. As clinicians, as researchers, or even for the general public, it's fine. The problem is that sub cohort of patients that move into moderate or severe diseases, condition of the disease from mild, and that is the challenge. That is the cohort that needs to be taken care of extremely carefully. And unfortunately, Delta was associated with a very high risk of severe disease and hospitalization as compared to other diseases. In fact, we all, I think data all shows that in specific at-risk groups or high-risk groups, that is, I'm talking about individuals aged, say, more than 60 years, or individuals with comorbidities such as diabetes, hypertension, more importantly, diabetes, or renal failures, or renal or any other chronic diseases. They have a much higher risk of developing moderate and severe disease and then needing oxygenation, needing ICU support, etc., and hospitalization, etc., as compared to other groups, say younger groups or people without any comorbidity. But unfortunately, and this was reflected in the wave that came last year between March and June. All of us have been through the wave. Most of us would have been treating patients and also been doing research in that. We saw, right? And that wave in India, if you look at in India, not only world, in India, was primarily driven by the Delta variant, right? Now, fortunately, over a period of time after last year, after June 2021, by October, November, fortunately, the Delta variant infections came down. One reason could be vaccination. One reason could be a natural mutation also. But unfortunately, at the same time, we saw the emergence of the Omicron lineage, right? Or the Omicron, or technically it's the B11529 lineage, right? This was first reported in Africa, specifically in Botswana, and then in South Africa, the country of South Africa, in November 2021. However, it is accepted, that even though that this variant was probably in circulation much before November 21, it was just that it was detected first in South Africa in November 2021. Now, Omicron, what was seen initially in South Africa, and now we have been seeing over the last 2-3 months in India also, it is very highly transmissible. It's much more transmissible than Delta. So, I think all of us probably are probably experiencing right now, over the last 2 months, almost every second household or third household, or probably even much more than that, are having cases, are being COVID-19 positive cases. Now, not all of them are being undergoing genomic testing, so we really don't know whether, what is it? Is it because of Omicron or Delta? But an assumption can be made based on the Omicron and Delta characteristics, those lineage variance characteristics, that such a high rate of transmissibility is most probably due to Omicron. However, I mean, it still needs to be confirmed. We can just only speculate right now. It needs to be confirmed. The major difference between Omicron and all of the other previous variants was the number of mutations in the spike protein, right? So I think, okay, I just missed that part. I mean, I think probably many of us know that it's a spike protein on the envelope, on the RNA, the virus envelope, that, that binds to the receptors and then it causes the infectivity. Mutations in the spike protein are important to note because that has implications for effect of efficacy of vaccine and any medicines that can be given for or that need to be developed, and antivirus that need to be developed, right? And generally speaking, I mean, if I speak about generally for in virology, many of you would know, the higher the number of mutations, the more difficult it becomes to control it, or more difficult it becomes to develop vaccines against or medicines against these mutations. Not again, or not all mutations would be harmful. Some mutations may not cause any, may not result in any difference in the virus replication or in virus binding, etc. However, the sheer number of mutations, that is more than 30 mutations in just the spike protein in the Omicron virus, is probably one of the reasons why it is so highly transmissible and why it affects so many. Again, Omicron is a relatively new variant that we have seen. There isn't adequate data as of now, but however, there is some emerging data which is coming up regarding Omicron from research data, which shows two very typical characteristics or very clinically significant characteristics of this virus. The first is it has a replication advantage. So what it means that Omicron, it appears to have a greater replication rate than Delta. Now, if we looked at if we come back to the secondary attack rate, which was around, say, 13 at the peak of Delta, it is almost as high as 20 for Omicron. Okay, I mean, this was based on a very small sample size data from the UK. However, this probably holds true in a clinical practice also. And the other replication advantage that Omicron seems to has is that in some in vitro studies and in animal studies and in lab-based studies, they have shown a preferential replication of Omicron in nasal epithelial cells and bronchial tissue compared with the Delta, right? So this probably shows a greater affinity of the Omicron to our respiratory cells, especially the upper respiratory tract cells, as compared to Delta or any other SARS-CoV-2 variant before that. So this is one clinically important aspect regarding Omicron. The other clinically important aspect regarding Omicron is a higher rate of immune evasion. So what it means is that Omicron appears to escape humoral immunity, and it is associated. And secondly, it seems to be associated with a higher risk of reinfections in individuals previously infected with a different strain. Again, in very preliminary data based on some national surveillance from South Africa, the rate of reinfections in a period of 90 days, that is, say, in a period of 3 to 4 months, as compared to primary infections, was higher in the Omicron wave, if we can call it, as compared with the beta, alpha, delta waves that were seen previously. These findings have been.
I'm sorry to interrupt you like this, but are we supposed to be seeing your screen?
No. Sorry, I just mentioned that I've deliberately not put in a PPT for now. I just wanted to speak about this and interact with this.
All right. My bad. Please carry on.
Yeah, no problem. Thanks. So this immune evasion was also corroborated from a study in Qatar, in which they also showed that a higher risk of reinfection, and basically it probably suggests or indicates that Omicron's probably it escapes the whole immunity mechanism that we have, if not completely, but some part of it, there is some rate or some degree of immune evasion for Omicron. Now, these obviously are important challenges clinical, because these are implications for clinical practice, of course. Because if there's a higher rate of immune evasion, if there's a higher rate of reinfection, and if there's a higher rate of replication in the respiratory tract by the Omicron, obviously we need to consider these during in our clinical practice. Fortunately, the third characteristic of Omicron is probably a good one. I mean, if I want to say it is advantages, is that it shows that, I mean, till now, observational data shows the risk of severe disease with Omicron is much lower than the other variants. Again, this was shown from hospital-based studies in South Africa, as well as an hospital-based study in England, in which they found that the risk of hospital admission was almost 1/3 as compared to Delta. And I think this is something that we have been saying. The clinicians on this panel would probably be a better person to say, but I mean, I think even in India, the risk of the hospitalization rate, or even need for oxygenation and ICU admissions have been probably 3 or 4 times lesser in this current wave, that is from December or November onwards, as compared to the Delta wave that we had last year in between March and June, with the peak was between March and June, right? Now, this again has been shown, it's not been confirmed, but some in vitro studies and some animal studies, in fact, not just in vitro studies, animal studies have shown a lower viral levels, RNA levels in lung tissue. So basically, it has a affinity towards the upper respiratory tract. The Omicron virus has an affinity towards the upper respiratory tract cells. It is not found much. It is found in some patients. It's still found, but in overall, it is the affinity of Omicron to the lower respiratory tract tissues are much lesser. However, we need to still be careful about the higher at-risk groups. So individuals or patients with immunocompromised conditions would still have a relatively higher risk of Omicron virus affecting their lung tissue, the lung parenchyma, and then causing severe, moderate to severe diseases. But unfortunately, I mean, the other another way to other side of this coin is, even though Omicron does not have a higher risk of moderate to severe, which is a good thing, because of the sheer numbers of Omicron disease. The total absolute number of Omicron is so much higher than Delta, because of which higher transmitter, etc. If we look at just pure numbers, we have to still be careful that hospitals can still have a large load of moderate to severe disease of Omicron. Even the proportion may be less, but overall numbers, because of the number of patients that are being affected by Omicron, so number of patients with moderate severe also can be higher. So this is something our health system, hospitals, etc., need to consider and be prepared for, even over the next 2-3 months. Now, I've talked about Delta and Omicron in details because these are the variants that have affected us, India, as well as globally the most. Now, there have been previous variants, Alpha, which was first identified in the UK, Beta, which was again first identified in South Africa, and there was a Gamma variant, which was first identified in Japan and then Brazil. However, fortunately, they have not caused much damage or infectivity or severe disease, etc. So, and so I won't speak over them right now. But then we never know, being a virus, when these can mutate in the future. So we need to be careful and get as much data, as much information about these variants also. Now coming to the transmission, overall, I would say for all variants, Delta, Omicron, etc. If you look at the transmissibility or transmission characteristics of SARS-CoV-2, So person-to-person spread still remains the main mode of SARS-CoV-2 transmission. It was the case 2 years back. It still remains the case 2 years back. So direct person-to-person respiratory transmission, through droplets in close range contact is the primary route of transmission. When we say close range, there have been lots of debates of what do we how do we define close range. So now WHO, to be on the safe side, defines close range as a distance of 6 feet or roughly 2 meters, right? So virus released in the respiratory secretions when a person with infection can coughs or sneezes or talks can infect another person directly if that person is within this close range. And the second is infection through fomites. That is, if a person's hands are contaminated by the secretions or by touching contaminated surface and they touch their eyes and nose, etc. So that's another way of transmission. However, what was previously thought, this is something that I'd like to reiterate, but what was previously thought that even transmission through touch is probably a major pathway of transmission. Currently, it has been shown in lab studies as well as in observation studies that transmission through touching, so as I said, common stuff such as surfaces or pens or mobiles, etc., is not a major route of transmission. There is a risk. There is a risk of transmission. However, it is not a major route of transmission. The life of virus on surfaces is much less. Even both for the Delta as well as for the Omicron variants, it's a few hours. The viability of a virus on a surface, right? So even though we still need to maintain our hand sanitization, etc., still just for our knowledge, I'd like to say that direct person-to-person transmission is still the most important route or the major route of transmission of SARS-CoV-2. Now, there have been some reports, there have been, I know, a lot of debates about airborne transmission. So can SARS-CoV-2 be transmitted or longer distances through, airborne route? In fact, last year, if you remember, 2021, 2020, there were quite a few reports and some very small lab studies which showed that airborne route is also there. But overall, if we say now with after 2 years of research and after 2 years of observation, it has been seen that SARS-CoV-2 does not have a major airborne route of transmission. Now, in very specific systems, suppose, for example, there's a closed room without ventilation, and quite a few people inside that closed room, there may be a chance that the virus, can be transmitted for more than 2-3 meters. However, such situations are rare in our daily life, and I'm not talking about just hospitals. We're talking of the general public, right? And hence, airborne transmission is, again, there is a theoretical possibility, but it is still not a major route of transmission. Now, apart from this SARS-CoV-2, the virus RNA has been detected in non-respiratory specimens also, including stool and ocular secretions, etc. But there haven't been any documented case of transmission of a COVID-19 case which has been infected by one of these rules. Now, these are all documented. These are all been speculated because RNA has been found in these specimens, stool and ocular secretions, etc. And there are some in vitro studies which have shown that it can be found in the in these non-respiratory specimens also. However, as of now, the WHO does not consider fecal-oral route or any other route apart from respiratory specimen as a route of transmission of this disease. And this is probably important for many of us clinicians, because we get asked by patients, we get asked by relatives of friends, and that they have read somewhere that fecal-oral route, it is present in stool and also can it transmit. Theoretically, yes. Of course, we all know theoretically everything is possible, but practically it's not been It's not an important fact at all. If we now talk about another question, or not just question, another important point that we all think about as clinicians is that when is the period of greatest infectiousness, right? I mean, when is a patient who has the SARS-CoV-2 virus in his or her respiratory tract, when can such a patient or such an individual start transmitting? We have to remember that the potential to transmit SARS-CoV-2 begins before the development of symptoms, right? So during the incubation period, that is when the patient has not yet started developing symptoms, but the patient has the virus in his or her respiratory tract, such individual can transmit, right? So then, I mean, this has implications because we really don't detect individuals until and unless they develop symptoms, of course, except for the contacts of known cases. But then when a patient starts developing symptoms, it means that he or she has already started transmitting the virus maybe a couple of days before symptoms. And so in that time, he or she wasn't aware that he or she has symptoms, right? But he or she has been meeting people or something. So could have this person could have spread the disease, spread the virus, not the disease, spread the virus. So this is important in terms of contact tracing. Now, I won't go into the prevention or treatment part, but I'm just saying implication for this is when contact tracing is done for COVID patients, it is contacts not only who have been in touch with the patient after development of symptoms, but also 2 to 3 days before the development of symptoms. Also, such contacts also need to be traced and tested. And overall, if we see the transmission potential is highest in the early course, early in the course of the disease, and after that, the risk of transmission decreases. Now, with Delta, transmission was usually there to about 7 to 10 days, after which it was highly unlikely. With Omicron, it has been seen that the transmission its period is much shorter. It's around 4 to 5 days. Okay. Now again, this has implications in terms of isolation of patients. I'll just quickly touch upon that. So this this period of transmissibility, which is highest in the earlier stage, have been corroborated, have been seen through studies in which viral RNA levels from the upper respiratory specimens are the highest, which have been the highest, right? And this 7 to 5 to 10 days, or 4 to 10 days transmissibility for considering all the variants has been seen in studies in China as well as in Taiwan and in the UK also. However, it is rare to find a virus 10 days after, after the infectious period. And now, and as I said, Omicron transmissibility is shorter compared to the Delta variant. So Delta was around 7 to 10 days maximum. I'm talking about Omicron about 4 to 6 days. And this has implications in terms of isolation. Hence, I mean, if you look at the WHO and Indian government guidelines, currently isolation is, if it's a Omicron case, the isolation is now recommended for about 5 to 6 days only. Whereas for Delta, as all of us know, remember, it was a 2-week isolation period if it was Delta. Now, one important aspect, this is again a query that comes up to us, to ourselves and from patients, is that in case there is a prolonged viral RNA detection, does it indicate prolonged infectiousness? Fortunately, it is no. Again, this is not very well documented as of now. There are very few preliminary studies which have shown that even though viral RNA may be detected in the nasopharynx, in the respiratory secretions for some time. In some patients, it may be there for a longer time. However, it does not necessarily mean that that person or the individual is transmitting the in the virus, transmitting the virus. So which is probably a good thing in terms of the practice, in terms of the pandemic transmissibility and spread.
Dr. Roy,
Yes.
we are coming close to the session.
Yes.
So
Yes.
perhaps please
Yes.
allow
Yes.
some
I'm
time
also.
for answering. Yeah.
Yes, I'm also almost done. Just 2 or 3 more minutes, and then I'll
Sure.
close the patients.
Sorry for interruption.
No problem. No problem. One important aspect regarding transmissibility is that it depends on quite a few factors. It depends on the exposure type. That is, first of all, is the type of variant, and Omicron is much more transmissible. Okay, as well as it depends on individual factors. That is the amount of the viral load, RNA load in respiratory secretions. Okay, and as well as the time, as I mentioned. Now, if you look at now, one important individual factor is a person who is immunocompromised. Okay, for whatever reasons, say diabetes, comorbidity, or old age, or whatever, or some other chronic illness, will probably have or harbor a much higher load of the virus in his or her respiratory secretions, and thus can potentially have a higher transmissibility rate as compared to a person who is immunocompetent, right? Thus, risk of transmission is not the same for everywhere, or for all people. It depends on the virus, the type of virus. It depends on the amount. It depends on the person's characteristics, the health of the individual, and hence transmissibility may differ from person to person. I mean, it's difficult to put 15. You have put a figure. So Omicron is say 15% chance of transmissible, or Delta is 10. It's very difficult, and hence you will see there are always ranges of transmissibility, and hence and one thing to probably to remember is that these are probably good for in research purposes, for a public health response purpose. As far as clinical practice is concerned, I don't think having these ranges really help in determining. As far as clinical practice is concerned, it's best to follow the protocols, the diagnostic algorithms, the treatment protocols that are there as per the one individual patient's profile. This is finally, I just wanted to speak about just the fact that any SARS-CoV-2 variant, be it Omicron or be it Delta, does trigger both types of immunological response in our body, both humoral as well as cell-mediated. I mean, you've probably known over the last 2 years there's been a lot of studies, lot of surveillance, serosurveillance done, which talks only primarily about antibodies, or basically about humoral antibodies. You have IgG, IgM antibodies. We talk about neutralizing antibodies, which are important. Neutralizing antibodies are important in mitigating the disease, in reducing the disease severity of the disease in an individual, as well as for having memory. So immune memory is also primarily due to the duration of neutralizing antibodies. However, cell-mediated immunity, which unfortunately has not been studied so extensively in SARS-CoV-2, probably has an equally important role. As I say probably, because as of now, we really don't have much idea. It probably has a more important role in maintaining a duration of protection or memory. So certain CD cells, CD4, CD8 cells, and they probably continue to carry this immune memory against SARS-CoV-2. This, and which probably helps in reducing the risk of reinfection. I won't say it prevents reinfection completely, because reinfection would again depend on a lot of other factors, but it does help in cell-mediated immunity, does help in reducing the risk of reinfection. So and unfortunately with Omicron, as I said some time back, reinfection rate is a little higher as compared to Delta, for whatever reasons. Again, it's not very well known. It's just been observed till now in studies from UK and studies from Denmark, etc. And even from clinical practice in India also, we'll probably see. Unfortunately, reinfection rates are higher in Omicron, but fortunately, again, reinfection is not as severe or as Delta, right? So these were just some of the, I mean, of course, epidemiological, I can say, points or factors that I just wanted to touch upon. I just wanted to give some talk about some updates regarding these epidemiological factors. I mean, of course, if we talk about complete epidemiology, it's a big topic, as all of you would probably appreciate. It's a huge topic. It probably will take a day or two, but I suppose looking, I mean, as far as myths of COVID or questions or false perceptions regarding COVID, SARS-CoV-2, especially with Omicron coming in, are concerned, I think it was probably, I thought these were some of the points that we could touch upon just to set, at the beginning, to set the discussion for all the subsequent sessions that we will have over the rest of the day. So here I will stop, sir, and I'll let the organizers please take over.
Sure. Thank you. Thank you very much, Dr. Roy, for elaborate presentation and also clarifying on some of the myths. This is a very important session. Before going to few questions which participants have posed, I will ask my co-chair, Dr. Mundada, to have his comment. Dr. Mundada, please. And then we go to questions for Dr. Roy.
Thank you, Dr. Sudipto. Nice lecture. I just wish to ask certain questions to you, because you are as part of ICMR and perhaps decision-making or policy-making person there. So when somebody is tested positive, what would be the exit strategies? Meaning, should he be tested again after 7 days when he wishes to join duty or wishes to travel? Because there are many organizations who wish that these persons should have a negative report, but there are also guidelines that testing should not be done when a person is recovering or after 7 days of infection. So what would be your opinion on this?
So as of now, yeah, I think that's thanks. This is a question that many of us probably get asked. So as of now, there is no need of repeat testing to confirm recovery from illness. It is the recovery. I mean, recovery from illness is purely a clinical decision, is based on clinical factors, signs and symptoms. For routine, use, it is not recommended retesting, say after 7 days or 10 days. However, as you mentioned, some of these, especially the travel agencies, maybe if a person is traveling somewhere, airports or something, they may require. I mean, they may have their own policies. So for that, the patient will probably have to retest, but. In principle, there is no need for retesting to confirm recovery. Recovery is still, I mean, which was, I think, if I remember correctly, even towards the end of the Delta wave, also there was this need for recovery testing to confirm recovery was removed, and it's still the same even now. So in principle, there is no need to test for confirm recovery.
So you would say a person would be non-infective 7 days after he is tested positive, irrespective of the fact that whether we have tested him or not.
Yes. So most likely, again, it's most likely if the person continues, say for example, I'm just giving an example, say an immunocompromised person continues to exhibit symptoms, then that person still needs to be kept in isolation and treated. But for majority of the people, it has been seen that 5 to 7 days is good enough for recovery in this current way, we can say, in the last couple of months, and there is no need for retesting after or post that.
Thank you. There are some questions in the question answer box
Yes.
also. Maybe my co-chair would like to, should we ask those questions or?
Yeah, we can take the questions, Dr. Roy. We have questions in the chat box asked by the participants. So I have 3 questions which are related to the same part, so I can take up those. The question is the current wave due to Omicron variant? Can you give some more information about B2 variant? And also, can you shed some light on Neocov, the virus which has been detected, and is Chinese scientists have shown some concern that this may come to humans and may infect humans as well. These are 3 questions related to Omicron.
Right. Okay. So firstly, Neocov is something which is very, very new. I mean, I think we just read about it. I mean, we also read about it a couple, 3 or 4 days back, that there's a new variant known as Neocov. So again, I mean, so firstly, we don't have any data about this as of now. I think it was reported again by the China scientists from China, if if I remember correctly. So in India, there is no evidence of any such Neocov or such variant. But again, I mean, as I said some time back, that we need to remember that this is a virus. This will have this will keep on mutating. This will have variants, over the next few years. Also, this SARS-CoV-2 will continue to have variants. Whether it is clinically significant or not is what we should be worried about, or we should think about, right? So as of now, there is nothing about Neocov data at all as far as India is concerned. I think there's a question that, is there any chance that COVID-19 virus is exhibiting varying pattern of endemicity during third wave? It's too early to say whether it is becoming endemic, whether it is still it's an epidemic or not. It's too early. Why I say it's too early? Because many parts of India, the number of cases, if you see, it's still rising. Some parts of India, especially bigger cities such as Delhi and Bombay and Mumbai, the increase has kind of stabilized. There's no decrease, but increase has stabilized. But in many other parts of India, we are seeing increasing cases. So we cannot say anything about endemicity right now as far as India is concerned. I know that the UK and many countries, in especially Western Europe, are thinking of declaring it as an endemic disease. But again, we need good, high quality, real time data, to be able to go to that stage. So as of now, we are still seeing a significant number of cases of COVID-19 in India, if we're talking of India, and that is what we should be, concerned about. This is that's how our response should be.
Sure.
Yeah. So quickly, I think any study about B2, I don't think I have not come across any study about B2 variant. And so, what was another question that you just mentioned?
Is this current wave due to Omicron, which obviously it is. The last question, which is coming up again about ICMR guidelines for isolation of Omicron when there is no diagnosis of Omicron. Because Omicron diagnosis may require genomics, you don't have genomics, and what do you do for how long you keep the patient? And I think you have answered part of that question. For the normal, it is the clinical judgment, and for the immunocompromised, you can keep it a little longer. I just would like to clarify something on the Neocov. As you know, that Neocov is not a part or variant of the current SARS-CoV-2 virus. As you know that scientists all over the globe try to discover new viruses, particularly in bats. And even in India, National Institute of Virology, which is my alma mater, is also discovering new viruses in the bats. So this Neocov virus has been detected in bat. It has nothing to do with SARS-CoV-2 as on today. It has not been detected in humans. So the concern is that, yeah, okay, the new virus is detected and we need to keep a watch and we need to do certain studies to see whether there is any threat of spilling it over to humans. And as you know, there are many bat viruses, particularly from coronaviruses, which are still in bats and not spilled over to humans. So of course, it is too early, and this also demonstrates the power of social media and the spread of information that this news was just out there in 2 or 3 days, and there are not a lot of information out there. Dr. Roy, I have one particular question to you.
Yeah.
We've been even from WHO, ICMR, and all the agencies are coming up with a number of cases, the numbers that how many cases have been detected on day-to-day basis. Is it not the time to move from number of cases to maybe a number of hospitalization or number of death as an indicator to monitor this pandemic in a given setting?
Right. So actually, number of cases, what you see is rightly, as you rightly said, is what is being published daily, I mean, by the WHO, by the government of India. However, ICMR does collect data on hospitalizations and deaths and severe disease also, which is not published, which is not in public domain as of now. But ICMR and the ministry is collecting. There are registries, there are clinical registries which collecting data on a regular basis. But yes, I mean, in principle, I mean, if I say personally, I think all these three parameters are important. As far as the government decisions or guidelines are concerned, they are based on all of these parameters. Also, along with rate of vaccinations, So these 4-5 parameters are considered data. So data is considered by the government in when they release the regular guidelines, for isolation and treatment guidelines and etc. The only thing is the number of tests and cases being published is in a public domain. But yes, rest all data is being considered actively.
Yeah, sure. Thank you very much. Thank you very much.
Sorry, just
Yeah.
if you can give me just a minute, I'd just like to project this a home isolation guideline which was issued by ICMR in 5th of January. I'll just put it up on my screen for a minute. So if you see, it's not 5 and 7 days. So home isolation guidelines say that asymptomatic contacts to home quarantine for 7 days. And the symptomatic individuals will end home isolation after at least 7 days from testing positive. Now, this guideline is available on the ICMR website. Anyone can please visit the website and download, and it's been translated into 3 or 4 languages. There are plans to translate this into other regional languages also. So this is something you can refer to. This can be directly given to hospitals or even patients. If you want to give it, you can give it to them. So this is there on the ICMR website.
Sure.
I just wanted
Thank you
to
very
share
much.
this.
Yeah, absolutely. Thank you very much for pointing this out, and thanks very much for a very elaborate presentation and taking up a few questions from the participants. I do have a few questions related to vaccines, but I think it probably would be appropriate to take up those questions in the vaccine session late in the afternoon. So thank you very much, Dr. Roy, and thanks my co-chair, Dr. Mundara, for this session. And I hand over back to the organization for the next session. Thank you.
Thank you, Dr. Roy, for simplifying such complicated topic for us and explaining the differences between epidemiology of Alpha, Delta, and Omicron variant. And thank you, Chairperson, for carrying out this question and answer session and clarify our many doubts. Now we will proceed to our second lecture. Our guest speaker is Dr. Pradyot Garge sir on D-dimer dilemma. Dr. Garge sir is a practicing pathologist and histopathologist at Apollo since 28 years. He has done research project at Meghat Bill Gates Foundation and recently published journal at Endourology. I again hand over the mic to the chairperson, Dr. Shailendra Mundra sir and Dr. P.S. Aher sir. Dr. Ahir sir is also a practicing pathologist. He is the senior most pathologist at Akola, practicing since more than 30 years. So thank you, sir. I request chairperson to carry out the further session.
Yeah, I would like to welcome Dr. Garge. Dr. Garge has been a colleague at GMC Nagpur, and he is a very popular figure in Akola, not only in Akola, but in entire Vidarbha. And yes, D-dimer, the topic he chose, perhaps has created a lot of dilemma, how it should be interpreted, and how treatment guidelines should be based on the results that we give from pathology labs on D-dimer. So I would like to welcome Dr. Garge and speak and guide us and tell us about his experience on D-dimer test. My co-chair, if he would like to say something, Dr. Ahir, please.
Shailesh, am I audible?
Yes, you are audible, Dr. Garge. You can continue. You can start.
Okay. Thank you. Thank you, Shailesh. Good morning, everyone. At the outset, I would like to thank our President, Dr. Ajay Jhunjhunwala, for giving me the opportunity, and to Dr. Satish Jethwani for making it a reality. Today's topic I had chosen is a very simple test and with very simple interpretation. But unfortunately, during this COVID-19 pandemic, the test is something misused as far as my opinion. I will discuss all these things. Rather, it's not a lecture. It's my story or a journey. Since last 1.5 years, I'm discussing this issue with different authorities at national and international levels. So in the beginning, I would like to give a special thanks to my friend, Dr. Pawan Sharma, who is a pediatrician at UK. And my son, Pramya, he has prepared this presentation. My presentation is very simple. As I have told you that it is a very simple test with simple interpretation. So the purpose of today's talk is to discuss the issue of use of elevated D-dimers values in the management of COVID-19 patients. Intentionally, discussion about the anticoagulant drug therapy is not addressed in today's presentation. I have mainly concentrated on the D-dimer test, its interpretation, use, and limitations pertaining to the COVID-19 management. Intentionally, I have focused a single test, not other pathological tests, in today's lecture to bring your attention to this issue. So, what is the usefulness of D-dimer test in COVID-19 patient management? Whether it's a diagnostic test, or it's a prognostic, or it's a something rule-out test, or it's of no use, we will discuss and we will come to the conclusion at the end of the lecture. So this is the roadmap. Initially, I will discuss something about the D-dimer test. I will give information about the D-dimer test. Later on, the second part, I will discuss the communications with the authorities. The main is the editorial board of Journal of American College of Cardiology, and the author. I have focused on these particular things because that was the first article we appeared and which caused the this spread of word I'm using, D-dimer test all over the world. So later on I will give some evidences in favor of less usefulness of D-dimer test. I will point out some ground realities, and at the last we will reach to the conclusion. I'm sure at the end of my talk, most of the ideas regarding the D-dimers will be clear. I will try my best. So we start with the D-dimer. D-dimer is a plasma protein formed after the fibrinolysis. It is endogenously present in the blood, metabolized in liver and spleen, and cleared through the kidneys. Here it is important. So anything which is something wrong with the liver or spleen or even kidneys, they interfere with the D-dimer levels. It increases with the age. That the values, they are age-associated, it is called as age-associated D-dimer levels. This is peculiarity of this particular formula. It is applicable from the age of 50 to till 80. Before 50, it is not applicable. The formula is very simple. Your age multiplied by 10 will be the normal, upper normal reference range of your D-dimer levels. I'm talking in unit of milligram per liter. So if your age is 56 years, 560 is the normal range for you. Another important thing, this is a non-specific test. Remember, this is a non-specific test. I repeat, this is a non-specific test with high negative predictive value. The meaning of high negative predictive value means if it is normal, it rules out. That is negative predictive. It cannot predict something. It rules out something. So if it normal D-dimer test rules out DVT, PV or pulmonary embolism, and it is adjunction test in the DIC, but not routinely used. There are some other issues related with the units, methods, and what are the normal range if the patient is below 50 years or some above 80 years. Another point we should know that there is no normal reference range I have seen in the pediatric age group since last 1.5 years through either in WHO guidelines or in the ASH guidelines. There is no normal reference range mentioned. So we'll turn to the D-dimer itself. Increased D-dimer is associated with multiple conditions, including non-thrombotic situations such as hospitalized patient after surgical procedures, pregnancy, inflammation, malignancy, trauma, and all these things. There are things. There is another list of conditions which in which the D-dimer is raised. The point I want to show, but none of these conditions are monitored or treated by D-dimer levels. Try to understand one thing: D-dimer raised in nephrotic syndrome, D-dimer raised in myocardial infarction, but these conditions are not monitored or treated by D-dimer levels. So D-dimer level is never used as a prognostic indicator for these conditions. Oh, you have myocardial infarction and your D-dimer is raised, the outcome is bad. You cannot say like that. Then why this particular test is being used in the COVID-19 patients? And this was the questions which appeared in my brain while when I got the message that D-dimer is advised by task force members. So the D-dimer, now this is from the Harrison textbook. What is written? It is D-dimer has rarely any value in hospitalized patients. It is written that it's a normal D-dimer test is useful rule out test. It rules out something. It cannot diagnose anything. This is from the Harrison textbook. Increased D-dimer level does not confirm the diagnosis of pulmonary embolism DVT in COVID-19 patient because the elevated D-dimers may result from COVID-19 infection and other causes. Other causes, even other outer lung injuries such as ventilator-induced lung injuries or ARDS have a very high D-dimer and fibrinogen levels, but independent of presence or absence of VTE. Increased D-dimer value does not indicate severity of the disease. This is most important thing to remember. Increased D-dimer value does not indicate severity of the disease. This is from the Mayo Clinic laboratory reference. Even today, you can go to the site of Mayo Clinic laboratory and you can read this, that the increased D-dimer value does not indicate severity of the disease. Negative D-dimer is, the D-dimer negative, unlikely thrombus is present. Raised D-dimer, no prediction about the presence or absence of thrombus. So it is hazardous to change the anticoagulant dose depending on the values of the D-dimer. Elevated D-dimer indicates endogenous, although clinically non-effective thrombolysis. So anticoagulant therapy cannot be given depending upon these values because it is indigenously present. So negative and normal D-dimer test rules out pulmonary embolism or DVT, and this is where the test ends. This point is also important to remember. The negative normal D-dimer test rules out PV or DVT. The test is like this much only. ऐसा समझना कि अपन VT स्टेशन पे पहुंचे, उसके आगे अपने को यदि कहीं जाना है तो we cannot go by the same train. Unfortunately, the extrapolation of the test is done knowingly or unknowingly and interpreted as follow. If the results are normal in the normal reference range, the test is negative or normal. If the results are above the normal range, it is positive or abnormal. Here I take objection to the words to the positive and abnormal. It is a misinterpretation of the test. You can take normal or raise. It is not normal or abnormal. Okay. If raise levels are obtained, the test becomes insignificant. Here I will like to, how the extrapolation of the test is done. I will quote some my experience. A few years ago, I was in the external quality control program of microbiology from a reputed institute, and I got a slide for reporting a gram stain. I identified the organism and reported it, but out of 4, they have given me the only 2 marks. Then I contacted them. Why there is a reduction in my marks? They said on that slide you have not mentioned something. What is in the background are the RBCs and the WBCs. The test basically gram stain is meant for whether the organism is present or absent. If it is present, it is gram positive or gram negative. That test ends here. So I told them, you cannot extrapolate the test, gram test like this. I can even write down no malignant cells are seen. Is it advisable? So same thing is happening with this particular test. D-dimer is raised in pregnancy first. There is physiological rise in first, second, and third trimester. It is at the peak, at the term, the values goes up to something around the 4,000. And there is another peculiarity. After delivery, it goes down, and after 10 days, it again rises. So this is a hyperthrombotic phase, but never required treatment. So kindly note the time taken. In the body, for clot formation, it requires few minutes. And for fibrinolysis, it takes few days to months. This point to be important because I have seen the patients, they were monitored by the D-dimer levels. उसको normal आने दो, फिर अपन discharge देंगे करके. So what are the recommended coagulation and platelet assays? This is from the International COVID-19 thrombosis biomarker column. These are actually anti-factor 10 assay, prothrombin time, and all these things. Actually, these tests, they are recommended for monitoring the anticoagulant therapy and not for the diagnosis of D-dimer or DVT. So tests for monitoring anticoagulant therapy are the prothrombin time, activated prothrombin time, and the platelet count. These are the simple tests. Factor 10 assay we cannot afford. We move to the second part. After knowing a little bit about the D-dimer, we move to the second part. What are the communication I have carried out? So after knowing that the test is included into the guidelines, I contacted a gentleman from the Maharashtra Medical Task Force and alerted them that this test should not be done. So they have partially accepted. They say, okay, asymptomatic and mildly symptomatic, we are deleting this test, but this test is more important in hospitalized, moderate to severely ill patients. And they are given with the reference of Journal of American College of Cardiology article. This article was written by Professor Dr. Bigdeli. He is a professor at Harvard and he is a visiting professor at Yale. This is the article which was quoted. Till today, this article is cited by nearly 2,200 in 2,200 articles. So I approach JACC editorial board and mentioning that it is something, the test is misinterpreted in this article. Initially, they rejected my claim. Later on, I put some more documentation and all these things. They accepted it. They realized the severity because I have mentioned them, because your journal is of international repute. So after 6 months, all over the world, the test will spread and you will get references mentioning that the D-dimer is more important and the most important thing. They realize it. They have given me the email address of Dr. Bigdaily, the original author. I returned to him mentioning that this is the unique test in pathology. It doesn't have any diagnostic or prognostic value. How you have mentioned in your article. The explanation given was by him was, I have suggested this D-dimer test only for the research and not as a routine test. Try to understand the meaning of this particular test sentence. Research you can do for anything. Whether I should hold mobile in my right hand or left hand, you can do research on it, but it cannot be the routine thing. I again contacted him after a gap of 6 months. What he has written, so far results have not shown a strategy based strategy help change in the management. So D-dimer based strategy doesn't help in the change in the management of the patient. This is written by the author, which cited by in 2000 nearly more than 2000 articles. 3 weeks ago, I again contacted him. What is the latest development? He said the evidence is somewhat conflicting. And later on, what he has written doesn't seems like to be written by a professor from Harvard. And it's just a play of word if you go through it. If I will just speedily read it. However, in considering the data from, it may be reasonable to check D-dimer periodically. It markedly elevated in the right setting. You may want to diagnose test for thrombosis and no particular suspicion. It may be reasonable for hospitalized floor patients who are not admitted to the ICU and do not have a high risk of bleeding. This is just play of words. I think he is kidding. So what are the evidences? We'll move to the next part. What are the evidences? The most important and most reputed is the evidence from the American Society of Hematology ASH guidelines. They published last year. They have not changed it till today. And they are clearly mentioned in their article. The AC Forum also recommend against serial monitoring of D-dimers and recommend against intensification of the anticoagulant dosing based on the D-dimer concentration. The D-dimer as a prognostic factor for thrombotic risk and mortality is not addressed in the present guidelines. These are the ASH guidelines, and ASH is such a reputed organization. It is respectable all over the world. These are the other articles which appeared, which are stating that it's a high negative predictive value. These are other guidelines which are important for the diagnosis. European Society of Guidelines for Pulmonary. These are all related guidelines. Even British Thoracic Society, they have issued guidelines last year. The important points to highlight in there is the D-dimer levels are frequently elevated in patients with COVID-19 are prognostic. Okay, they are considering as a prognostic. But another thing what they have written is important. High levels may arise as a result of thrombosis or inflammation. Thrombosis or inflammation, this is to remember. Current data do not support the routine use of high D-dimer levels in isolation to guide decision regarding the investigation, and the anticoagulation levels should be assessed within the overall clinical context. This is also important. This is shared by my friend, Dr. Abhay. Now, what the textbook are saying? Okay, I already mentioned that the Harrison textbook, it is written that a normal D-dimer is useful rule out test, and the D-dimer rarely has any useful role among the hospitalized patient. Here, point to remember is that Dr. Fauci is one of the editor of this article. His name is appearing on the screen. This is hers is the Bible for cardiologists. It also says the same thing. A negative predictive value of a D-dimer is remain high in these situations. So all these textbooks, they are highlighting that it is a test of negative predictive value. This is another textbook, which is 1,600 pages. And what they have mentioned, negative, highly sensitive D-dimer assays rule out DVT and pulmonary embolism in outpatients with low or intermediate probability of VT. And last, they have finally, D-dimer is unlikely to be useful in very elderly patient or in hospitalized patient with suspected VT. in hospitalized patient with suspected VTE. This is point we should remember. So what are the ground realities? Now we come to the ground. Okay, the authorities, they give the guidelines, and what actually happens on the ground, I will just tell you. 85% of COVID-19 patients are asymptomatic. 10% are mildly symptomatic, 5% are moderate to severely. But only for this 5% of the so-called moderate to severely ill patients, remaining 95% were charged for doing D-dimer test. What is the national loss? Why the simple test with simple interpretation, and why I'm taking this issue? Considering the total number of cases, 3.5 crores, I have intentionally updated this on 17th of December, not updated for today because of the Omicron. So if you test, only 10% are tested once. Considering at that time the 3.5 crores, 3.4 crores were affected. So if 10% are tested once, the cost is 340 crores. If twice, 10% tested twice is 680 crores. And if the 20% are tested, 1,360 crores was the cost. Please note that kits are not manufactured in India. It's a national loss. And the doctors of all patches are prescribing this test. Actually, I am prepared this presentation at the peak of second wave. The fact remains the same. Another problem with the interpretation of this test is that the patients were raised D-dimer were hospitalized, so their hospital beds and other resources were unnecessarily occupied because of this particular test. If you consider financial losses at personal level, one hospitalization is 1 lakh rupees approximately. And the unfortunate thing is that some hospitals, they use D-dimer levels as a criteria for discharge. My close friend is a journalist at Bombay. He was discharged 8 days later because his D-dimer levels were not coming to the normal. So calculate the financial burden along with the psychological trauma at the time of pandemic. Another ground reality, this is the prescription. 19 drugs are returned and the patient is admitted because it has a raised D-dimer. A person who cannot write the spelling of D-dimer or a platelet has advising people get the D-dimer test done. All these are the ground realities. And another fact I want to point it out, it is the most advanced nation in the world and the largest number of COVID-19 patients, largest number of hospital beds, and most advanced data collection system and data analysis system, that is USA. What they have written. These are the NIH treatment guidelines published last year. And I'm just highlighting what are the important points. But they are written in non-hospitalized patients, no data to support. In hospitalized patient, currently insufficient data to recommend either for or against using this data to guide management decisions. In VT screening, currently insufficient data. After 3.5 crores persons were affected in US. Still the NIH guidelines, they are saying that they have no data to support or currently insufficient data to support. I was a little bit surprised. These are for the first time I have seen such guidelines that actually the guidelines means what to do or what not to do. But they have mentioned like this, no data to support. And these guidelines, they were nearly for last week of December, and they were using these guidelines. They are currently in the first week of Jan. They are currently with another guidelines. I have gone through it, but they are they're more confusing and non-conclusive. So we reach to the conclusion. So it is time for us to revisit and rethink. We should not forget the hypocrites. First, we should not harm. We should not harm patients because of these things. And in the era of evidence-based medicine, with the wrong data, we should not treat the patient. And another thing is that we have changed our policies so many times regarding such as coalescence plasma or remdesivir use. So we can change our policy. So at the conclusion, say whether this test is a diagnostic, I don't think so. It's a rule out test. This is, I'm telling we are discussing about the increased D-dimer. So it is not discussed here. Prognostic, we have seen guidelines, even what Ash has mentioned. So if you draw the conclusion, all these things are not used. So as far as my opinion goes and what the literature says, D-dimer is not of much utility in COVID-19 management. Here I want to say one thing, the popular beliefs are not always correct. What you require is the courage and mindset to fight against them. So take home message, a D-dimer level is a high negative value test. It should not be used for diagnosis, prognosis, or determining the treatment management of the COVID-19 patients. Considering all these factors, it's my humble request to you, please think over it and omit this test from the COVID-19 treatment management protocols. Thank you for the patience listening.
Thank you, Dr. Garge. Excellent talk. I couldn't have agreed with you more. I remember during the second pandemic, we were short of kits and machines that were doing D-dimer tests. And I would like to add that if we wish to fight a system, maybe we can have Dr. Garge as our leader there whenever there's something wrong with the system in which we work. One more other test I would also like to mention is the IL-6 test. That was also perhaps so much used with very little utility. Dr. Garge, what would be the ideal test, a prescription, pathology lab prescription that you would recommend for a COVID positive patient? Just a bare minimum, just CBC, CRP, what all few things that you would like a patient to get done?
Actually, last week I was RT-PCR positive. So I had done my CBC, serum create, and CRP. And just for academic interest, ferritin and LDH, but I was not, even I have not seen my reports regarding the ferritin and LDH. Basically, all the thing what went wrong was, instead of doing research on these predictive indicators from triglycerides and CRP, ESR, and all these things, directly these were launched in the public domain for doing the test. That was the problem, why we are getting number of tests and not a single conclusive test.
I wouldn't agree more. Even I was tested positive a week ago. I did not do any pathology tests at all, like not even CBC.
I was asked by my physician, yaar, CBC to kar le bole yaar, okay.
But yeah, as far as prescription would go, I would suggest that CBC and CRB should be bare minimum initially. But beyond that, it would be only in certain patients that you would require the other tests. Dr. Hay, would you like to comment something, please?
A wonderful talk, Pradyot. And you have wonderfully pointed out the utility of this test for the clinician as well as for the patient from the prognostic diagnostic point of view. I would just like to add a little humor to the discussion, in the sense that we are called upon to do D-dimer at 3 o'clock in the morning, 2 o'clock in the morning, 4 o'clock in the morning, because the clinician feels that the D-dimer test is so very important in diagnosing COVID-19. So if we take Dr. Garge's advice in its proper spirit, then doing unnecessary D-dimer testing at ungodly hours should be stopped as far as the technicians are concerned. And the best thing that Dr. Garge has pointed out is the high negative predictive value of this test. These are the 4 words which every clinician should keep in mind. I would say that it is not even as useful as an ESR. At least ESR has got a prognostic value. D-dimer doesn't have even a prognostic value. So this test maybe, if at all, if it is done, it can be done once or twice during the patient's illness, especially when the patient is admitted. For OPD patients, doing a D-dimer or ferritin or IL-6, I personally feel is of no value. So if the patient doesn't have very serious symptoms and the patient doesn't require any admission, then the exotic test should not be done. I really agree with Dr. Garge in whatever he has said. Thank you very much.
Thank you, sir.
There are some questions in the question box. One I would particularly like to mention is from Dr. Satha. He wishes to add that what is the role of blood sugar? Meaning, he wants to say that blood sugar should be done in patients with COVID. Your take on this, Dr. Garge?
These are the routine tests, basically. It's not pertaining to the COVID also. But the treatment modality is if the due course of time the patient is getting steroid and all these things. Or for knowing a baseline, we should do a blood sugar test. That's a routine test.
Yeah. So I think there are no more questions here in the question box. Excellent talk. I think people would not request unnecessary tests at the end of this talk. Thank you, Dr. Garge, once again.
Thank you.
Thank you very much.
Thank you, Dr. Garge, sir, for enlightening our knowledge about relevance of D-dimer test in diagnosis and as well as prognosis of in COVID patients. Now I thank you, Chairperson, for your valuable comments. Now we will proceed to our next lecture by Dr. Anita Matthew ma'am regarding COVID disease investigation phase versus clinical base. Dr. Matthew ma'am is a consultant in medicine and infectious diseases at Fortis Hospital, Mumbai. She has completed her training in internal medicine and infectious diseases from GS Medical College and KM Hospital in 2002. And she has written some chapters in books, also published couple of publications in peer-reviewed journals. Now I hand over the mic to Chairperson, Dr. Ashok Agrawal, sir, and Dr. Deepak Lote, sir. Dr. Ashok Agrawal, sir, and Dr. Deepak Lote, sir, both are the practicing physician at Akola since many years, more than 30 years. And they have done immense work in managing COVID patients, even critically ill patients during this pandemic, and help the society. So I request Chairperson to carry it out further session. Agrawal, sir.
He's on mute.
Agrawal, sir, please unmute yourself. We will wait 1 minute for Dr. Agrawal, sir.
Dr. Agrawal, please unmute.
Hello. Are we audible?
Sir, please disconnect the other device.
I think there is some problem with our connectivity.
So please disconnect the other device.
Hello.
Sir, disconnect the other device.
Yeah, hello. Are we audible now?
When
Hello.
you're audible, please remove the other device from Zoom.
Hello.
Yes, sir. we can-
Are we audible?
Yes, sir.
Yeah. Yeah, we have just seen that two tests have not been found to be clinically correlated. So it's very likely that clinical management is very different from the test we do. In fact, which test we should do and which we should not do at all. So today we have Madam Anita with us to highlight the clinical correlation and the lab tests that are to be done. So we hand over the mic straight of to carry her.
Good morning, everyone. Thank you, Agrawal sir, for the kind introduction. Would like to thank the organizers for giving me this opportunity. Can I share my screen?
Yes, ma'am. You can. Go ahead.
Is it visible?
No, ma'am.
Okay, just a minute.
It's visible now.
It's visible? Yeah. Thank you. Yeah, so the topic that I would be discussing and which was given to me is regarding the clinical and the investigational basis in terms of management of patients with COVID. We all are aware of the fact that this particular virus is capable of causing symptoms which are beyond the respiratory system, in addition to cause complications in the form of inflammatory nature in various organs, which actually gives it a huge range of clinical manifestation. There are various variants of concern which have already been denoted and been there in the circulation, the latest in the line being Omicron. Coming to the clinical features, I'm going to be talking in terms of the roadmap is going to be talking about clinical features vis-a-vis the lab features and what is the correlation between the two and what is the best practice ahead. This is the way the roadmap for my talk is going to be. Coming to the clinical features, I've actually grouped them into two categories. So if you see the first part of it, it's fever, cold, cough, sore throat, runny nose, which are common in both the variants. I'm talking about going to be talking between the two variants that we have seen, the major ones between the two waves, one being in the April of last year and one being in December of last year. So if you look at the first 4 or 5 symptoms, they were more or less common in both the waves. But the breathlessness and the sense of loss of smell and taste was something which was more peculiar to the variant, which was Delta, as against the Omicron, which is what we are seeing currently. In terms of fatigue, backache, joint pains, severe headache, which is typically talked about by the patients in this particular Omicron variant, they have been the most common presentation with the patients that we are seeing this time around. GI symptoms were seen in in all the three waves, but it is more predominant now that we are seeing in the third wave as against the previous ones. We were seeing a lot of hyperglycemia in Delta, probably also maybe because of the use of steroids, but patients also used to come with us with the hyperglycemic symptoms. This may be anecdotal, which is what is my personal experience, but we have been seeing a lot of patients coming into the ER with hypoglycemia, and then we pick them up as incidental COVID positives. So hypoglycemia was one predominant symptom that we have seen in this time around. CNS symptoms, of course, have always been the case right from all the three waves. We have seen that patients have been presenting with either a TIA or a stroke, or I have not mentioned here, but yes, cardiovascular manifestations as in the form of either an acute coronary syndrome. All of these can be a part of the COVID presentation, but predominantly in the present wave, which is what I'm going to be really stressing on, we are seeing your upper respiratory symptoms along with immense fatigue, backache, joint pains, and headache as being one of the predominant symptoms. We are not seeing majorly patients presenting with lower respiratory tract infection kind of scenario. So those were coming into terms of the features that we spoke about. In terms of progression of the disease, fortunately for us, majority of the patients with Omicron, though they start off with a flash in the form of very high grade fever, which could be lasting anywhere between 3 to 5 days. In a younger individual, we land up typically seeing the fever lasting for about 3 odd days, and it could max extend about 5 to 6 days. Generally, beyond that, the patient would have fatigue, but nothing more than that. As against in the Delta wave, we were seeing patients starting off with not a very high grade fever, moderate to low grade fever, and the fever would then step up in the second week, which is your typical feature of what you would get with an inflammatory or the immune system responsive phase. In terms of labs, we were pretty not so judicious, I would say, in the first two waves. We probably were not aware of the implications of the test that we were doing, and we were getting carried away with a lot of investigations. So there was a lot of investigations which were done in the first two waves, as against the present wave, where we are actually judiciously using most of the investigations here, and the labs are actually playing a lesser role as against the previous two waves. As I said, it could be because we are a little more smarter now as compared to what we were in the first two waves. So if I have to look at a clinical scenario, what is it that I'm going to look at and say that this particular patient has COVID? Now, there is nothing in COVID symptomatology which is pathognomonic and which can say that this is the reason why it would be COVID, except for the loss of sense of smell and taste, where you could pick up and say that, yes, probably this guy is going to be COVID. There's no other symptom which will really give you an idea. It is almost like any other influenza-like illness or any other viral illness. In fact, so much so that the headaches and the high-grade fever without any other symptoms were so commonly seen in this particular variant that we actually used to test for dengue as well. So having to say that, it is like any other viral infection this time around. But if you look at the epidemiology, if you look at the scenario that we are in, we are right smack in the middle of a pandemic. You're going to assume that whatever fevers that you're going to get in are most likely to be COVID, and you need to rule out the other illnesses. So you obviously need a lateral flow test or an RT-PCR to be able to come to the diagnosis of COVID here. Besides that, we also used to stratify the patients according to the risk to decide whether the patient needs to undergo any investigation or whether the patient needs to be given any treatment at all. So one of the major considerations for us obviously has been the age of the patient. We have enough data to show that patients above the age of 50 and older have a higher association with increased risk of progression of the disease. So anyone above that particular age group used to be one of our red flags for us, and we used to try and monitor these patients a little more closely, even if we were doing a home quarantine kind of a consultation for the same. Now, age has been shown as one of the major indicators for the severity of the disease. The symptoms of fever and fatigue, if they come in and they are very predominant in the patient, is another way ahead to say that their patients might progress. Patients with a the complaints of severe obtundation or generalized weakness were the ones who typically were seen to be worse off. And in terms of gender, male gender were the ones who were more severely ill as compared to the females. When I'm talking in terms of comorbidity, hypertension, diabetes, all these are comorbid states, but uncontrolled hypertension, uncontrolled diabetes, patients who were immunocompromised, be it because of autoimmune status, post-transplant, or patients of HIV AIDS, or ones who are on immunosuppressants, all of these were again the red flags for us to really go and monitor them more closely. Symptomatology, as we already spoke about earlier, there are certain symptoms which made us to be at a higher index of suspicion that these patients could progress. We still continue to do our walk test in patients, asking the ones who were above the age of 60 to curtail it to 3 minutes as against the 6 minutes, and the rest for 6 minutes, less than 60 for 6 minutes. The vaccination status was important as against the first two waves, because this time around patients were vaccinated. So the vaccinated patients, we would have again some amount of clarity, considering the fact that vaccines have been able to curtail the severity of the disease. We were a little hopeful that these patients would not really go in the direction that we wouldn't want them to. And the past history of COVID also had some bearing. Of course, the fact that you have had COVID in the past doesn't necessarily prevent you from landing up with COVID infection again. We all know that. But having said that, the patients who have had a past COVID probably were a little more better off than the ones who have never had it earlier. So these were the things that we would look at when we were stratifying the patients, considering what and which patients to admit as against which ones could go in for a home quarantine. The diagnosis of COVID here, we need to understand, is definitely based on the clinical and the epidemiological history. You need a test for the etiological diagnosis. You can't empirically start treating a patient for COVID with an assumption that he is one. You need to have a RAT or an RT-PCR positivity. And once you know that this is what the patient is basically having, then you need to look at if there is any complication, and you need to be watchful for the same. Not every patient, like all the previous speakers have spoken, really need to go ahead and start investigating all the patients that really come to you. So the need for investigation is basically because the heterogeneity of the clinical presentation from asymptomatic to severely symptomatic is so vast that the relevant diversity is also seen so much more, that complementary tests need to be done, which need to have a good specificity and sensitivity as well. You can't randomly start doing tests just because they are available with you. So what are the two tests that you're going to really look at? We look at radiological and you look at lab. Now, radiological, we have your X-rays, you have your CAT scans, and we have your sonographies. Now, we generally do not do any of this in patients who are not hospitalized. For the patients wherein the fever continues beyond the first 7 days of, from the onset of symptom, these are the patients that we go ahead and get a scan done, a CT scan done, if there is an indication for the same. Otherwise, none of these patients who are managed on OPD basis undergo any kind of scans, be it a sonography, be it a CAT scan, or be it a X-ray. Now, obviously, we all are aware of the fact that the radio diagnosis is one of the ways in which you could confirm and look at the clinical picture of the patient. But as we reiterated earlier in the part of my talk, Omicron is more of an upper respiratory illness. So the chances of the patient having a lower respiratory involvement is actually lower as compared to the previous two waves. So getting a test done unnecessarily in the form of a CT scan here is just not advisable. So we do it only if there's an absolute indication. And it obviously would show presence of GGOs. X-rays, in fact, are lesser sensitive. They are done routinely only in patients who are critically ill and who are requiring ventilatory support or some kind of an oxygen-related support. We really do not do it in others. A CT scan has a better sensitivity, but moving a patient who's critically ill from a center which doesn't have a CT scan within its premises to some other place is not the best modality. Here, one can actually look at doing a pulmonary ultrasound, which is what we used to do for our patients in the hospital in the ICU setup. It's got good sensitivity. Typical findings of B-line and consolidation, pleural thickening can be easily picked up. It's got lower cost, absence of radiation, and the fact that you do not really need to sedate the patients who are really critically ill and the ones who require transportation, probably, and if they are unstable, that can be curtailed quite a bit if you tend to do a pulmonary ultrasound. Having said that, as I said, we hardly land up doing any of this right now unless and until the patients are requiring oxygen support or they are still continuing to run fever despite 7 days from the first day of onset of symptom. The most common test that we'll end up doing in our patients, if at all we are screening them and if we are even admitting them, is obviously your complete blood count. That's something that we have been doing for almost all our patients. These are the patients, we normally see the neutrophil, the eosinophil, the monocyte, the basophils, and the total WBC counts. Neutrophils typically are seen to be higher and with an absolute neutrophilia in patients who are critically ill and the ones who are in the ICU. You typically would see these patients having neutrophilia. Eosinophils, monocytes, and basophils, these are all seen to be on the lower side. And they correlate to some extent in terms of the disease prognosis as well. What I've mentioned here, eosinophil-derived neurotoxin, we really don't do any of these on routine basis. I've mentioned this here because these are one of the modalities for research. Platelets, both thrombocytopenia and thrombocytosis have been observed. However, severe thrombocytopenia is one of the factors which is important because it tells you that the disease is probably more severe. Bleeding, though, in these patients are pretty uncommon. Presence of a lymphopenia, a eosinopenia, and a neutrophil lymphocyte ratios of more than 3.13 is by itself a indicator for greater severity and a worse prognosis in these patients. So, as I said, CBC is one of the best tests that can be done and the cheapest and the easiest available one, which will give you a fair hang of how the disease progress might turn out to be. Thrombocytopenia, again, is having a higher risk of myocardial damage and a worse prognosis. Lymphopenia is actually multifactorial, and it is because of the cytopathic effect of the virus itself, an induction of the apoptosis, and an IL-1 mediated pyroptosis and a bone marrow suppression because of the cytokine levels. All of these are contributing towards it. So it's a good indicator for us to know what is the kind of viremia or the viral load that the patient could have and the possible course that the patient can take. In fact, the neutrophil, lymphocyte, and the platelet score of more than 6. This is one of the papers which was by Heng et al., which was in, I think, 2021. Which they used the neutrophil, the lymphocytes, and the platelet scores. They had a scoring system of neutrophils less than 4.45. I think the lymphocytes were less than 1,000. All of these and the platelets of less than 1.5. They have used this as a scoring methodology, and this is a good way to really predict if a patient could land up going into an ICU. So these can be your first time point predictors to decide whether the patient requires admission or whether you could manage the patient on OPD basis. We all knew about the NLR ratio, which is a good surrogate marker for the diagnosis of severe COVID. We have a lymphocyte to CRP ratios, which have been used in various cancers as well, which again in some of the meta-analysis has shown to be a significant marker as well. Coming to the inflammatory markers, which I think is the most used and abused of all the tests that we have. So you have the D-dimers, you have the CRPs, the ferritins, and the LDH. All of these are used as prognostic indicators for the severity of the infection, and they may predict the mortality in these patients. Though we have seen that the CRPs, ferritin, dimers, and LDH have been significantly higher in patients who have succumbed to the illness. Coming to the CRP and procalcitonin, these basically go hand in hand because we have been using this since ages as a predictor for infection, bacterial predominantly, and as a part of inflammatory response. In fact, we using CRPs right from the outset for patients who are especially in the pediatric age group to differentiate between viral and bacterial. The difference between the CRPs in other viruses and this is here, the inflammatory response is so huge that the CRPs are extremely high. In fact, CRP was elevated in about 60% of the population, procal in just about 5.5, suggesting that there's some amount of bacterial infection as well, which could be super added in some patients, and LDH in 41% of the patients who were severely critically ill. The cutoff for the CRPs, if you're looking at in milligram per liter, should be more than 10 and more than 5 in nanogram per ml. for the CRP and the PCTQ respectively have been shown as a predictors for poor outcome. CRPs of more than 26 has actually been a cutoff for prediction of severe disease. A raised CRP actually reflects only the level of inflammation. Do not use it as a marker for starting an antibiotic. Right? So it is an inflammatory response. So it should be considered as an inflammatory response. It is not suggestive of a bacteremia. So unless and until we have sent the appropriate cultures and looked at the procalcitonin, going ahead and starting an antibiotic for all patients of COVID is not the most judicious thing to do. It's a good indicator and it's a cheap indicator. So a CBC and the CRP still stays as the mainstay in the third wave as well in terms of doing the investigation. Coming to the other key mediators of immune dysregulation, ferritins and IL-6 have been again indicators which are used. Studies on ferritin have actually shown equivocal results. They have not really been able to identify whether it's just a bystander or it's a true characteristic of the disease per se. But we have seen, as I said, that ferritin is extremely high in patients who are critically ill, but it is also the last of the markers to come back to normal. So you cannot use it as a prognosticator for deciding on the line of treatment for your patients who are admitted in COVID ICU. Elevated D dimers were very frequently seen in almost all patients who were critically ill in COVID-19. Several meta-analyses have actually shown that it can be used for prognostic value, and it could relate and correlate with the in-hospital mortality. The levels of more than 2 actually is what is known to predict the higher mortality in these patients. These elevated D dimers are again inflammatory in pathology. We do not really need to go ahead and do it on a repeated basis. For the ones who are critically ill and admitted to the hospital, you could use it at 1 or 2 time points if required. But there is no role of serially doing a D dimer and trying to match your coagulation medications on the basis of the same. Coming to IL-6, it is dramatically increased in COVID-19 patients, but it is also increased in many other inflammatory conditions as well as infective conditions. So more than half of the patients who are admitted in the hospital will probably have an elevated IL-6 levels. IL-6 levels require a lot of support in the form of how you take the sample, how you process the sample, how you send the samples to the lab. So it is really important to understand all of these factors and send it only if it is absolutely required. It's an expensive investigation. You do not need it really for deciding on your line of treatment. There was a time point when tocilizumab was probably used in a huge number of population. At that time point, IL-6, I have seen people using it 3 times a day, twice a day to just look at whether toci is having its effect, and then again redoing another set of, giving another tocilizumab just to see that the IL-6 goes down. It's an inflammatory marker. It's going to take some time. It doesn't really necessarily show you how the patient is going to move ahead. So it's not something that we are using at all. In fact, we started going down on the use right after the mid of the first wave itself. We started, because we have not been using tocilizumab in our center at all. We stopped using it in August of 2020. So none of our patients have required it. So we have not been using IL-6 at all for really monitoring these patients. Several meta-analyses and systematic reviews which have been done have shown that it can be a marker for severity and predictor for mortality. But let us understand that even a simple test like CRP can be good enough for showing us the severity and the predictor for mortality. So we did not really need to go ahead with high-level testing. Cardiac biomarkers, again, something which has been utilized very often in COVID patients. So these include your LDH, your CK, CKMB, STROPs, ASTs, and anti-proBNPs. These are important in patients who have come with you for a cardiac related issue with COVID. They are not to be done for the other set of patients who haven't really come to you for a heart related issue. So these have not to be done in those patients. So these need to be not used as a routine in all patients because they are fairly misleading. You would start probably barking on the wrong tree and start doing investigations unnecessarily, from the looking at the cardiac front when it is probably not required at all. So less than 7 days, some of the biomarkers which could be utilized is obviously your total leukocyte counts, your lymphocyte counts, your LDH may be raised, your AST, ALT may be raised. If you'll end up doing your CK and CKMB, it may be on the higher side. It could be used as a predictor for severe disease and mortality, but let us understand that investigation by themselves are not the gold standard. You need to factor in the patient profile along with an investigation. Don't consider both of them individually. You need to combine both of them and use them judiciously. Between the 7th to the 14th day of illness, the TLC, the lymphocytes are known to show a fall. It's a normal phenomena. It reaches its nadir bar about the end of the first week and the early second week. Thrombocytopenia may actually occur. The rest of them that I have mentioned here at the FAG and IL-6, 10 and MCP, these are only for research purposes. We do not do it any which ways as a routine. More than 14 days, an increasing TLC, lymphocyte, and the platelet count shows that the patient is actually in the recovery mode, and it reduces your risk of mortality. That's one of the indicators for us as well. So these are for patients who are admitted in the ward only. We do not really go ahead and do all these set of tests individually for all patients. We need to individualize investigations if required. Standard template for investigations is not something that we are rooting for. So putting all of these factors together, we need to understand that severe COVID disease is associated with increased leukocyte, neutrophil, and the infection markers like a procalcitonin, a CRP, and a ferritin could be on the higher side. You could have a decreased lymphocytic count. Cytokine levels and the TNF alphas you need to do only when there is an absolute indication. How would you treat these patients? Now, first and foremost is in Omicron, the minute you suspect, go in for a RAT or an RT-PCR. We still have certain number of patients who are progressing to severe disease. So these could be Omicron or could be Delta. If we do have a patient who is comorbid, more than 65 years of age, having issues which are going to probably be predictors of the fact that he could progress into severe disease, then one should consider doing an RT-PCR. There is something called as an S gene that was popularly being talked about. Now we need to understand this S gene target failure that we were looking at is also seen with certain variants of Omicron. So what we have been advocating, if you have a means to do that, is to look at which of the variant are we looking at to decide whether there's a need to give a monoclonal antibody or we just stick around with remdesivir in patients who are critically ill. Vis-a-vis a molnupiravir, we do not have a Paxlovid any which ways in our kitty as of now. So that's one of the ways that we were actually segregating the patients. So the ones who were younger than 60 without really major comorbidity, we were not doing any major investigations. We would investigate only if required, and the patients were given only symptomatic treatment in the form of paracetamol and some multivitamin supplements. And yes, we were using inhalers for these patients, ones who had a little upper respiratory kind of a symptom. Treatment should be based on the severity of illness. It should not be a one shoe size fits all kind of a scenario. If possible, as I said, we should look at the variant. Further investigation should be looked at only if there is a severity of illness. Molnupiravir and remdesivir is what we were really looking at. Favipiravir for the patients who really probably do not need the drug is not required. Molnupiravir, again, we were speaking to the patient about the possible side effect of the drug, and we would take a consent before we, at least if the patient is on a home quarantine kind of a thing, from our side written, but at least a verbal consent, and talking to the patient about the possible issues with the drug. Steroids have been used to the base minimum in this particular setting. Most of our patients have not required anything more than inhalational steroid. These have been regulated into the back burner. We have been using it only for critically ill patients requiring oxygen support. A rise in the CRP or a rise in the IL-6 is not going to cause a knee-jerk reaction. causing us to start the patient on steroids. And the labs were done before we start the patient on any of the antivirals. So the labs that I am talking about is a CBC, a CRP for the patients who are running high-grade fever, maybe a blood culture and a procalcitonin if the patient has been affording, and an SGPT and a creatinine at least as a base minimum, because all of these drugs are known to be toxic to either the liver or the kidney. So you need to know what is the baseline before you move ahead. So the take home from this talk that I would want is for patients who are asymptomatic or in the mild category without any other underlying comorbidity, no investigation is needed at all. You need to symptomatically treat the patient. Just keep the patient in your loop. Tell them what are the warning and the red flag signs, and to reach out to us if there is a need and if that arises. Mild category with a associated comorbidity on the patients, you would do a CBC or CRP, complete LFT, because hypoalbuminemia is something that we would want to look at because that's another predictor for severe disease, and a serum creatinine. If any of these markers are abnormal, further investigations for those patients may be considered if your patient falls into the severe category, or else in the second week, we would ask the patient to do a CBC CRP again. We would not do anything in the intervening period unless and until the patient had issues. And these patients are generally managed at home front. The severe category, in as against the other ones that I spoke about, we would also land up doing at least at one time point a ferritin, D-dimer, LDH, and a procal. Patients in the critical category, we would do an IL-6 at first time point if required. Otherwise, we would not do it. But what we do use to monitor is the lactate levels, because that shows us the level of tissue hypoxia. So that was a good predictor for us. So we were doing the serial lactates for our patient. Fortunately for us, our hypoxic patients, lactates are given on our ABG machine itself. So we never really needed to go ahead and do it physically in any other form. To monitor hospitalized patients, a CBC and a CRP were done every 48 to 72 hours, depending upon the need for us to do that. Serum ferritin, IL-6, D-dimer cannot be recommended to monitor the response to therapy based on the current evidence that we really have. Thank you so much. I would be happy to take any questions. I can't hear anyone.
I think Dr. Agrawal, sir, is mute. He has not unmuted himself. Can we take question? Yeah. Sir, can you take question answers?
Yes. We are not able to see any questions on our screen. Hello. We are not able to see any questions on our screen.
Meanwhile, you ask your question if there are any.
Okay. Yeah. Thanks, Madam Anita Matthews. She has nicely elaborated the clinical and laboratory correlation in this COVID, and she has rightly pointed out that the lab tests were more of used and misused. Some basic factors on simple things like CBC, where neutrophil more than 3 times the lymphocytes would be useful, and the tests are to be carried out depending upon the comorbidities, worsening of the disease, and to monitor the side effects of the drugs, if any. And steroids and heparins have been used too much in the second wave. Also, maybe because the guidelines were little confusing, and they used to mention that all these tests are to be done whosoever is COVID positive, and there was a fear of COVID getting deteriorated, and hence steroids and heparins were being used to all and almost all patients to start with, even in the OPD patients. Madam has very lucidly elaborated when to use and when not to use and how to monitor them.
I would just like to add that you must treat the patient and not the report. And as Madam has said, keep the test to the minimum and individualize the treatment. That's it.
We pass on to the Master of Ceremony to take over. And thank Mrs. Anita, Madam, once again for her lucid talk.
Thank you so much, sir.
Thank you, Dr. Anita Matthew ma'am, for giving us detailed and very valuable information regarding clinical presentation, investigation, as well as treatment of this disease. And I also thank Chairperson for your valuable comments. Now I request Dr. Rupali Pachko to carry forward further events.
Hi, I'm Dr. Rupali Pachko, also practicing pathologist at Akola. Now our next speaker is Dr. Mukund Ashtaputre sir. He is going to talk on the topic of COVID-19 recent treatment protocol. He is the professor of medicine department at Government Medical College Akola. He plays a prominent role in teaching our undergraduate as well as postgraduate medical student. He has done great work in the management of the COPD and the non-COVID patient during the pandemic. And the chairpersons for these lectures are Dr. Pankaj Patil sir and Dr. Ashish Sato sir. Dr. Pankaj Patil sir is the physician and the intensivist at Ozone Multispeciality Hospital, Akola. He has given a lot of contribution in the managing critically ill COVID patients successfully. And Dr. Ashish Sato sir, he has played important role in providing the medical facilities to the tribal area of the Melghat and made available tertiary medical care center there, so that the tribal people should get medical facilities during pandemic, which is very inspirational for all of us. Now I hand over the mic to the chairpersons to carry out.
Thanks, Rupali. Actually, after a very good presentation by Dr. Anita Madam, which was really an eye-opener. Actually, I had 4 questions for her. If permitted, may I ask questions to Anita Madam?
Yes, sir. Please continue.
Yeah,
Yes,
actually, we have treated hundreds of critical patients of COVID in Meghat, and Dr. Anita was really guiding us, Dr. Anita and our another guest speaker today, Dr. Toraskar sir. We found many cases with increased TLC count more than 14,000, 15,000, and there are no facilities like culture or PCT in our setup. In such rural setup, can we start antibiotics in absence of facilitated culture when TLCs increase more than 12,000? That is first question. Second question, we have noted many cases with hypokalemia and hyponatremia in critical COVID cases that might be a manifestation of acute tubular necrosis. And if Anita can throw some light on that. Third, we have noted many cases of thrombocytosis rather than thrombocytopenia in cases of critical COVID-19 cases. These are my 3 major questions for Anita Madam.
Actually, sir, I was writing individually in the chat box and sending it across to all of you all. Whatever questions were put up, I was doing that. So hyponatremia, hypokalemia, we were seeing quite a bit in the Delta wave. Like you rightly pointed out, we have not really seen much of that in the present wave this time around. So most of our patients have done really well without really having, majority of them have really not had a major renal involvement. Secondly, if the critically ill patients that we are talking about have received steroids, then the WBC counts could be falsely on the higher side because of the steroids itself. So if the patient is symptomatic, really running fever, looking sick, then yes, if we do not have the means to go ahead and do further investigations, obviously one would err at the side of caution and start an antibiotic. But it is always probably more judicious if the patient has not been in the healthcare sector in the last 3 months to probably look at a lower generation antibiotic rather than upscaling the antibiotic to something which is like a a piperacillin tazobactam or a meropenem. We would like to probably restrict antibiotics as much as possible and maybe stick around with your basic amoxiclav or even just a plain ceftriaxone. We would like to cover the bugs which are probably more gram-negative than gram-positive, especially in patients who are critically ill here. The third question, if you could come again.
Thrombocytosis.
Thrombocytosis. Yeah, so thrombocytosis, I have not really, pardon me, but I've really not seen a majority of our patients really having thrombocytosis. It's more either a normal platelet count vis-a-vis ones who have had actually low platelets. This is what we still are seeing. If you have a thrombocytosis along with COVID, it is a known thrombocytopenia and thrombocytosis both could be something which is inflammatory, which is known, but I don't really know whether it has any major significance. I would be probably able to get back to you on this, but I don't have any data to really talk about, and I don't want to just talk through my hat.
Thank you, Anita madam. Now I'll invite Dr. Ashtaputra sir. Dr. Ashtaputra sir is a well-known physician and professor of medicine in Government Medical College, Akola. His topic is COVID-19, recent treatment protocols. When there is doubtful role of D-dimer, CT scan, remdesivir and favipiravir, whether it is really needed or not, what is the myth and facts, what is the real reason for prescribing such guidelines by the so-called experts, which need to be tested vigorously. I'll invite Dr. Ashtaputra sir to throw light on the facts.
Thank you, Dr. Ashish. Am I audible?
Yeah, you're audible. Please go ahead.
Thank you, sir. Thank you. Very good afternoon. We are just beginning the afternoon session. What we will be starting with is how we will be proceeding in our webinar right now. As being in a GMC, what we are basically dealing with is a DCH, dedicated COVID hospital. And that is why we'll be looking for proper treatment protocol for every hospital and hospitalized patient, specific therapy, then issues regarding the patients that we will be covering, and then what are the different policies which are being effected till date, as we can say up to the 17th of January, that we'll be seeing through. These are what we are following since the beginning of, say, the first case we started in 2nd and 3rd April of 2020 at GMC Akola. But right now, this is what is being followed for DCH admission. And fortunately, I should say, because of that only, this time around, we have very less number of admissions as compared to first and the second wave. These are very clear-cut criteria. I think all comorbidities, patients age more than 60, diabetic, hypertensive, CKD, COPDs, immunocompromised, immunosuppressive drugs, all liver patients, liver cancers and morbid patients should be admitted. Another group which I would like to highlight is patients, those who are symptomatic, what we say, going into a moderate category of COVID pneumonia. Febrile respiratory rate more than 24, blood pressure sinking below 100, saturation below going 92, I should say rather, they should be admitted. Now this, as all are aware, when we started in April 2020, our Maharashtra State Task Force, they guided us with own treatment guideline protocols so as to have a uniformity in all over the GMCs as well as the district hospitals and the rural hospitals and everywhere. With passing of few months from April 20, we had another revision in September 2020 as the remdesivir started entering from, I think, May into June first week in 2020. There was revision in certain guidelines. Then came tocilizumab and IL-6 inhibitor etulizumab on the roll around June, July 2020 for cytokine storm patients. Steroids were already in from last April, May only 2020, I should say. Then after September 2020, there was no real efforts were made to again go back to the revision of any treatment guidelines. It was done in September 2021, and now These are what we have 9th January 22nd latest guidelines. There are changes which are supportive, and they are has been categorized as per the criteria, investigations, and treatment. As the first slide indicates, as we are seeing this slide, it is categorized into stages 1, 2, 3, and ABC category. Stage 1 ABC, as we are seeing, not much of investigations are being advised, but as we are proceeding to 1C, which is symptomatic with comorbidities, as we discussed, hypertension, IgD, diabetes, malignancies, chronic kidney, chronic liver disorders. In those patients, there is an addition of HRCT thorax. I think that is an important thing which has been included. And second is the oral antiviral drugs. Still the option is being kept open, whatever the, as per the clinician's choice, whether to go for favipiravir or molnupiravir. During the last session by Dr. Anita, I could see certain questions which are being asked. How do we decide regarding molnu or favipiravir? As on today, in second week, we were short of favipiravir and remdesivir when we started using it right left, I should say. All patients, those who were mild with normal saturation, with history of fever, we started giving favipiravir. And all patients, those who required moderate pneumonia and severe pneumonia or critical pneumonias, we ended up giving them remdesivir. Not only remdesivir, but we also give them the extra remdesivir doses also that we'll be seeing now. In stage 2, I should say pneumonia without respiratory failure, still the drugs remains oral. That means oral drugs, favipiravir or molnupiravir, no role of antibiotics. But as we enter stage 2B, that is respiratory failure, there we will be able to see, apart from HRCT, LFT, KFT, ferritin, LDH, we will be requiring certain cardiac investigations and arterial blood gases. Now here comes the role of remdesivir, which is essentially has been described experimental off-label use, COVID pneumonia, RT-PCR positive with low saturation. Those were the patients, those were classically classified for remdesivir use only. There is another change in remdesivir use in recent guidelines. In those patients, those who are critically ill, initial documentation was 200 milligram first day, followed by 100 milligram once a day for 4 days. Now it has been recommended in a critically or a severe pneumonia, the remdesivir use can be further extended to 1 plus 9 days. That means total 10 days. That is been advocated for remdesivir use. Still, in second wave, I should say, in spite of using remdesivir, we had our own problems associated with this. One, kidney functions derangement, second, liver functions derangements. In some of the cases, we also got cardiac toxicity in the form of bradycardia, not cardiomyopathy or nothing, but extreme bradycardia to the level of 50-40. That was noted in some of the patients. And again going back to our protocol, when we were in stage 3, that is the stage when we have a severe pneumonia with respiratory failure, with MODS. Yes, then we have each and every possible investigation which should be done to save the patient. Apart from CBC, CRP, ferritin, LDH, kidney functions, liver functions, D-dimers, X-ray, HRCT, all. These are the mandatory things. Before going to this slide, one thing, there is a mention in ICMR and AIMS New Delhi guidelines regarding how many times we should repeat blood test in a patient in a dedicated COVID hospital setup, especially moderate category and severe and critical category. In a moderate category, pneumonia, where patients are admitted to us, on admission, we are doing CBC, CRP, ferritin, LDH, kidney functions, liver functions on arrival. D-dimer is also done on arrival. Then every 72 hours, we are looking for CBC, CRP, and liver functions if those patients are receiving remdesivir. We need to monitor in between, and another every 5th day we are monitoring D-dimer of these patients. Is there any incremental deterioration of D-dimer values? Regarding, I should say, critical patients, all critical patients every alternate day, CBC and CRP, every 72 hours, we are doing kidney functions, liver functions. We are monitoring them, and procalcitonin, of course, to see for what is happening, whether patient is improving on parameters or some drug-induced toxicities are happening with the patient, that needs to be monitored. Now coming to this remdesivir, all people like me, those who are frontline workers, extensively involved in COVID management in first wave, second wave. Of course, on first, we had a clear-cut indication. In second wave, in March, it started extensive use. April, all hell was broken, and we had a very acute shortage of remdesivir. So that the guidelines they were modified to make sure that remdesivir is only given to the patients, those who were COVID RT-PCR positive with moderate to severe pneumonia with hypoxia. Only those patients who are receiving in second wave remdesivir, just to prevent its, should say, unauthorized use or unbiased use. But now again on 9th January, the task force which has given us the uses. Here again, I should say, RT-PCR negative SARS-CoV has been included the use of remdesivir. Favipiravir, as I said, this is in third wave. We are not using any antivirals because patients are not needing any antivirals. Tocilizumab, as Dr. Anita has very clearly mentioned, we also used in first wave tocilizumab in 11 patients to be specific, and we had mortality 2 of 6 patients. I'm not talking anything about convalescent plasma because it is a forgotten story now. Already it was over in the first wave only. In second wave, hardly, already there were guidelines not to use convalescent plasma, so there is no mention. Tocilizumab, as in second wave, we couldn't really find the clear-cut indication. And what we were using in second wave, I should say, it was more of a last option therapy. We have given steroids for 7 days. We have given the remdesivir. We have given best possible antibiotic. Patient has very 5 to 6 lobes GGOs. Patient is not improving. Relatives are pushing. There are multiple calls from various high-profile people. Patient should improve. And so many times, what we seen, this itolizumab or tocilizumab were used as a last resort for the patient. Unfortunately, that should not be the case with IL-6 inhibitors. When we used it in our first COVID ago, there were specific guidelines, and we really tried. We had our Maharashtra GMC one group where we used to put all these doubtful patients when we should launch tocilizumab, these patients. We used to discuss daily all these patients, those who require tocilizumab. And with a consensus from intensivist anesthetist, then medicine people and anesthetist people, we used to have a daily video conferencing, and then we used to decide which patient should be given tocilizumab. And with that, what we could infer, a patient who is admitted with moderate to severe COVID pneumonia has fever which is not responding for more than 48 to 72 hours. His CRP is elevating on admission, maybe 20 or 30, going to 70, 80, or on third day, maybe going to 120. Then TLC is deteriorating, patient holding on well, kidney functions and liver functions. Procal is normal, but X-ray shows some deterioration. Now, these were the patients before they crash. These were the patients we had given this patient tocilizumab. And really, again, I should say the patients when we had failed to survive the patient, uh, those patients had significant comorbidities, or maybe we were slightly late in launching the tocilizumab. I should say right now this thing to be very true. So, and because of that, I think from second wave beginning onwards, tocilizumab have taken a back seat. Rather than a front treatment option, it has taken a last option in the treatment. Antibody cocktail, it was very huge presentations, push given to after the ex-US President Donald Trump received this. But fortunately or unfortunately, it never took off in any of our GMC ICUs and moderate pneumonia wards. It never took off. Frankly speaking, as on today, we do not have any of these drugs, rather cocktail therapy available with us. That is why even we have not used it in our GMC setup. But my counterparts in private big setups also, they might have used and they may have their some own experiences, but we are not. I think this drug doesn't require any special words. This has remained the only cornerstone from first, second, and the third wave now. Absolute no confusion regarding the usage. Only thing which has gone wrong with this drug, I should say, is the non-responding fever. That is the most common thing which I have observed when it has been misused, I should say, is a non-responding fever. Second, patient who has high CRP but no pneumonia. These were the indications, or some COVID HRCT showing patches of say 3 or 4 score out of 25 or 7 score out of 25, but patient has no fever, CRP is normal, Procal is normal, but these were rampantly used in second COVID phase. That is my observation. What has gone wrong? Because in first wave, all were like we were all blind. We were all treating first in our lifetime these patients. We were also not sure, so we were holding on well everyone's hand, and we were moving around. But after the first wave was over, in second wave, everybody became independent and we started taking our own calls. Sometimes there were influential people, we never wanted to take a risk for their treatment, and this happens. To be very frank, all the people, those who are working in government setups or in a big private hospital setups, there is always a pressure to deliver. And especially if your patient happens to become a very high profile patient, and where you really want to make sure things should never go wrong with this patient, then sometimes we take a call for extra precautionary use of certain drugs. And steroids has become that drug in our second wave. First wave, we really used it nicely, but in second wave, we slightly overshoot with the steroids. And that is why one of the important, we are being blamed, medical fraternity is being blamed for mucormycosis. We used it left, right. What happened in first wave? Everybody was afraid of COVID. There were guidelines which were not percolated up to the grassroots level. In second wave, like December, November, December, only everything was very well documented and it was percolated to the minute date of PSC or ADH level. So when the second wave started in February, then right from PSC to a RMP or a general practitioner at ground level, everybody started using steroid. And what we have seen as a terminally ill patient receiving after 8 days history, 15 days history, a comorbid patient living at home with some nearby GP prescribing them so many drugs at home, injectables or oral formulation. And then we are getting these patients, those who are already on steroids since last 5 days, not investigated, and we find patient is diabetic, patient already has so many complications. I think this we have taken, but in third wave, everybody become as smarter. Now we are very judiciously, not even only treating, but also classifying them. So that is why there is a, thanks to Omicron also, which we are not sure whether it is what it is, but severity of disease has definitely decreased, and hence the use of drugs has also decreased. Now this is, I think, all of us, those who are involved, this is beyond doubt the best thing which has given, the best results which has given in moderate to severe pneumonia. This is what is COVID awake repositioning and protocol. And I'll tell you, apart from monitoring and the CAR protocol, what has really saved the patient is the CAR protocol. And all hospitals, whether in a government hospital setup or a charitable or a private or NGO funded, wherever there was meticulous follow of monitoring and CAR protocol, there definitely there was significant reduction of mortality has happened, and that is the best part of it, I should say. These are something protocol says regarding the thromboprophylaxis. My senior colleague Dr. Garge sir has very well elaborated, and this statement, therapeutic dose of anticoagulation may be considered in patients with markedly elevated D-dimer level more than 6 times of upper limit of normal. This has been a newest correction of 9 January state protocol. If we take upper limit of normal as 500, this becomes 3,000, I should say. That is been included. But what is the practice? As a clinician, as a person, we are dealing with since almost I should say 22 months with COVID and non-COVID things. What we are practicing at our centers, all patients, as we are only getting DCH patients, all patients, those who are without any comorbidity, less than 60 years of age, only at the time of admission we are doing their D-dimer levels, and we are not treating them aggressively with low molecular weight heparin. Second, as I said earlier, we are monitoring with D-dimer every 4th day with this patient. In associated, if patient has clinical deterioration in the form of fever, increase in breathlessness, patient has increasing infiltrates over the X-ray chest, patient has abnormal ECG changes which are in favor of, I should say, pulmonary embolism, like non-progression of RA wave, RSR dash pattern, then hypoxia, deteriorating hypoxia in spite of maximum settings achieving saturation to 90 to 96% is not being achieved. Then on bedside to the ecography, we are getting a dilated IVC, dilated RARV. Now these are the things which are guiding us. Are we really treating pulmonary embolism in such patients? Ideally speaking, all these critically ill patients, they are not in a position to be shifted to scanning for or any pulmonary angio or for any radiological invasive investigation, I should say. So unfortunately, all these management relies more on a clinical shoulder, on a more of a clinical background. If fever, cough, hemoptysis, deteriorating blood pressure, deteriorating hypoxia, ECG changes, echo changes, deteriorating radiological features on X-ray. I think we are managing these patients more on clinical grounds associated with bedside measures we have, rather than only blood value, I should say. We are not. Absolutely. This is, I think, in a non-intubated patient, This is the most important thing, how patients should be going in for oxygen. By and large, all patients, those who require oxygen, as they are admitted to us at a DCH, first nasal prong should be used or a simple face mask, 2 to 5 liters. And this monitoring of SpO2 should be 1 hour. In last year's guidelines, there was special mention of monitoring nurse. There was mention of monitoring nurse so that one staff nurse dedicated for 30 patients supposed to monitor fever and SpO2 of each and every patient 1 hourly in the ward. The idea was to take care of these decisions. When patient should be shifted from a nasal cannula to a non-rebreathing mask, and when patient from non-breathing mask should be subjected for a non-invasive ventilation. Now, these were the main things which are important, and this is a part of monitoring and nothing else. From here, as we are seeing this PaO2 FiO2 ratio, these are more of arterial blood gases things which needs to be done. If patient is not above 94 SpO2 with 10 to 15 liters, this is the site when we are shifting patient to COVID ICU and managing them there. And there are some absolute indications when the FiO2, PaO2, FiO2 ratio goes below 200, and if saturation is not increasing, and after 1 hour, these are the patients, those who are going to require planned elective intubation setup. Now, when I say each and every word are important, because COVID severe ARDS or critical COVID pneumonia, it is never a emergency intubation which we are doing in our medicine ICU or medicine wards. If it is a COVID severe pneumonia and if it requires intubation, it as I'm saying, it has to be a planned intubation, elective intubation, to be done by the most expert intensivist available with a team of 3 people around. Because why 3 people? Because the best person when he is doing, there are hardly any chance of not getting it sufficient. One person is taking care of circulation, one person is taking care of suction, and it is always a closed suction. It is never open suction, what we see in our general medicine ICUs. So that is a word of caution. This is up to the regarding the management of severe COVID pneumonia. This is a revised discharge policy which has been just discussed. To point to add it, that we'll be seeing in panel discussion also. In first wave, we used to keep patient for 15 days. In second wave, we used to keep patient for 10 days. In third wave, we are not admitting right at the onset if it is patient has mild disease. And even if we are admitting moderate disease, if patient is febrile for 72 hours, there is no oxygen requirement. In moderate disease, there is no need to do repeat RT-PCR. We can discharge the patient after 3 consecutive days where patient is not on oxygen support, no fever, and there is radiological resolution. In severe cases, it is absolutely as per the protocol. That means patient has to have a clinical improvement. One, second, patient should not require any oxygen support, no injectable drugs, and patient should be RT-PCR negative before sending. These are discharge policy, as I said. These are very short things. These are generated, and Dr. Roy has elaborated it on January. This was very clear. On 7th day onwards, there is no need to do anything for the patient. Patient can go home. These are guidelines which I was speaking. Why did I included this? These are very small, not readable, but everything has a QR code scanner. Everyone can have a look at their own home, at their offices. The purpose of this putting this slide was very specific. Not all the GMCs, but even the ICMR, AIMS, and a joint monitoring group. These are the special things which has been mentioned. In mild here, in state task force, there is mention of antivirals. But if we go at leisurely time, there is no mention of antiviral here. In a moderate category, there is a use of steroids. I would like to point our attention in this group, the dose of steroid in moderate is 0.5 to 1 milligram of methylprednisolone. As against in severe category, it is 1 to 2 milligram per kg of methylprednisolone. At any cost, at any severity of duration, the total duration of steroid therapy ought to be more than 7 to 10 days. And that is the bottom line. I think all panelists, everybody who has seen the patient, managed the patient, sometimes or they might have violated this protocol, I should say. And yes, अगर किया है तो किया है, कोई गलत नहीं है, but this is a time when we should realize and move ahead with proper dosing and corrections. Again, this was done. We need to really stick up to the things, and we have really been punished very heavily in second COVID wave because of our ignorance or overplaying with the steroids very heavily. Third thing, the oxygen and oxygen. Not only giving oxygen, but monitoring the oxygen use along with the CAR protocol is really the key for these moderate patients landing into the severe patients. Because if these patients, when they are admitted, it takes minimum 3 to 5 days for this patient to go from this zone to this zone if they are not monitored properly or they are not being investigated on time to time basis. So word of caution here. Then comes the special things. Here in this last this one, it is a mention of remdesivir, tocilizumab. It is very clear-cut indications are there when to use remdesivir and when to use tocilizumab. Here there is no mention of cocktail therapy to be given or not to be given. So this is purposefully have included. Now these are again Dr. Sudipta Raya has informed about this. Why this is important? These are the regulations which has been given by Ministry of Health for all of us, healthcare workers, frontline workers. What should happen when we are in contact with a certain COVID positive patient? What we should do? First, immediately quarantine ourselves, have some rest. Second, test yourself if you are symptomatic. Third, if you are symptomatic, if you are positive, just monitor yourself with daily 6-hourly monitoring of fever and SpO2 and daily walk test twice a day. Walk test at its own importance, I should tell. The most earlier diagnosis of moderate pneumonia is not done by the the blood parameters, but by the walk test. Patient collapsing in bathrooms, collapsing in staircases. These were the scenarios what happened in first and the second wave. But we learned from our mistakes and we really monitored these patients of mild going into moderate, moderate going into severe with these protocols, and it really helped us. Thank you again for being a part of this wonderful webinar. Thanks again.
Thanks a lot, sir. Very nice and elaborate presentation. Especially you have thrown very good about steroids, use of steroid, use of tocilizumab, use of low molecular weight heparin, and use of oxygen. And special thanks to your stress on CAR therapy, that is prone position therapy. There are some questions, but I'll ask few questions first. WHO has conducted a very big study called Solidarity study, and it has concluded that there is little or no benefit of remdesivir in management of COVID. So please guide on that.
Sir, in first COVID wave, we got our first shot of remdesivir in 3rd or 4th June. Again, I said remdesivir is an antiviral drug. It is not specifically for only COVID pneumonia. So first, and there should be clarity, it is not the Brahmastra for COVID, first thing. Second thing, in a solidarity trial, what the WHO has conducted, on 4 parameters they concluded. One is mortality. Second, the severity of pneumonia. Third, the hospital stay. And fourth, 30-day complication rate. So on these 4 or 5 parameters, they evaluated remdesivir. But uh, that is true. But when we are giving remdesivir matters to the patient, if we go back to actual incubation period and when patient is being symptomatic, unfortunately, at right now I don't have this slide. But when patient gets COVID infection, for first 3 to 5 days, there is what we get a phase of viremia. And then we, after 5th or 6th day, we go in a phase of lung involvement. And after lung involvement, up to this 9th day onwards, till that time, if we use remdesivir for these patients, then it is of best use. After the 9th day or 10th day of illness, I am saying the day of illness, not the hospitalization. When we should ask, that is why when we like our basics in sir, first MBBS, second MBBS, third MBBS, go back to the patient, take the proper history. Fever कब से है? Fever कब से है आपको? Cough कितने दिन से है? Breathlessness कब से है? So if we get the history, if it is up to 9th day, if you are giving remdesivir, we may get some benefit in decreasing the severity of pneumonia, but ultimate mortality benefit, no. All 10 patients on the remdesivir in moderate, 10 patients on critically, 10 patients of moderate will not go to serious or on ventilator. No, that cannot be predicted at all. But again, I'll sir go back to my first thing. Please make sure that when we are giving remdesivir, we are choosing patient in first 9th day. If we are getting patient already on 10th day of first day of hospitalization, and we are planning or remdesivir, I don't think it is going to help. Second, patient already on ventilator or on BiPAP, when we receive patient, and if we are thinking of giving remdesivir, no, it may not help. These are not the patients to be benefited. We are just satisfying our own egos, I should say, कि नहीं मैंने सब patient के लिए कर दिया, मैंने ये भी दे दिया, मैंने ये वो भी दे दिया. अभी कल कोई सीपीए में गया, कोई कंज्यूमर फोरम में गया, तो मुझे बोलेगा रेमडेसिविर तो दिया नहीं है, वो प्रोटोकॉल में तो बोला था कि देना चाहिए. I think these are things are also happening. We should be very aware. But yes, 100% remdesivir to decrease mortality, no. Remdesivir to decrease hospitalization stay, no. These are not the indication for giving remdesivir before 9th day of illness from the beginning of symptoms. Remdesivir is on. Otherwise, don't even think of giving. Also, SpO2 less than 94. RT-PCR positive or negative, COVID pneumonia on X-ray, or HRCT 4 or 5 corads. These are clear-cut indications for remdesivir.
Thank you, sir. There are questions from Dr. Nitin Vairakkar, sir. First is, monoclonal antibody cocktails are not working or effective for severe Omicron patients. Why antibody cocktails are still part of treatment protocols? FDA has reversed the approval of regeneration and LLET monoclonal for treatment of Omicron. Please comment.
Sir, first thing, what sir has said is correct. I will again draw back this slide. These are generated on 9th of January. There is no mention of monoclonal antibodies. The most apex body governed or monitoring the usage of drugs in COVID to us. We are not advocating monoclonal antibodies anywhere. State task force, but we should always remember the things we should say. These are off-label emergency use. These are emergency use approval only. And when they are say emergency use, they are not mandatory. It is the decision of the treating intensivist or a physician in which patient he or she should use this drug. It is not a part of protocol. As I said, protocol ये करना ही है. Antibody cocktail अगर available है and we as a clinician or an intensivist decides yes this is the right patient for this drug only, then so only it should be given. Otherwise it should not be given. Sir, for example, the second thing I should say, antibody cocktail has never picked up in India. I think it is available since October or November, I think. But it has never picked up in what we have uses of like baricitinib or tofacitinib, or in fact rather IL-6 inhibitors, itolizumab or tocilizumab. Nobody is benefiting. And the Omicron severe wave, the third question sir has asked, I am not sure. Are we really have a sufficient data on clinical data or as well as viral studies or genomic sequencing data? Are we really dealing with Omicron first and third, second point out of it, the severe Omicron, I should say, because what we have seen, severe critical pneumonia is most of the time seen in Delta, not a feature of Omicron. Omicron feature what we are seeing, some fever, body ache, myalgia, throat pain, some cough which is lasting for 3 and absolutely third or fourth day patient become normal with some paracetamol, levocetirizine, and patient becomes improving. They even do not requiring azithromycin or cefixime or amoxiclav. They are not absolutely not requiring anything. And frankly speaking, I have not used this antibody cocktail in GMC sir here.
Thank you, sir. There is second question from Dr. Nitin. Is the task for treatment protocol based on research papers published or personal experiences or opinions of task force members?
I think Dr. Kedar sir, who will be talking after me, is the best person to answer this because he himself is a Maharashtra task force member since last almost 2 years now. From the very first meeting, sir is Maharashtra task force member. But I will direct this question to him after his presentation.
Thank you, sir. I'll hand over the mic to Dr. Patil, sir.
Thank you. Thank you, sir. It is my honor to chair session with you, sir, and to listen to very good talk. If any other questions, you could answer. So I think most of the questions have been answered by the talk itself by sir. So we'll move to the next session.
Thank you, Dr. Ashtaputre sir, for sharing your valuable information and sharing your experience of managing the patient during the second wave. And that time it was very horrible, and managing dedicatedly the COVID government hospital is unimaginable. Thanks for your great contribution to our society. And once again, thanks to our chairperson to give your valuable opinion and comment. Now I proceed to my next speaker, Dr. Kedar Thoraskar sir. He will be talking on topic on the ICU management of COVID. Dr. Dr. Kedar Thoraskar sir is a director of critical care of Wokat Hospital in South Mumbai. He is also a member of Maharashtra government task force for the COVID-19. And the chairpersons are of this lecture is Rahul Pingre sir, and he is the intensivist and one of the director of the Ozone Multispeciality Hospital, and also the other chairperson is the Dr. Pankaj sir, They both have given their immense contribution in the COVID era by managing the critically ill patient. So now I hand over the mic to our chairpersons. Carrie.
Hello. Thank you, Rupali ma'am. Can you hear me?
Yes, sir.
Yeah.
You are audible.
Yeah, without wasting much time, should I ask Kedar sir to start his lecture? We are very eager to hear his experiences and his guidelines. Thank you.
Yeah, thanks, Dr. Rahul. And I thank the organizers and Dr. Anand Kaude for giving me this opportunity to speak. I hope you can hear me. And are the slides visible?
Yes, sir.
Okay, fine. So in the next 30 minutes or 40 minutes, I'm going to speak on COVID management in the ICU. So we are all fighting this virus since the last 22 months, and all of us have seen a lot, and all of us have a lot of experiences with dealing with COVID. But first and foremost, obviously, we have to protect the protector, and that goes for all the members in the ICU team as well as all the caregivers. So it is on us to respect and protect our healthcare workers, and we have to do the same. So PPE is required, but things have changed since the beginning of the pandemic. So in the beginning of the pandemic, as the other speakers also said, we were not sure about what exactly the virus was, what was the treatment for it, and how do we use the PPE. So we had initially big hoods, we had complete covers, we had PAPRs also. But the most important thing here is still the N95 mask, whether it is ICU or whether it is the ward or whether it is the OPD. So I personally feel that ICU is one of the safest area for COVID-19 because naturally the patients come in the late phase. They come in the inflammatory phase when the viremia phase is already over and the virus shedding is basic minimum. And you know the enemy and you are protected to the key. The most dangerous areas, everybody will agree with me, are the wards or whenever you put your mask down while you eat with your colleagues. So that's the most dangerous area anywhere in the ward or in the ICUs. So N95 mask, a good, nicely fitting N95 mask is the key. And of course, apart from the other PPEs also. So this is a powered air purifier respirator, which some of our colleagues were wearing, but it is not mandatory. A good fitting N95 mask is also good enough. So what is the current scenario in the ICU and across the world and India? So obviously India is in the midst of the third wave. Obviously things are much better now because we are seeing a downfall of cases in the ICU as well as in the community. And there is a surge of Omicron, as the previous speakers have mentioned, that it is mostly Omicron. 90 to 95% cases are Omicron and BA2 sublineage is seen. So the silver lining being that Omicron is mild and Delta and has replaced Delta across the continent. Predominantly, ICU admissions are limited to a mild disease with non-COVID related complications. If you see currently in my ICU also, 90% of the patients or 85% of the patients are bystander COVID. So they come with hardly any COVID-like symptoms, but they are positive because you have a myocardial infarct and they have turned RAT positive or RT-PCR positive on routine screening. They have to go for a elective surgery, supramajor surgery, and they are positive. Or you have strokes which are incidentally positive. So things like that. So it's and around 10 to 15% are still deltas, okay, which are coming with ARDS like complications, lung complications. So limited COVID related ARDS and other organ failures, but predominantly these bystander COVIDs. So the most important thing is why timing matters. Dr. Mukund was also saying that timing is very, very important. And it is rightly pointed out that remdesivir works best in the viremia phase. So COVID-19 is a deadly novel virus and you have three phases. The first phase is viremia phase, followed by the inflammatory phase. So the first phase lasts anywhere between 1 to 8 days. Then the inflammatory phase from 8 to 14 days. You may have a cytokine storm phase, which can be in the second week or third week, and that can overlap with the inflammatory phase. And that was hyped up for these immunomodulators. And of course, the post-COVID syndrome, which is also significant and makes life miserable for especially elderly patients with comorbidities at home also. Now, specific interventions and drugs may work in specific time frame or the mentioned above phases. So this is the schematic diagram. You have the incubation phase here. You have the viral replication phase, which is the viremia phase. Now your antivirals will work best in this viral replication phase. Even if you have to give the antibody cocktail for a valid reason, they will work best in the viremia phase. Okay, the first 5 days are very important. Okay, then you have the early pulmonary phase where you have the inflammation setting in and you have inflammatory complications of the lung, where you have hypoxemia. Earliest hypoxemia is seen on the 6 minutes walk distance test, where the patient starts desaturating after the walk test, and the baseline saturations may be absolutely normal. Okay, and then of course a late pulmonary phase where you have immune dysregulation, you have macrophage activating syndrome, or you have cytokine storm phase. So your steroids work best in the early pulmonary phase. Okay, and as rightly pointed out by Dr. Mukund, it is a short course and a moderate dose. It's not a high dose steroid. And of course, if you have a cytokine storm phase and if you are worsening, your immunomodulators may work there. So COVID is timing based. Everything in COVID is literally timing based. And if you get the timing right, and if you can time the therapies as per this timing, you will get a treatment right. So what are the criteria for admission to the ICU? So we do what is called as a modified News 2 score. If the News 2 score is 7 or more than 7, the patient requires admission to the ICU. That's one of the criteria. News 2 score between 5 to 6 is an intensivist call. Of course, failed 6 minutes walk distance test, desaturation on the walk test, needing around more than 2 to 4 liters of oxygen, and oxygen saturations persistently below 94 in spite of that. Shortness of breath, obviously, baseline saturation 92 or less, or desaturating on the 6 minutes walk test. Cardiac arrhythmias or any episode of hypotension, shock, or other organ dysfunction, maybe AKI, maybe liver failure, maybe stroke, maybe ACS. So these are a few criteria for ICU admission. Now, this is the early new warning score, which is used for non-COVID era, in the non-COVID era also. What is the beauty of this score? The beauty of this score is physiologically based. So you can use this score even in small towns, even in villages, also in primary healthcare centers also. So you just need the physiological parameters and a finger probe pulse oximeter, of course, in that. So depending on the News 2 score, you have the threshold. So if the score is 0 to 4, it's low risk, okay, ward-based response. Red score, if it is low to medium, it is urgent ward-based response. And as I said, if the score is 5 to 6, the intensivist or the physician decide whether this patient requires ICU care or ward care. And any score above 7 or 7 definitely requires ICU care. So we had a study in which we correlated News 2 score with the clinical outcomes, and it was a robust score to look at for COVID-19. Now, what are the blood investigations? Dr. Garge had an excellent lecture, a master class on D-dimers. And as he rightly pointed out, D-dimer is an overused entity and abused entity. Similarly, most of the investigations were abused in the first wave, and we were wiser in the second and the third wave. So obviously, in the ICU, you have to do a CBC, absolute neutrophil lymphocyte ratio. If your neutrophil lymphocyte ratio is more than 3.5, then that suggests a poorer prognosis. Of course, RFTs, LFTs, a baseline coagulation profile, a shortness of breath panel if the patient is breathless. So in that, we do a troponin I. D-dimer, of course, as Dr. Garge said, has a good negative predictive value. The positive predictive value is absolutely 0. And we also are not repeating the D-dimers. Now we have stopped repeating the D-dimers. NT-proBNP if you are suspecting cardiac failure, CPK total if you are suspecting myositis, and ABG. Now arterial blood gas is one investigation which is very cost effective in the ICU. You get the basic parameters like pH, PaO2, PaCO2, you get the bicarb, you get a standard bicarb, you get the lactate you get the electrolytes, you get the calcium and methemoglobin levels. So all these can be got in one single point of care. So ABG is the most commonly used investigation in the ICU, and we repeat it as per the clinical status of each individual patient. Of course, cytokine panel, again, hyped up. We have stopped doing IL-6 levels altogether. They don't correlate with cytokine storm. The most cost-effective investigation here is a CRP. So that's a bread and butter. Okay, even in a smaller center or patient who cannot afford it, the daily CRP gives you a very good trend of what is happening, infection, inflammation, and so on and so forth. Ferritin levels, again, we do at a baseline or when we are suspecting a cytokine storm or HLH, which is related to COVID. It was not uncommon in the initial two waves, but again, very high ferritins above 10,000 suggests that it may be HLH. Ferritins in hundreds or few thousand doesn't matter. Of course, blood cultures when the patient comes to you from outside or you're suspecting secondary infection. And procalcitonin again is a very good marker to rule out bacterial infection. So if your procal is negative, we don't give antibiotics at all. So what are the oxygenation targets? Something related directly to the ICU. For most critically ill patients, we prefer the lowest possible fraction of FiO2 necessary to meet the oxygenation goals, and ideally targeting a SpO2 between 90 to 96% if feasible. I would go down that most of us target SpO2 between 88 to 96%. No supranormal oxygenation required, like the Schumacher group had propagated around 25 years back. So oxygenation, higher flows of oxygen may be administered using a simple face mask or a venturi mask or a non-rebreather mask. But as the flow increases, the risk of dispersion also increases, and it augments the contamination of surrounding environment and staff. So you have to be very, very careful when you are doing that, or you are using any nebulizations also. So all of this, plain nasal mask, a non-rebreather mask, a venturi mask, wall-mounted venturi can go up to near 90% of FiO2. The common venturis can go up to 50 to 60. And of course, the new kid on the block, high flow nasal cannulas, which have been used to good effect in COVID era. We'll come to that later. And of course, NIV, the non-invasive ventilation, which acts as a bridge to avoid intubations, okay, wherever necessary. But if you overdo NIV, it may be a disaster. And of course, invasive intubation and ventilation, if your conservative management and non-invasive ventilation or HFNC is failing. And of course, awake proning repositioning, the CARP protocol is very, very important, which Dr. Mukund has rightly mentioned. Now, room air saturations are obviously 21%. Okay, a nasal cannula can go up to 24 to 44%. Simple face mask up to 60%. High flow mask, non-rebreather mask up to 90%. Wall-mounted venturis up to 90%. Of course, and your BiPAPs, if they are home BiPAPs, portable BiPAPs, they cannot go above 60% or maximum 70%. But your wall-mounted BiPAPs with the blender, they can go up to 100% as the invasive ventilator. So the $1 million question is when to intubate and ventilate. So we had a lot of problems in smaller centers, bigger centers also, where people were shying to intubate and ventilate these patients. Because in the first wave, it was like, once the patient goes on the invasive ventilator, the mortality is 100%. Nobody with COVID-19 pneumonia comes out. But as we became wiser and we got more protocols and we got more experience, obviously, it was like any other viral ARDS. So we should not shy away from intubation and ventilation wherever it is indicated. That's the take-home message. So whenever the patient is not protecting the airway, that's a common indication, not specific COVID-19. Your PF ratio is below 180 despite of HFNC, CPAP, NIV with CARP protocol. You use the modified intubation protocol, PPE and minimal exposure techniques, and of course RSI. So what is the exact timing? So in patients with COVID-19 who have acute hypoxemic respiratory failure and needs more than low flow and require low flow oxygen, we can suggest non-invasive modalities and maybe selective rather than proceeding directly to intubation. Like for example, a young patient who without any comorbidities who can tolerate the nasal cannula and the HFNC or NIV. But on the other hand, some patients may warrant avoidance of HFNC directly and may benefit from proceeding directly to early intubation. For example, an elderly confused patient who cannot protect his airways with several comorbidities and risk factor for progression. So the bottom line here is do not delay intubation if it is very clear that the patient will not improve with oxygen therapy or HFNC and CARP. So what is more dangerous is delaying an obvious invasive ventilation rather than not intubating the patient. So that's the take-home message. So other indications are rapid progression over hours. So if it is a rapidly progressive hypoxemia in spite of conservative management, lack of improvement or more than 40 liters per minute of HFNC with more than 60% FiO2s, evolving hypercapnia or increased work of breathing. That word is very, very important. The work of breathing, if it goes bad, that's an indication to intubate these patients if they are not improving. If it is a happily hypoxic patient and the work of breathing is not bad, you can still wait. Hemodynamic instability and multi-organ failure, again, one obvious indication for intubation and ventilation. So intubation and ventilation, again, is a high aerosol generating technique. And as Dr. Mukund mentioned, that you require 3 people ideally for intubation and ventilation. And you have to have a checklist like any other checklist you have. So you have to have a team, okay? You have to have the patient with proper indications. You have to have the drugs which are ready, sedative, hypnotics, muscle relaxant, and you have to have the equipment, all the equipments ready. So you have to have fluids on flow. The suction should be working. The face mask with viral filter should be connected. The EtCO2 should be ready. The oxygen should be on. Oropharyngeal nasal airways if required. Video laryngoscope obviously helps because the proximity to the patient during intubation is not as much as the routine laryngoscopes, the manual laryngoscope. Of course, you have to have a plan B of supraglottic airways and 2 to 3 people who are in the process. And the best person obviously intubates the patient. You have to have other backups like scalpel, bougies, tubes, okay, and of course a bronchoscope if you have a bronchoscope available in your institute. So modified intubation protocols, planned intubation as far as possible, take good time to have your steps, assess the airway difficulty using Malampatti or Lemon classification, 3 people for intubation, airway doctor, airway assistant nurse, and drug administrator. All 3 obviously should be wearing a PPE, okay. Video laryngoscope is preferred. If not, standard laryngoscope can be used. Select bougies, pre-oxygenation is very, very important. Keep the ventilator with disposable circuit checked and ready. The RSI, rapid sequence intubation, that's the key. Attach a bacterial viral filter to the end of the endotracheal tube. So once intubated, there is no passive expiration, which will increase the viral shedding. Clamp the tube with the forceps, attach the ventilator circuit, and confirm the intubation with end-tidal CO2. Auscultation may not be possible with some hood PPEs, but nowadays hood PPEs are not being used very commonly. We have stopped using it. So you can auscultate, or if auscultation is not possible, you can use the lung ultrasound or of course your end-tidal CO2. Now this is a schematic diagram of your high flow nasal cannula. So those who have not seen it, there is a nasal prong which is attached to a humidified circuit and which is attached to the wall mounted flow meter, okay, to the central oxygen here. So you can adjust your parameters here. So the FiO2 can be adjusted here. You can go to as high as near 100% FiO2, and you can adjust the flow and of course the temperature. So the temperature is self adjusted. So you have a auto temperature control here. Now what this does it gives you a high flow oxygen which is humidified and some amount of PEEP also, not as much as the NIV. So it's a small pliable nasal prongs. It is heated and humidified. It washes out the nasopharyngeal dead space. It gives you some PEEP also. And of course, it gives you a high nasal flow rate. Now, what's the benefit? It enhances patient comfort. It facilitates removal of airway secretions. It also decreases the work of breathing. Okay, those patients who cannot tolerate the NIV, you can use the HFNCs. It uploads the auto PEEP if it is present. And obviously, there is a reliable delivery of FiO2. It also improves the breathing pattern. So all these are physiological advantages of the HFNC. So use flows below 40 liters per minute to mitigate the risk of aerosol. Use the lowest FiO2 to maintain the oxygen saturation up to 96. We would say that the current targets are 88 to 92 also. And if it consumes a lot of oxygen, so you need to beef up the oxygen store. So in second wave, we had real problem with HFNC and we had stopped using HFNCs because of oxygen shortage. So HFNCs, if they are not available, of course, you can go to NIVs also. Before that, Dr. Mukund shows this slide. This is one cost-effective This is one cost-effective maneuver in the ICU or even in the ward for hypoxemic patients, which really helps, which is called as CARP protocol or COVID-associated awake repositioning and proning. So you give different positions and see in which position the patient has maximum improvement in the oxygenation, and you can change the position every 4 hours. So it is a nurse-dependent protocol, and we have assigned one nurse to ensure that all the patients in the ICU are carved properly, and we train them, we counsel them, we cajole them into carping. So this is a classical picture of a patient who is lying prone, awake prone on the NIV here. You can use carp for with any oxygenation tool. It need not be NIV. It can be HFNC. It can be a plain mask. It can be a nasal cannula also. Now, HFNC versus NIV, amongst the non-invasive modalities, we prefer HFNCs. But if HFNC is not available, you can always use NIV. Now, if it's CPAP is preferred over BiPAP, because we have seen that if you generate supranormal tidal volume, there's something called as PCL, which is patient self-inflicted lung injury. If the patient is having excessive supranormal tidal volumes, you use the CPAP. Otherwise, for COPDs, obstructive sleep apneas, acute cardiogenic pulmonary edemas with hypercapnic failure, we use the BiPAP. Again, the risk of aerosol generation is high in the NIV. So you have to monitor those patients who are on NIV or HFNC very vigilantly, and we advocate a very low threshold to intubate such patients. So whenever you put a patient on HFNC or NIV and is borderline and is not fulfilling the criteria, then obviously you have to go ahead with intubation and ventilation. So do not delay intubation and ventilation for such patients. The disasters and poor outcomes have been because of not intubating these patients and pulling on with NIV or pulling on with BiPAP with 100% FiO2 for 5 days, 7 days, and you get a pneumomediastinum, you get a pneumothorax, you get a complication, and then you intubate. It's too late for everything. So initial ventilator settings, HNF, L phenotypes, fine-tuning of ventilator settings, prone position, weaning targets, and tracheostomy. That's what we are going to discuss in the next 15 minutes. So at the beginning of the pandemic, Gattinoni and colleagues had propagated this phenotype of L and H. So L means low elastance, the nearly normally compliant lung. That indicates that the amount of gas in the lung is nearly normal with a low ventilation to perfusion ratio and a low lung weight. So this was called as a L phenotype. And whenever we found that once the patient was intubated and the plateau pressures were good and the compliance was good, obviously these were L phenotype. And most of these most of these were the L phenotypes, around 70 to 80% were L phenotype, but there were around 20 to 30% patients who developed the H phenotype. So it was high elastance and poor compliance, high right to left shunts, high lung weight, a wet lung, and high lung recruitability. So this was the H phenotype. So this was at the beginning of the pandemic, and currently the theory is that the lung is a combination of a predominantly L type or H type. It is not only L or H type. So you may have areas where you have H type, you may have areas where L type, but if the L phenotype predominates, okay, then it's a good thing to have. If the H phenotype predominates, it's a bad thing to have upfront. If the patient progresses from L to H also, that is a bad thing to have. So what are the ventilation strategies? So normally it is nothing, there is no magic bullet here. It's a low tidal volume with PEEP, which is titrated to the FiO2 requirement as per the ARDS net protocol, the protocol which we apply for any ARDS patient. So you have to have a low threshold for proning if there is a refractory hypoxemia. And of course, if you don't reach the targets in supine position, you have to prone them as early as possible. Of course, before proning, you use a central line, arterial line, a Foley's catheter, NG tube with a portable X-ray chest done before the proning, and consider ECMO only if resources are available and if 3 to 4 cycles of proning fail. So that is the only indication for ECMO. Of course, there are other indications for VA ECMO. I'm talking about PV ECMO here. Now, this is how you titrate the PEEP. There are standard charts. This is a nomogram taken from the ARDS net protocol. And this is how you titrate the FiO2 and PEEP. So these are fixed protocols. And this is the physiology of prone position ventilation that was seen in a PROSEVA trial, which was a landmark trial for proning. And proning, again, doesn't require extra money, but it requires trained manpower. So that's very important. So you should have a proning team. Just you have an intubating team, you have a proning team. Now, what happens in proning? So this is a wet lung. It's like ARDS lung is like a sponge lung. Okay, so whenever you have a sponge, the water gravitates in the most dependent area. Okay, and the ventral areas are relatively dry. Similarly, ARDS lung is similar. You have the dorsal alveoli, which is collapsed, the ventral alveoli, which is over distended. Okay, and of course, you have the blood flow, which is maximum in the gravity dependent areas. When you prone these patients, you have the ventral lung, which is over, there is a decrease in the over distension of the ventral alveoli, and the dorsal alveoli obviously is decreased. There is a decreased collapse in the dorsal alveoli, and there is a change in the blood flow pattern also. And this is the basic physiology of proning. Okay, so this is how it helps. Now, let's come to the imaging part. So what imaging we use in the ICU or in the ward? So we use a baseline X-ray chest, which is a norm in all the ICUs, okay, for routine monitoring. And of course, we use a point of care ultrasound very, very frequently. I'll come to that later. HRCT as a baseline for severity of disease is good, but if the clinical condition is worsening in select cases where an alternative diagnosis is not picked up by POCUS, we repeat the HRCT. Otherwise, we do not repeat the HRCT. I remember Dr. Garge's words, it is a burden on the exchequer of the society and somebody is paying. So if D-dimer costs so many crores, imagine how much a repeat HRCT would cost. Okay, so this is a bigger exchequer on a bigger financial burden on the population, and you should not repeat the HRCT. First and the second way we saw HRCTs being abused, being repeated every third day. So that is wrong. So when do you repeat a HRCT test or a CTPA? So whenever there's a worsening in the clinical condition, namely hypoxemia, for example, a worsening of ARDS, you don't know what is the exact cause of hypoxemia or the clinical deterioration. So whether it is worsening ARDS, whether it is a pneumothorax pneumomediastinum, or whether it is a secondary bacterial fungal infection or mucormycosis or a pulmonary aspergillosis or a VAP or pulmonary thromboembolism, which is not picked up on your routine imaging like POCUS. So that is the only indication to repeat a HRCT or do a CTPA. Now, what is POCUS? It's point of care ultrasound in the ICU, which is bedside. It's like a visual stethoscope because it's impossible to auscultate with the PPEs on, but off late we are doing that. COVID pneumonia is essentially an interstitial pneumonia, and it has a patchy, inhomogeneous peripheral subpleural involvement. And COVID-19 is a multi-system involvement. It is not just the lung. Okay, all of you will agree that wherever you have ACE2 receptors, you have involvement of COVID, including all the major organs. And this was more true for Delta. Maybe Omicron is different. And it involves the hearts, the liver, the kidneys, the brain with microthrombosis and DIC-like picture. So why is POCUS useful? It's bedside, no risk involved in transportation as in the CT scan, no risk of exposure to the healthcare workers. It's cost effective, it's portable, no radiation hazard, can be safely used in pregnant females who are afflicted with COVID-19 also. So what is the protocol? We do POCUS in all the patients with moderate and severe symptoms who come to the ICU. We do a lung ultrasound with a modified blue protocol. We do a cardiac ultrasound that is not a dedicated echo, but a screening of the heart, that is eyeballing. Okay, no fancy measurements. And we do a venous analysis, which is a 2-point compression ultrasound, which screens for the DVT. Now we repeat the POCUS every 12 hours or 8 hours, depending on the clinical condition. And the screening is complete within 8 to 10 minutes. So it's a fast protocol. So the correlation is done with the shortness of breath protocol, your inflammatory biomarkers, and a change in the treatment is made as per the combined information obtained from the POCUS and along with the other clinical markers. Now you see a classical B prime protocol, okay, B dash protocol, okay, where you see that the sliding is present, but there is irregular thickened pleura with the break-in pleura. And you see multifocal inhomogeneous distribution at the basis, which is classically seen on the CT also. Now, severity in COVID lung is as per the extent of the B lines. Cardiac involvement can be picked up on the POCUS because you are seeing the heart also, which you don't see on the HRCT. Viral myocarditis, stress cardiomyopathies, regional wall abnormalities associated with acute coronary syndrome. And we also see a lot of mild non-specific pericardial effusion. No tamponade has been documented with COVID. Venous analysis, IVC, is generally small, more than 50% collapsibility. Deep vein thrombosis with smoky echoes are seen. Now that is a hallmark of COVID. So that's called a slow flow in proximal femoral veins. And we see in around 4 to 5% of patients with very high D-dimers. Now D-dimer correlation is not very robust. We use a 2-point compression ultrasound for common femoral veins and the popliteal vein. And I will show you certain videos, then you can pick it up. So POCUS can pick up pneumothoraxis, it picks up massive pulmonary thromboembolism, Maconal sign can be diagnosed, and these patients cannot be transferred down for a CTPI because they are too unstable. Secondary infections, we can see shred sign, you can see dynamic bronchograms, which can tell you that this is a pneumonia. And of course, worsening of the primary disease, which is a diagnosis of exclusion. So if your CT severity, if your ultrasound severity increases, then obviously it's a worsening of the primary disease. And if you don't have the above three. Other utilities, it guides the response to proning. We use the lung aeration, de-aeration score. Management during ECMOs, especially for cannulations, and focus-driven weaning protocols during weaning. So this is a classical picture of lung ultrasound. If you see this vertical line, flashlight line, this is vertical line is a B line, that's called as a flashlight blue line or a B line. So this is the pleura here. That is, there is a break in the pleura here. So these are subpleural consolidations, and these vertical lines are the B lines, which are the interstitial involvements. So this is a Burule pattern in which you see a whiteout lung, analogy of a whiteout X-ray, a white lung on the X-ray. So this is a Burule pattern, which is a coalescing B line here. Now here is the 2-point compression ultrasound. The femoral vein you can see being compressed clearly. So there is no DVT, but you can see smoky echoes here, white echoes, smoky echoes. That's the sticky blood. So that's an analogy. That's a precursor of deep vein thrombosis. And in our study, which we saw the smoky echoes in almost 60% of cases who had severe COVID, with of course in the second wave of Delta wave. So here again you have the cardiac ultrasound just eyeballing. You can see a mild pericardial effusion there, nothing else. But here you can see a classical Takotsubo cardiomyopathy, stress cardiomyopathy, which you can see in any stress, okay, you can see in any other viral myocarditis also, where you have apical ballooning. Can you see a classical apical ballooning, and the ejection fraction has gone down. Now, of course, the baseline management in the ICU remains supportive. Feeding, very important. Analgesia wherever required. Sedation. Now, sedation is a big thing. You don't overdo the sedation. You keep the Ramsay score to 2 to 3, or your Richmond agitation scale can be used. Don't oversedate these patients. Don't use neuromuscular blockade very frequently. In the initial first 48 hours, you can use the neuromuscular blockade, and then use it very sparingly whenever required. Again, thromboembolic prophylaxis for all the patients, an opt-out strategy, even in COVID, like any other non-COVID patient. Head and elevation of the bed, very important. Ulcer prophylaxis, tight glycemic control holds true here also, because the patient may be on steroids, the patient may have COVID dysglycemia. We have seen diabetic ketoacidosis de novo, even in non-diabetic patients with COVID in the second wave and in the first wave. Of course, spontaneous breathing trials wherever necessary, bowel regimes, indwelling catheter removal wherever it is not required, and de-escalation of antibiotics wherever you get the cultures. Now, game changers, again, antivirals, monoclonal antibodies, steroids, immunomodulators, and anticoagulants. I won't go into details of this, but somebody had one question on remdesivir, and why is remdesivir being used, though the solidarity trial has not shown any benefit. Dr. Mukund has answered that. But again, here there is one more good trial which has come out in NEJM, which was published in December, late December. And that says that early remdesivir as an outpatient for patients with multiple comorbidities who are spiking and having fever despite even after the third day, there you can use remdesivir on outpatient basis. And there the dose is, instead of 5 days or 6 doses, it is 3 days course. And that has shown a significant improvement in vis-a-vis progression to a severe disease. So remdesivir has one more evidence to back it up, though as Dr. Mukund rightly said, if it is used too late beyond the viremia phase, it's not going to work. So it is not the molecule which is at fault, it is the timing and the user which is at fault. So early use, no benefit if you use beyond 8 to 10 days of symptoms. So as and when the patient comes to the ICU and he is hypoxemic, it's too late for remdesivir. Monoclonal antibodies, again, no role in the ICU. It should not be used in the ICU because once the patient has hypoxemia, it's too late for monoclonal antibodies. What we do is we use a UTA risk score on outpatient basis. If the UTA risk score is 8 or more than 8 for doubly vaccinated patients, and it's not Omicron, on the multiplex RT-PCR, because the genomic sequencing is going to take a long time to come. So we do use a multiplex RT-PCR. If the multiplex RT-PCR is showing that this is not Omicron, it's Delta or Delta derivative, and the UTA risk score is 8 or more than 8, we consider monoclonal antibodies for this subset. Otherwise, we also are not using monoclonal antibodies for any other patient. So again, a hyped up thing and costly. Steroids harmful in viremia phase since it delays the viral shedding, restricted to not more than 10 days. The previous speakers have talked on this. There is no role in post-COVID ARDS fibrosis. And of course, it increases the incidence of secondary bacterial and fungal infections when used in high dose and beyond 2 weeks. Classical example is our mucormycosis epidemic. The short course, low dose is the recommendation. High dose are definitely harmful. Mortality benefit in hypoxemic patients who are mechanically ventilated. That's what the recovery trial showed. Off-label use in persistent inflammatory phase beyond viremia, but again, this is not to be encouraged. Preferred agents, Dexa versus methylprednisolone. For ICU, use a dose of 1 to 1.25 or up to 2 milligrams, not more than that. Again, tocilizumab, sarilumab, immunomodulators should be used with a pinch of salt. Is harmful if given in patients with active infection and immunocompromise. Best used within 24 hours of cytokine storm or respiratory decompensation. Harmful in viremia. Again, best results within 24 hours of the decompensation. Baricitinib, again, should not be used in patients who have already received an IL-6 pathway inhibitor. The dose is 4 milligrams given once a day up to 10 to 14 days. Now coming to anticoagulants, and we had a master class by Dr. Garge on why D-dimer is hyped up. I completely endorse his thoughts. D-dimer guided anticoagulation decisions should be strongly discouraged. All ICU patients, either prophylactic dose should be given or a therapeutic dose depending on the clinical status. Now, when do you give therapeutic dose? When it is confirmed DVT or pulmonary thromboembolism or myocardial thrombosis. Otherwise, do not give therapeutic doses. It can cause increase in bleeding risk. Okay. There were a few trials which showed that published in NEJM, which showed that moderately ill benefited from a bigger dose. But again, the N number was not great. Extended anticoagulation only for patients with slow flow and confirmed DVT or PT on outpatient basis when they are discharged. Mild patients do not require anticoagulation. Now, prophylactic dose, as I said, only for patients who have a normal 2-point compression ultrasound, and here a negative predictive value of D-dimer helps. Okay, so to be continued at least for 3 months for documented PU or DVT. Coax on discharge if there are no contraindications. Low molecular weight heparin is preferred. Unfractionated heparin for patients who have renal failure with creatinine clearance of less than 30. Fondaparinux in patients with suspected HIT. Okay, and the dose is guided by the 2-point compression ultrasound, which has to be a part of focus, along with D-dimer, which has a very good negative predictive value. Some centers use the sepsis-induced coagulopathy score also, but that's again not validated. Now, the major cause of mortality in the ICU is secondary bacterial and fungal infection. No patient per se generally directly dies. Very rarely they die because of direct COVID-related complications. Okay, they die predominantly because of bacterial and fungal infections, which is a major cause of mortality. And we were really helpless to certain point in the second wave where we had a lot of MDR gram-negative bacterial sepsis. You name it and you had it, which we had not seen in the last so many years. Klebsiella, Acinetobacter, Chrysobacterium, Burkholderia, Elizabeth Kingella meningosepticum, other tongue twisters, Turnotrophomonas, Enterococcus, mucormycosis epidemic was a classical example. Pulmonary aspergillosis, candidemia. Though mucor also had some independent risk factor of COVID itself in the second wave, apart from rampant use of steroids and immunomodulators. So adherence to strict infection control protocols and norms, which go for a toss in COVID-19 ICU, that should be done. Judicious use of gloves as in non-COVID critical care. We saw that all our nurses, doctors were using the same gloves to the next patient also, to the third patient also, to the fourth patient also, and there was cross infection. So we did away with gloves in the second wave. We did away with redundant other PPEs in the second wave. And of course, tight glycemic control is very, very important, avoiding high dose and long courses of steroids and sparing use of immunomodulators. Surface cleaning, very, very important. Surface cleaning went for a toss. Disinfection went for a toss. That is very, very important. What about tracheostomy timing, early versus late? Again, the consensus guideline says that mentions 10 days with improvement in the patient condition. You can wait up to 10 days, but it is case to case basis. So if you have a limited resource, limited setup, an early tracheostomy is prudent approach, but not before 7 days. And it does cause some problem in proning, but centers like ours, where you have a dedicated proning team, we prone with tracheostomies also. So tracheostomy is not a contraindication for proning. This is the window. So you may have a delayed window where the patient requires prone ventilation or where there's a multi-organ failure. Otherwise, most of the studies favor early tracheostomy. What about ECMO? Initial reports suggested a high mortality for COVID-19. Okay. And subsequent cohorts did report some differences, that it doesn't differ between COVID-19 and other ARDS. But initial part, we had a very high mortality on ECMO. So institutions without a well-established ECMO program should not attempt to initiate a new program when the resources are scarce. This is what we did. We used to transfer them to a dedicated ECMO center. Even institutes experienced in ECMO may reach a full capacity in large numbers if there's a huge surge of patients like in the second wave. In that, even use of ECMO in a limited cases may overwhelm the hospital resources. So what about code blue in COVID-19? It's protected code blue. Obviously, it is a modified. So don the PPE first, limit personnel, consider resuscitation appropriateness. That's very important. So protect the protector first, protect yourself first. And communicate the COVID-19 status to any new provider. Use a HIPAA filter whenever it is available for ventilation. Use the modified intubation protocol. And if intubation is delayed, consider a supraglottic airway. So you should have a modified code blue protocol. Now, this is what was completely neglected. We had a lot of healthcare workers, including our nurses, our doctors, including us sometimes, who broke down because of depression, anxiety, continuous work, overwork, disease itself, family members getting affected, and that was neglected. So you should have a good backup, give your team rest whenever it is necessary, and try to rotate them to the non-COVID areas also. So some food for thought: mortality reducing measures in COVID-19 critical care. Of course, there is nothing which is out of the blue here, but stick to your basic protocols as in the non-COVID era. Machine versus manpower. Obviously, trained manpower is very important. We had a series of ventilators lying in government hospitals, but nobody to operate them. That's the problem. Technique versus timing. Again, timing is the key in COVID, which I have reiterated. COVID is time bound. And unfortunately, if you don't get the timing right, the patient lands up in the ICU, and then in the ICU it is damage control. So that's very bad. So you try and avoid so that the patients don't get complicated. So test early, treat early, okay, and trace the contacts. That's very, very important. So basic epidemiological principles are very important. Newer treatment options, no magic bullet here. Do not use. So what is the take home message? What are the don'ts in COVID ICUs? Don't use high dose steroids and extended courses. Our previous speakers have reiterated on this. Even I reiterate on this. Do not use immunomodulators indiscriminately without proper indication and without proper dose. We have almost stopped using immunomodulators. We do use baricitinib for some patients, but we have almost stopped using tocilizumab. No therapeutic anticoagulation without evidence of thrombosis. Do not use D-dimer as a tool to guide your anticoagulation. Limited fluid strategy, avoid liberal fluids, tight glycemic control, prevent iatrogenic complications like secondary infection, bacterial, fungal. Stick to your basic principles of any viral ARDS management as we do in the non-COVID era. Protect the protector. Your life is very important. Fast hug BID in the bed. That's the key. Supportive management. Prevent nosocomial infections. Do not delay intubation and ventilation where it is indicated. Then the outcomes will be poorer. And as I said, no magic bullet for COVID. You have to go via the guidelines, and the guidelines, this is a pandemic situation. So the guidelines keep on changing. So somebody had asked the question whether the task force uses its own guideline. No, we are we are not a guideline body. We follow the universal evidence-based guidelines. So as Dr. Garge and other speakers also said, most of the problems in COVID ICU and in treating COVID are because of harmful treatment. So first, do no harm, avoid harmful treatments. The don'ts are more important than the do's. And thank you very much for your patience and attention. I can take questions if there are any. Thank you very much.
नाही त्या सेमिनार चालू आहे. बोल काय झालं, घेऊन गेला होता मग काय झालं?
थँक्यू केदार सर.
हा
Sir, please mute. Somebody is not muted. Please mute. Dr. Iyer, sir, please mute your microphone. Hello. Very nice presentation by Dr. Kedar sir. He had nicely elaborated us regarding the timing and the timing of admission and drug to be given. A very novel use of modified new score, basic investigations, what are to be done. Target SpO2 and a use of ultrasound in COVID patients. Hello, Dr. Kedar sir.
Are there any questions?
Actually, there was a question from Dr. Ashish Sathav sir. Hello.
Yeah.
Yeah, Dr. Ashish had asked what should be the optimal level. As you have rightly said during your discussion, previously we used to keep oxygen level around 94 to 96. But is it safer to go below till 88%?
Yeah, it is completely safe to go below. No, below 88 can be a problem, but the target should be anywhere between 88 to 96. The optimal targets when you want to conserve oxygen and get down to the lowest FiO2 is 88 to 92. That's the optimal target. Okay. So high FiO2s also have problems. You can have complications of hyperoxia, which can itself lead to more ARDS. So up to 88 is perfectly fine. Those patients can go, some patients can go below 88 also. If they are stable, the work of breathing is fine, you can accept a saturation up to 86 also. But by and large, the target should be 88 to 92. And definitely not above 96.
So there was one question from the participants that in your experience, what was the best mode for ventilation for COVID ARDS patients?
So the best mode there is no best mode, but generally we use the pressure control mode upfront when we intubate the patient. Okay, because volume control, you are not in control of the pressure. So the idea is to limit your plateau pressures to up to 30 centimeters of water, and that can be effectively done with pressure control mode. So pressure control assist control is the initial mode when you intubate and ventilate these patients. And then once you know how much tidal volumes you are generating, okay, in what pressures, you can go to PCVG or PRVC mode, the dual modes also. But generally, we don't use volume control in such setups. We start with pressure control, and then we graduate to the dual modes, either PRVC or PCVG or whatever you have on the ventilator. But the basic principles of ventilation remain that it is a lung protective strategy. So low tidal volumes with high PEEPs, try to get down the FiO2 to safer levels up to 60%. Okay, and you have to avoid barotrauma, volutrauma, atelectrauma, and biotrauma. So avoid CLE. So lung injuries have to be avoided. So that's the basic thing.
Yeah, correct. Thank you very much, sir. I think if there are any questions. So thank you, Kedar sir, for a very nice, informative lecture.
I thank the organizers again for giving me this opportunity, and Dr. Anand specifically. Thank you very much.
Yeah, thanks a lot, sir. Should we move on to our next lecture and next speaker? Over to organizers, please. Thank you.
Thank you, Dr. Kedar Thoraskar, sir, for enlightening our knowledge on the ICU management of COVID, and also thanks to both chairperson for their valuable comment. Now we move to next lecture on COVID vaccination by Dr. Anand Kavde, sir. Dr. Kavde, sir, is a consulting pediatrician and done research in the clinical trial at KEM HRC Pune. He is currently playing important role in phase 2 and phase 3 clinical trial in various vaccines, including the COVID-19 vaccine. And the today chairperson for this lecture are Dr. Nitin Vairagkar, sir, and Dr. Sanjay Marathe, sir. Dr. Marathe, sir, is the director of the Marathe Child Care Hospital and also the head of the Color Pediatric Neonatal Intensive Care Hospital since many years. Now, I hand over the mic to chairpersons to proceed.
Thank you very much. We had excellent session on management of patients in various settings. And from management of patient, now we move to the next session, which is how can we prevent occurrence of severe disease and hospitalization at a mass scale, and that's a session on vaccines. So I would like to say hello to my co-chair, Dr. Marathe.
Hello,
and,
good afternoon. It's a pleasure for me to be a part of this.
Yeah, go ahead, have your comments, please, and then we can start with Dr. Anand's lecture.
Yeah. Good afternoon, everybody. It's a pleasure for me to be to chair such an important session. And after having such an excellent talks about the COVID management and D-dimer and all that, I think it was all absolutely rational therapies which we have discussed. And nothing more interesting for me will be a vaccine in COVID. And we are so fortunate to have Anand here, who has done extensive work in COVID and research and all that. So I'm sure we can call him a vaccine man of today's CME. And with his experience and whatever he has done for last so many years, his information, his knowledge in research in COVID vaccines will be of great help to all of us. Friends, let us believe in the vaccines and not on anti-vaxxers. I hand over the mic to my friend Dr. Anand to proceed for his talk, and then we'll have a discussion on this. Over to Anand.
Yeah, thank you, Sanjay sir. Thank you, Nitin sir. Let me start sharing my screen. Is it visible?
Yeah.
Yep.
So, okay. So, good afternoon, everyone. At the outset, I would like to thank organizer for giving me opportunity to share my experience with you. So the topic given to me is COVID vaccines. What are the lessons we learned so far, and we can how we can go ahead. And the theme for this whole webinar is decoding the myths around the COVID entire some management and vaccine part. So I think in a couple of next 30 minutes or odd, I will try to do that.
Can you put on the presentation mode, please?
Yeah.
We can see the bigger slides here. Thanks.
Is it okay, sir?
Yeah.
Yeah.
Yeah. So this is a word we know, and we are living in this world before COVID. We are enjoying our holidays, we are doing parties, and we are meeting our friends and all. But COVID had changed that. And this is a world where we are now living with the COVID. So you can see there is a big bulge in American continent, South Asian, entire Europe. So entire world has affected, and it has spread so fast that everyone know that the only thing or the thing which can do good in that such a pandemic is a vaccine, and therefore the vaccine need come there. Now, when we thought of or scientists and authority thought of what is the ideal pandemic vaccine, then these are the initial four criteria was there which they thought of. One is that vaccine should be efficacious, it should be safe. And since we are developing a vaccine in a pandemic situation, it should be ideally have only one single dose. And it has a rare side effects. So these are the initial criteria. And when the initial phase in early 20s, then WHO has commissioned the experts in the vaccines, because since this is a very new infection and there is no prior immunity to this. So experts, they are called, and then they have decided what could be the criteria for doing the vaccine trials. Okay, because it was an entire new situation. So they decided that there is some criteria, like at least the vaccine should have at least 50% efficacy. At least we should have the 2 months of safety data of that to give to the participant. And then these another 3 criteria, they are come subsequently, that once the vaccines they start developing and then they are in the trial, then they should also prevent the breakthrough infections. Then what will be the real world impact, and what were the effects on the variants once variants come to know. And therefore, what happens that there are a number of people, they come together and they start developing the vaccine. So there are a huge number of vaccines, there are candidates, they are start developing. The only reason for this is that there are, as you are developing more and more number of vaccines, at least couple of vaccines should be safe and efficacious to be used. That was the only idea. And therefore, we are seeing so many number of vaccine candidates to be in the trials. So as of now, you can see that 334 vaccine candidates, they are in trial. And in clinical trial, that is in human trial, 118. And already 33 candidate vaccines, they are in use, different vaccines they are used. So this is a very torrential efforts by the humanity. So, and this is a recent situation. So various vaccines which are developed from the various platforms. And you can see that there are so many in preclinical trials, and almost many they are moved in the phase 4, and they are also in the use. So this is a very torrential effect and torrential efforts by the scientists and vaccine developers. So this is the current situation. And if we look at the current situation of the vaccine, COVID vaccine, and I have give you an example to compare with the routine vaccines. So you can see 334 candidate vaccines are there in preclinical and clinical studies. Out of them, 118 they are in clinical trials, 33 already on use, and 10 vaccines that are already WHO approved. If you compare this with our common infections like measles and TB, we know that there are only a couple of vaccines, 1 or 2 vaccines which are available. So you can see the tremendous effort by the community. Then another important point with this vaccine is there are almost 100% efficacy against severe and critical illness and death. If you compare with our routine vaccines like rotavirus vaccine, which has efficacy of only 60 to 70%. So this is also very extraordinary efficacy, which has seen in the phase clinical trials, and even later on when the actual real impact is seen. So this is also very unexpected, but very useful and very extraordinary efficacy has been seen. Almost 10 million doses are given in 1 year. So this is very torrential effect by all the people, those who are in vaccine development and then after all vaccine distribution. If you compare with your routine vaccination, then a global cohort need almost 2 years to give the 3 doses of pentavalent vaccine. And you can see that almost 10 billion doses are already given. Then in terms of the securing the vaccine doses, 17.7 billion doses they are already secured. And by the COVAX facility, almost 2.8 billion doses they are already given to the COVAX facility. So this is very, very Herculean effort, I can say. Another important point with this vaccine, they are used many platforms to develop. So then another important differentiating point is they are manufactured in record timing. If you see that from the identification of organism to development of the vaccine, so they have taken just 10 months to develop the vaccine. And if you compare this with our routine infection like pneumococcus has been identified since centuries, but you have seen the vaccines in last 20 years. And for malaria, we yet to have the complete vaccine. So this is very, I can say, the extraordinary effort. And in a subsequent slide, I will explain you why this thing has happened. And then global spending by 2025, almost $157 billion on these vaccine programs. So in a single word, you can say these are the extraordinary and historic vaccines. Now, these are the vaccines which are available and WHO approved, and the vaccines which are available in the India. So Covishield, Covaxin, J&J vaccine, Coavax, then AstraZeneca vaccine and Spikevax. These are available. These are approved by Indian regulatory authorities also. And there are certain vaccines which are available in India, approved in India, but they are not approved by the WHO, like Sputnik, Zycovid-D, and Corbevax. While other vaccines like Pfizer and then Sinovac and Sinopharm vaccines, these are WHO approved, but these are not available in India. So this is a list of vaccines. So this is our current status of the COVID vaccine. Now, where I'm coming to the point that, so our current situation that the vaccine knowledge, any information regarding the vaccine and vaccination it is like a syncytium of the facts, misconception, evidences. So what I'm trying to do that I want to segregate all those things. So I will try to segregate the facts, misconception and evidence too, and so that at the end we can have a clear-cut lessons which I've learned, and then which will lead the path to the way forward. So I will try to segregate these things which are intermingled, and it causes a lot of confusion, and it ultimately adds to the vaccine hesitancy. So what I have done is that I have chosen a couple of themes of misconception and I try to counter argue or put the evidence against or to myth to demystify that. So these are the very four common themes I have identified. So there are various questions and couple of questions are there, and every question is fit into the one of other theme. So these are the four themes regarding vaccine hesitancy from the mind of the common man to even for the medical fraternity. So I will go one by one this theme and try to put a evidence or put a counter argument to that, so that we will come to know the importance of vaccine. So first thing is not needed. So his argument is that vaccine is not needed, and there are a couple of arguments to support this. That the first is that we know that this is mostly asymptomatic or mild, and even the first data from the one also suggested almost 80% of the infections they are asymptomatic or mild. So therefore, I don't need any vaccine. Now, if even I'm affected, then the survival rate is high, the mortality is not much. So therefore, I don't need a vaccine. Since I have previously infected with the vaccine, I have a good immunity in my body, so I don't need a vaccine. I am healthy, absolutely healthy, doing right exercise, so I don't need a vaccine. And I am below 18 years, so I also don't need a vaccine. So these are the few of the arguments which try to support this theme that we don't need a vaccine. I have a couple of counter argument to say that. So even if the most of the infections, they are mildly symptomatic or asymptomatic, but the cost of getting infected and treated is very high. So the recent World Bank data and WHO data also said that almost 500 million people, they have pushed below poverty line just because of the COVID. You have seen the many people around you also who has bankrupted or who are lost because of the COVID treatment. So getting infected and treated is not a choice. It's not a good choice. The cost is very high. Then the mortality is, the survival rate is high. Yes, it's true. But even a 1 or 2% of mortality, we have seen that how the health system is shattered in the last year. We have seen there is no oxygen, no remdesivir, and even our dear ones or near ones or the friends, we lost them because of, so very little even the mortality by the sheer number and then unpreparedness of the health system. We have seen that the health system, they are shattered. So having this, even the short of little mortality also affected very highly. Then the sequelae, you can see the sequelae and the chronic effects, they are devastating. The physical and mental effects of the COVID, they are very devastating. We have seen and experienced that also. Then I am previously infected, but we know that the antibody titer varies with the severity. The antibodies, they decline over the period of the time. And then it is also added by the emergence of various variants. Various variants, they emerge over the period of time, and therefore they again have this some or other immune escape and they infect you and again cause the mortality. For the young and healthier, we know that they are also affected in the similar, the risk of infection is quite similar. And it is not that since you are young, you are not a risk of getting infected. Yes, you have a similar kind of risk. And this risk is similar to child and adolescent also. So there is some data I'm going to show you to support that. This is the data. So we support that in both of the, this is Indian data, the two waves, they are very similar age-wise spread, indicating that the risk for the adolescent and elder age group, it is quite a similar one. And symptomatology is also, there are very similar symptoms except for some diarrhea and vomiting here and there, but the symptoms, they are also similar one. Then this is a real world impact. So what vaccine has suggested done. So this is not a clinical trial data. This is a recently published meta-analysis from 51 observational studies from the 14 countries. It has shown that the vaccine efficacy fully vaccinated against the death is almost 99%. Then admission to intensive care unit, 97.4%, COVID-related hospitalization, 97.2%, and severe disease, 89.1%. And you just see what is the efficacy in partially or immunized person. You can see that in partially immunized, there is efficacy ranges around the 60 to 70%, not more than that. So it clearly indicates the importance of full vaccination. And this is a meta-analysis of the observational study. The same, it endorses what we have seen in the clinical trial data, phase 3 efficacy data. This is a real world impact of the vaccination we have seen. This is another slide I've shown you. So in terms of death, how many deaths we can avoid because of the vaccination. So this is from the UK data. So almost 46,000 hospitalization, we can prevent that. And the recent WHO data suggests that 500,000 deaths can be avoided above 60 years. So this data clearly indicates that vaccines are very efficacious and we can really prevent as the in an elder age group. You can see as the age increases, the effect of vaccine is seen more clearly. So this is a real world impact of the COVID vaccine. Now come to the another theme that, okay, you have made the vaccine, even if you don't need, then we don't trust your vaccine, because these vaccines, they are hurriedly made with compromised trials. A genetic material is used in your vaccine. It causes infection. And we know that the natural infection also induces immunity. So natural infection is the best vaccination, and it produces the infertility. This is a theme that the arguments to support the view that there is no trust on the vaccine. Now, I have some story to tell you, and I think I will like to take some little bit more time on this theme, that these are the hurriedly made vaccine and with a compromised trial. So I will just go I will go back, and you know that in December 19, we have cases of COVID-19 in Wuhan, and there is a rapid declaration by the WHO public health emergency. And in January 2020, the genome is sequenced. That is very important milestone in the development of the vaccine. And there is an urge to speed vaccine development. And in March 2020, clinical trial started. Moderna, the first vaccine clinical trial has been started. Now you can see in just a couple of months after identifying the organism, the vaccine trials have started. Now this has happened because of very important hand-holding of multi-stakeholder. So I think it is important to understand this. I call this as a billion-dollar game, and these are the partners of the billion-dollar game. So this vaccine game or a vaccine race, you can say, or a vaccine development has multiple stakeholders, multiple partners, and these are the major partners in this vaccine development. So I'm trying to tell you the story behind the curtain of this vaccine development so that we have a fair idea about what has exactly happened. So first partner is community, we the people, that means we. And our role is basically to put a demand. So all over the world, it has been demanded very highly. So in each corner of the world, everyone is saying that we want a vaccine because this is a very widely spreading disease and causing high mortality. We want a vaccine is the highest priority. And then another important part is public money is poured. If you have seen the money which is poured into the vaccine development, many of the government, they put their own money, even the billions of dollars for the diagnostic, for the treatment, and for the vaccine. And this government money is nothing but a public money. You must have heard or read about all news there, putting the $1 billion by the American government, Indian government. So a public money is put. So as a common man, we have not only the demanded, but we offered our money to solve this problem. Then third part is of massive testing. So for example, RT-PCR, now even a common man, layman also utter the word RT-PCR. But before January 2020, RT-PCR was only done in the research lab or very few labs. It was not a common test. But because of this, it has become a common, very common test, and now it is available in your nearest lab also. It was not an easy test. Please remember that RT-PCR in fact requires quite a good amount of training. But because of this, massive testing has been done. And last but not the least, we as a common man, we offer ourselves as a volunteers. If you just count the number of volunteers in the clinical trial of all the vaccines, I'm sure there are millions of the healthy volunteers all over the world. So that is our contribution to this vaccine that we have demanded. We have poured our money. We have made available us as a vaccine candidate for the vaccine trials. So this was our role. Then another major stakeholder was the government. What government has done for the people is that they make the huge funding available. Every government, whatever the possible money they want to put, they put into that. And there is a multi-country collaboration. We are already seen and this experience that the India has collaborated with the other countries, and international collaborations was there. There was an advance purchase agreement. This is done mostly with the developed countries, America, Germany, Britain. So they have done the advance purchase agreement with the vaccine manufacturer even before the complete development. So usual practice is that vaccine is developed, it was tried, it was regulated, and then there is a manufacture and purchasing. But these sequences are almost reverse. Once the phase 1 was started, and after that, there was an advance purchase agreement by the various government. So this has put a hard pressure on the vaccine manufacturer. And that was one of the disadvantages that vaccine nationalism has developed. And to counteract that, there is one developed which is known as a COVAX facility. So for the vaccine equity, I will talk about that in my later slide. Research academia, these are the most important part to play. So many universities and institutions are involved. Before COVID, you can see vaccine is manufactured by GSK, vaccine is manufactured by Sanofi. These are the multinational companies who were manufacturing the vaccine. But during the COVID, what you are hearing that vaccine is Oxford vaccine supported by Astra. The Covaxin, the virus is isolated at National Institute of Virology, Pune, given to the BBIL. So almost all of these vaccines, they are manufactured with the help of many universities. There is a reason for that, because almost these universities, for example, Sputnik, the Gamaleya University was working on viral vectors since last 20 years. So all these universities which are already working on the various platforms, various viruses, their knowledge base is used, and the vaccine manufacturers start from there. So that is the reason why it has speeded so much fast, because previous knowledge which has developed by the universities, it has been used. This is very rarely happen in the medical history. There was some collaboration with the universities and industry, but this COVID has made it compulsory like that phenomenon. Ready-viral vector, I'll just give the example of the similar with like the chimpanzee adenovector, the Oxford University, they are already working with the adenovirus, these viral vectors since last 10 years. So whatever they are doing, they are now going beyond that, and then therefore they can make the vaccine very fast. Collaboration with the industries like Oxford with the AstraZeneca, the NIV with the BBI, these are the various examples. Others are also there so that they can push the vaccine manufacturing and production. Consortium for the trial, this is also important because not only the manufacturing but clinical development of the vaccine is very important. So for that matter, the WHO Solidarity Group, adaptive designs, there are various changes or various new designs has been adapted so that entire process of vaccine manufacturing will be very fast. And genome sequence isolator. So this is the single most important phenomena. In the January 10 or 11 or 12 January, Chinese CDC has completed the genome sequence, and therefore there is a very fast development. So this is the role of technology basically. Then industry and pharma. So they make themselves ready for the massive and rapid production. There is an advance purchase agreement. They have the collaboration with institute and academia, I've just told you. They are also started their own R&D, research and development. Now we are seeing those results of those R&D, and newer technologies like nanotechnology has been used. So industry also played their own role in a way that they prepare themselves to produce this vaccine on the massive scale, because they know that it will require on a massive scale. Regulators and ethics committee also have very important role to play, because in any clinical development of vaccine, this is a limitation. So they take almost months to regulators and ethics committee to give the approval. But in this COVID vaccine, they have very urgently, expediently speeded approval has been given. So everyone make themselves to available so that we can find out the solution to this in a very quick way. And quick review of the data. So whenever the data is submitted, it was very quickly reviewed by the DSMB board and then independent board, and then given the go ahead order like that. So that is also very important role played by the regulators. And there are other stakeholders, partnership and facilitations like COVID-19 initiatives, Activate, COVAX, and then WHO, Gavi, CEPI, World Bank, BMGF. So all these are the big players and big stakeholders in this vaccine development, who has provided the money, who has provided the support, who have facilitated all the government. So this is the entire story behind the curtain for the vaccine development. So this is the reason why this vaccine has been developed so fast in extraordinary speed. Then come to the third theme, like multiple vaccine. Okay, you have developed the vaccine, but you have developed so many vaccines. I am getting confused now which vaccine to take. So that is another myth or misconception. So many vaccines create confusion. You have used the different platforms. So now you are saying the multiple data or evidence that this vaccine is better, Covishield is better, Covaxin better, Covishield is not better, Pfizer is better. So it creates me. You have used many different platforms, so that I have confused. Then these vaccines, they have shown very different efficacies, ranging from the 60 to 90% efficacy already seen in the trials. So therefore, I am already confused which vaccines to take. And again, you have added the booster, so multiple dosing. Initially, you have assumed that there will be only one dose, but now you are asking me to take one dose every 6 months like that. So all these things have created a confusion. So I'm not too sure that I should take a vaccine. Multiple vaccine, yes. They have used the vaccine platforms, various vaccine platforms. And in these platforms, the inactivated, these are the known platforms. The recombinant protein subunit, they are also the known platforms. Viral vector, RNA and DNA, these platforms, they are new one. And viral vector and RNA platforms, they have previously has been using in the gene therapy or the cancer therapy. But scientists all over the world, they are little bit skeptical about using these platforms as a vaccine and then giving it on a massive scale to the healthy population. But that has happened because of this vaccine, that these platforms, they has been used for the first time in human history on such a massive scale. The vaccine developed with this platform. So all the platforms which are available, they are used to develop the vaccine that has been occurred. And therefore, there are so many multiple vaccines that are available, and now they are in clinical trials also. If you see about the vaccine efficacy, this is the trial data, and you can see that multiple vaccines, they have the multiple efficacies. This is the trial data, and this efficacy is against symptomatic COVID disease. Please remember that. For all these vaccines, their efficacy against severe disease, against ICU admission, against death is very similar. It is almost more than 95%. Though that means that their efficacy against symptomatic disease, efficacy against preventing disease, numerically different from each one other. But their goal, that to prevent the severe infection, to prevent the COVID death, is very similar. So that is a crux of these vaccine efficacies. And again, these vaccine efficacy, they are different because they are the trials, they are conducted in different parts of the world. They are in the different time period of pandemic. So all those factors are also affected these things. This is against symptomatic infection. That is, please remember that. Multiple dosing. Now you are suggesting me a booster dose. Now this is when there comes to the booster, there is always a question that whether the booster is heterologous or homologous. Now these are the 3 published studies of the booster, heterologous boosting. These are the trials, and all these, they have suggested that with the heterologous booster, the immunogenicity is good, better than what is homologous. But again, if you compare the efficacy, because in this all trial efficacy is not tested, the efficacy will remain this very similar. So this is just for the logistic purposes. If the other vaccine is not available, the vaccine, the immunogenicity, the antibody development is higher. And even we are also done one trial with the rotavirus vaccine, heterologous boosting, and it shows similar results. So whenever there is a heterologous boosting, we know that it will give a better immunogenicity result. In fact, the COMVAC trial shows that they have the better immunogenicity, but the side effects are also a little bit more. So in a nutshell, the booster, heterologous booster, will give you the better immunity, and we know that that will happen, but they are also, as a effect, final effect on the severe illness will almost remain the same. And then there is other, exactly you can see the homologous booster for 4 to 20 times and heterologous booster 6 to 73 times neutralizing antibody. So this is a recent NIH trial. So this is a booster. So booster is there, and booster has effect in terms of the development of the antibodies. Now again, okay, you have developed the vaccine. I have, okay, that I developed, but I find the vaccine is not safe. It is highly reactogenic. It poses serious side effects. It will flare up the infection. It doesn't. It still produces the breakthrough infections, and it doesn't protect me from the variant. And it is not suitable for the kids, pregnant women, and immunocompromised. Okay, so these are the various arguments that the vaccine is not safe. So this is the data showing that the vaccines, they are quite safe. And this 0.004%, these are from the Indian data, that these are the very minimal side effects. And these are the post-vaccination thing, the fever, headache, we all of us have experienced. These are the solicited reactions with the vaccine being a biological product. This has nothing to do with the immunogenicity. And you can see that the overall, the safety profile is very good. When you compare with this a placebo thing, then the similar side effects you can see. There are some rare side effects also, thanks to the reporting of the passive reporting system. We can say that these effects are also been detected, like thrombocytopenic thrombosis, clotting events, then Guillain-Barré syndrome, myocarditis, and death. Surprisingly, the clotting events, they are seen with the Covishield vaccine and Johnson & Johnson vaccine. Though the Sputnik has used a similar adenoviral vector and it's a very similar vaccine, this event was not reported with the Sputnik vaccine so far. The myocarditis is, again, it is with the RNA vaccine, by the Moderna vaccine. And these are the characteristic of those rare side effects. This myocarditis is not seen with the other vaccines. So I'm not sure at this moment that whether these rare side effects, they are the class effect of these vaccines or not. But these are the really rare side effects, and they are occurring in a very specific age group or a specific duration, and they are not a common side effects. Now, post-vaccination, then breakthrough infection, if you point out that, then this is the Indian data and then UK data also. You can see the 0.04% of the vaccine and the 0.02 or 0.03% with the Covishield. So really a very small amount of the breakthrough infection. So after the vaccination, it will show that the after breakthrough infection rate is a little bit more after first dose rather than the second dose. I already showed you the slide for that. And these are the CDC. So they are the 88% of reduction, then 96% reduction in hospitalization, and 96% reduction in the death. So these are the breakthrough infection real data. So really these are the vaccination. If you see that, then this is a very small amount of the breakthrough infections. Sorry. Then efficacy against the variants. You have seen that all these vaccines, they have shown also efficacy against different variant, alpha, beta, delta also. This is simply because those, even though you can see that with the the Wuhan variant, the neutralizing antibody titer diminishes quite a number of fold, but still whatever the antibody neutralizing are there, they are still protective. So all of them, they have shown the good, and that is a 1 dose and 2 dose antibody titer neutralizing antibody. So these are seen that these vaccines, they are effective. And currently also there is a data that these are neutralizing antibody titer against Omicron is also better with the booster dose. So this is a fold reduction with the various vaccines. You can see alpha, beta, gamma, and delta. So there is quite a fold reduction in the numerical reduction in the antibody neutralizing antibody titer. But if you go by the protection, then yes, this amount of neutralizing antibody, they are still protective to you. So these vaccines, they will protect you from the variants also. Now, these are the vaccines. In a slide, I will try to summarize the age group, then route and doses. We all know this. This is just to give the glimpse of the vaccine which are available and given in the various doses schedule. And then this is efficacy against the symptomatic disease. We can see that there is numerical differences against symptomatic disease, but to prevent the severe illness and death, they have very similar efficacies. So therefore, the lesson learned from all that message is that the safe and effective vaccine can be developed in the shortest possible time with handholding of aggressive player, specifically during epidemic or pandemic. Then scientific rigor and rigorous testing make it trustworthy. Healthcare professional, as a doctor, we have a very important role to play in part of giving the vaccine confidence. Vaccination is an essential tool during pandemic. COVID has proved that. Again, the preventive public health measures are very equally important because we are giving the vaccination during pandemic. That is very important. When the vaccination was started in the last year, this vaccination was during the second wave, and UK and Israel data shows that they have done the vaccination and there is a lockdown. Vaccination and lockdown, and therefore with this lockdown, they have proved that the vaccination can prevent the number of deaths. So that is very important too. Preventive health measures, they are also equally important, and public engagement absolutely necessary. If there is no public engagement, then no vaccination program will be fulfilled or very successful. Now, what is the way forward for? These are the clear message and not how the way forward we can go. So this, what I have done that, what is the way forward in terms of the vaccine, especially the second generation vaccine, and what is the effect of this COVID vaccine development overall on the medicine as a whole. So regarding vaccination, so three things are very important: development, disseminating, and deploying. So ensuring the continued development of safe and effective vaccine, that is the next we will continue. So maintain a strong and sensible R&D and incentives, running the coordinated clinical trials, authorizing safe and effective vaccine efficiently and transparently, and monitoring the effectiveness during and after post-vaccine deployment. This is a development. So supplying and disseminating the vaccine around the world. This is very important. I will come to another slide in next minute. Ensuring the equitable vaccine access globally, manufacturing sufficient quantities and maintaining the supply chain, and then deploying the vaccine within the country, safely and securely transporting and delivering the vaccine, determining the fair vaccine allocation, encouraging the uptake of vaccines, ethical implication of vaccine passport and other vaccine requirement, adopting the clinical and health research system. And for all these require financing and ethics. These are the baseline for all these things. So these are the further we can move when we move towards the vaccine. And as we are considering the second generation vaccine, so there are some gaps in the current vaccine. So, and then what are the solution for that? Who is doing that? I was mentioning in this thing. So first is a temperature. We know that the Pfizer and all these vaccines are very temperature sensitive, and we have to keep it below 20, below 40. So powder for stable at room temperature has been now, they are starting developing such powder form, and vaccine which is not temperature sensitive. Then another is ease of administration. All vaccines, they are intramuscular administration, which requires a good logistic. So either tablet form to induce nasal antibodies or intranasal. So already the Covaxin, they have started their vaccine, which is given intranasally. So this will induce the logistic dimension to the vaccine program. So it will be easy for the administration. Then third thing is a potent and long-lasting immunity. So currently we have seen that the antibody level, they are declining, and therefore the newer adjuvants, they are developed so that there will be the more longer immunity and lasting immunity. High pricing, this is very important. So for the Pfizer and Moderna vaccine, but the answer for that is a self-replicating RNA. So whether this will self-replicate in the body and provide the antigen so that over the period, a single dose, and it will give you the prolonged immunity, and the price will be very low since the production of such vaccines very high, massive, we can produce on a massive scale. Mutation, this is very important. You have seen the variants. So pan-coronavirus, pan-corona vaccine, so vaccine which can cover all the mutations. This is because to identify which is the conserved region of the antigen of the corona and then making the vaccine against that. So that effort is going on. Vaccine equity, that is very, very important. Supply chain. So COVAX facility is one of the answer to that. So we should do the equitable distribution of the vaccine across the globe. Then combination vaccine, flu and corona. GSK and CureVac already trying that. So we know that these characters, they are very similar, the corona and the flu, because when initially it was assumed that this was nothing but a different kind of flu, but later on this is a different disease altogether. So that combination, so that because this flu is also seasonal one, corona has seasonal characteristics, so we can combine those vaccines. Variants, so multivalent, for example, that is, we already seen 3-4 variants, and if we can, if these variants they remain stable, then we can have the polyvalent vaccine, like producing the vaccine which have the variants of Omicron, Delta, Alpha, Beta, all like flu vaccine, having the influenza A and influenza B with both the these serotypes or strains. So that effort is also going on. And technology, I have already told you, a nanoparticle based vaccine, so which is completely safe and can be produced on the large quantity with a small price. So these are the second generation vaccine, try to answer the gaps between the current vaccines. Little bit about the vaccine equity, because we know that in LMIC and African countries, only not more than the 10% they are vaccinated, and therefore this might be responsible for prolonging the pandemic, facilitating the emergence of new variant. For example, Omicron, we don't actually know that the unvaccinated population of the Africa, they are responsible for the multiplication and then subsequent mutation and immunization, increased disease severity and global spread. So we have already seen that this inequality, these are leading to the slow progress like TB, like HIV, and then the COVID is added to that. But already these LMIC, they have their own problems like short supply, lack of capacity, lack of infrastructure, trained person, funding, and political and economic instability. These are the problems with them, but still the vaccine equity is very important whenever we talk about the vaccines, like global vaccines, which we want to disseminate across the globe. Medicine. Now, this is very important because this COVID vaccine development has revolutionized medicine in the sense that the platforms like viral vector platforms, RNA platforms, these platforms has been using in the cancer therapy and gene therapy. And therefore, the scientists, they are not sure whether these platforms are safe in the human population. There are various theories, various assumptions for that. But now, since the billions of doses has been already given, the scientists, they are very sure that these platforms are safe for the human application. And therefore, I'm not surprised that if the cancer therapy will revolutionize in next 5 years. So that is already various universities, various industries, they are talking about the different kind of gene therapy and cancer therapy using the platforms, because we are now work with this platform and we know that these platforms are safe for the human deployment. Another thing is a fast track development. We have seen that many of the drugs, newer vaccines, newer devices, they are still in the regulatory processes. But now, since the awareness of the regulatory process has also increased and they found it is useful, so everything now will be the fast track development if it found very useful. National and international partnership, again, since we have experienced that, and everyone now come to the conclusion that yes, this kind of partnership with really can solve the issues very quickly. So this will be the more and more partnership will come together. Rejuvenated academia, this is also very important because previously there was research going in the academia, but little research was taken up by the industry, and then that is marketed. But now, since the academy has given the confidence that whatever the work we do, it can be used very positively for the human thing. So these academia has now rejuvenated, and they will try and they will go for the different kind of research to propose for to solve the various human diseases, human problems. It shows the new path or thought to control or eradicate known diseases like TB and malaria. And this is also very important because still these diseases we are facing very high mortality and we are not eradicated. So now this has produced a very new thought to the given the new thought, new process to the control of this or eradication of these diseases. And from the as a general practitioner or as a private practitioner, this is my take up, or this is what has been adopted, like adult and adolescent vaccination. So as a general practitioner, this was not recommended, or very few of the physicians they are doing the adult vaccination. But now since corona has COVID vaccines has proved that these are the safe vaccines, and even adult can be given vaccine with a safe range. So all these previous vaccines which was indicated and which has shown their effectiveness in the controlling or preventing the adult disease like zoster, like varicella, influenza, pneumococcal conjugate, hepatitis, all these vaccines, they are now adult vaccination will take up. So this is the overall effect on the medicine. Now I could not stop myself to produce this on slide. This is data which is reported, and this is our own data in the Maharashtra state. So this is the data from the hospital administration admissions from 1st of December to 24th Jan across 24 medical colleges in the Maharashtra. Though this data is limited by the certain limitations, this is very important data to my mind. So it shows that the vaccine naive, those who are not received vaccine, they have the 55% of hospital admission, and their death, they are 62% their deaths. Those who have the breakthrough infection, 41%, and those who have deaths, in the 35% they have deaths. But again, I'm saying that in this data, they are not, these are not segregated by the comorbidity or clinical severity score and what was the age of this participant. Reinfections, not vaccinated, 1.6%. Previous infection, only 2%, 0.7%. And reinfection and breakthrough, 1.9%. Previous infection and vaccination, again 0.7%. So it indicates that if there is a hybrid immunity, then you are best protected so far. And I think our current scenario is that in last presentation, someone was asking where there is a herd immunity or not, and what is the percentage of vaccination in this immunity. So I think currently we are having both things. We are infected, having immunity, and that is either boosted by the vaccination. So that is my assumption, but it is yet to be proved. Now, I think this is my last slide probably. So I think this is our big opportunity for us, because we have the second largest number of cases, 40 million cases. We have the huge mortality, 0.5 million. Still, there is some differences about that. Someone say that this is underreported, but whatever the data available, I am quoting that. And we have the largest mass vaccination, 165 million doses has been given. So now it is time for us to sit back and do some data curating and find out or generate a credible evidence for real impact and effectiveness of vaccine in terms of reduction in mortality, severe illness, hospitalization, symptomatic and asymptomatic infection, effectiveness of vaccine, and then segregated as per the age groups, as per the comorbidity, as per the variants, persistent of immunity, need for the booster, and safety of the vaccine, AEFI. So I think we can generate a very credible and very huge amount of data we have. So we can generate very credible, because we have Covaxin. That vaccine is not available all over the world. So we have different kind of vaccines which are available. And this is a research thing we can do and produce the very credible evidence that vaccines, they are really, really very important to contain the pandemic. So last message, yes, I must take a vaccine because it largely prevents the disease, severe disease and illness. It induces good immune response. It is effective, safe and tolerable. So 2 doses there. So complete dosing is very important. So in a couple of centuries back, this person has said that we know very little, and yet it is astonishing that we know so much. And it is still more astonishing that so little knowledge can give us so much power. I think the COVID has proved that we know very little and very little to come more and more. Thank you very much for quiet listening. Thank you.
Thank you very much, Dr. Anand. Very illuminating talk, and you have covered almost all the myths and misinformation out there, and presented a very credible counter argument. I think everyone will be benefited out of that. Just to mention two additional things on what you have mentioned, that there is an incredible partnership set up in government, non-government, academic, industry setup.
Yes,
and there is a public finance which is available, like in an organization like CEPI,
yes,
with which I work, and also kind of examples like Operation Warp Speed by US government,
yes,
where the additional money was available to the manufacturers to take the risk of having manufactured all the needed doses even before the clinical trials are done. So usually,
Yes,
as you know, vaccine manufacturers usually would go in a sequential manner, that you complete animal studies, phase 1, phase 2, phase 3, then start vaccine manufacturing, etc. Public finances have encouraged them to simultaneously manufacture the doses without waiting for the clinical trial result. And that's why CEPI gave Serum Institute $300 million for Novavax vaccine, even when it was not started. And now Serum can export the vaccine when Novavax has got the approval. So these are incredible advances which will definitely be useful for us. And thank you very much for illuminating all those with a very credible information and very good examples. I hand over to my co-chair, Dr. Sanjay Marathe, to take a few questions people have been asking and get further.
Before that, I must say, Anand, thank you for your very interesting and lucid talk, which was based on the evidence and the real facts. I absolutely agree with what Anand has given us the details for last 3 years, what we have done. And it was really amazing. And we must compliment our own researchers and scientists of Indian origin for doing an excellent job and giving us 2 important vaccines on which we have protected almost 80% of the population. And we are not dependent on any industrialized country, and we are not begging for them for the vaccines. Friends, in last 3 hours, we are listening to the different topics on how to manage COVID. But what I have realized, in last 3 years, not a single antiviral has been approved. Not a single monoclonal antibody has come which can give us a good protection. But vaccine is the only one which is the most cost-effective intervention I have seen. And without any doubt in our mind, vaccine has given us a lot of protection against the severity of the disease, the hospitalization, and the intensive care requirement. So there is no second thought in our mind that vaccine is the only one at present which is going to protect us. The another thing which I thought, which I would like to share, that do not get impressed by the vaccine efficacy only, because the different companies will try to impress you with the vaccine efficacy. What Anand has very rightly said, the vaccine efficacy which is varying from 65 to 95 is against the primary disease. But all the vaccines which are authorized by the WHO are also called as emergency use authorization. The vaccine efficacy of all those vaccines against the severe disease is almost 100%. And that was basically the aim of giving you the vaccine. I will give the example like an Omicron. If you will see, Omicron is a milder disease. So people are not after giving you a vaccine against the Omicron, because we know that Omicron is like a flu at present and everybody is getting infected. What is more important, like we have seen in Delta wave, so many patients we have lost. So many patients were admitted and had severe disease. If the vaccine can give you protection against all these things, the WHO will say this is the one ideal vaccine which we want. The third thing, what people in the Western country, what we have seen, there after one dose, second booster, third booster, fourth booster, I'm sure any number of boosters are not going to give them the 100% protection, because we have already discussed what WHO has said right in the first year, that is 2020, you are not safe if everybody is not safe. And therefore the concept of equitable distribution of the vaccine all over the world has come. If American will give you n number of booster doses to their population, and if you get the variants from the South Africa or in other third world country, the Americans will have this problem throughout their lives. So friends, it is our responsibility to vaccinate each and everybody in this world, not in only our country. Secondly, I would like to say, because I am not only in the research but also a practitioner, these vaccines are very, very safe against in pregnant women, in lactating mother, in immunocompromised, in adults, and now also in pediatric age group from 12 years onwards. Now we have got a vaccine, and on the different platforms which are said to be very safe. Very soon we'll have vaccine for every child, about 2 years most probably. So they are very safe also. Don't worry about the variant of concern, because there will be a lot of news items which are not verified by anybody, but then you will see on the WhatsApp University, and they will make you scared. So don't get scared by all such news. Unless the WHO and the authority has said that this is a variant of concern, which has got more transmissibility, more severe disease it can cause, or an immune escape, don't worry for small variations which are going to occur with this, because this is a new virus going to mutate very fast. One more thing which I thought, I think what we have not discussed in the future, the Americans are already thinking of going for a super vaccine. If you will see, all the vaccine platforms are trying to give you protection by using the receptor binding domain, RBD or NTD. Now in a super vaccine, they are trying to go for the S2 segment of the spike protein, which is showing very few mutations. So if you have the vaccine with S2 segment, then irrespective of the variants which are coming up, this should work, and they're trying on this super vaccine. With this few addition to what Anand has rightly said, again I say thank you very much, Anand, for your lucid talk on these vaccines. If there are any questions, we'll be very happy to take.
There are a few questions from the audience, which probably Anand can take up, and maybe I can take 2 or 3 of them.
Yes, sir.
First question is very interesting. Now that almost all the subjects are either vaccinated or antibodies are present in subject due to natural infection, how a new vaccine gets evaluated? Your thoughts?
Yeah, great. So already, if you say that recently our DCGI has approved one of which is known as Cobravax, which is a protein subunit vaccine, and entirely as we are now doing the trials, we have to compare this vaccine with the known approved vaccine like Covishield or Covaxins. We just can't use the placebo for these things. So these vaccines are evaluated based on the immunogenicity, whether they will produce the similar immunogenicity as to that of the approved vaccine, because the efficacy of this, to determine the efficacy, it is very, very difficult, and it is basically not needed, because we have already given the billions of doses and efficacy is already proved. So I think there is no need to prove their efficacy in a trial. What we can do is now almost all trial will be the more of immunogenicity and the bridging studies.
Yeah,
sir,
but
you
I
can
think,
add.
sure, I think there would be a requirement of phase 4 studies in terms of effectiveness data after the vaccine has been used in the population.
Yes.
That sort of strengthens the credibility of vaccine. Of course, here you are comparing the immunogenicity with a comparator only, and that needs to be translated into the data as well.
Yeah, I'm talking until the approval of the vaccine.
Yeah, sure. Absolutely. The second question here we have, Dr. Anand, is why there is a EUA for children when there are no pediatric deaths in 2 years, and why no emergency ban when there are 18 deaths so far? I don't get the second part of the question, but I think the first part you can take up.
EUA for children.
EUA for children, when there are no pediatric deaths, why you go for EUA in children?
See, the emergency use authorization is, I think, I would like to talk about little bit about that. This is not a marketing authorization. This is a emergency use authorization. It is usually done to prevent the pandemic or epidemic like situation when the transmission and the risk of infection is very high. And therefore you have seen that almost all the adult population is vaccinated. The group which is under risk is a adolescent and the children group. So, and we already know that since we have the survey data that they have very similar kind of risk. And the death data, if you have seen that in the children, and again the same thing, those who have the comorbidities, they have very high risk of developing the disease and then death and critical illness. And therefore the EU has done, because these population has remained to be unprotected, and if they are infected, then they are their inherent capacity, they are very much highly multiplying. So the viruses in the respiratory tract of children and adolescents, since they have the lesser number of the ACE receptors, the virus will remain in the tract and they will have high chance of transmission. So they are potentially transmittable. So even if a person or adolescent or children in a family is infected, then the older member of family who is suppose non-immunized or non-infected is under very high risk of getting the infection. So that is the reason why the EU was extended to the adolescent and children, because their risk is very similar and they are the potential transmitters of the infection. And then I also understand the second part of the what is the death they have said.
Okay, we can leave it. The last question I can take before summarizing and finalizing this session is, when would the new COVID vaccine with a new variant will be available?
Now, yes, they are developing the vaccines with the specific variant also, but I think if you look at the overall data, then the vaccines for specific variant is unlikely to be required. Because current study from the Paris, they have shown, the France, they have shown that the vaccines, the Omicron vaccine, it has immune escape to all of the monoclonal antibody combination, and again the natural immunity by the booster. But they have effective, after one booster dose, it has prevented that. So they have shown that. So even with this booster, and if the booster is heterologous booster, we know that they have the better canvas or the better this spectrum of the antigens to be, and then antibody to be developed. So I think it is not required as such, unless the variant is very, very either severe, giving severe infections, or it has different characteristics, and then the variant is stabilized. What I mean to say, basically, all these variants, we have not since they are under evolution, we have not seen their stabilization still. So what we have seen with antigenic shift and drift with the influenza, these things are not yet to be seen with the corona. Corona is still evaluating various variants. Immune mutations has been occurring, and I'm not sure if it is the mutation at receptor binding domain, they are having so much mutation. So if these mutations are there, then ultimately it could be the very different virus. It will not remain the coronavirus, or it may not attach to the ACV receptor. So that is the reason why we don't, as Dr. Sanjay has said very clearly, that don't rush towards the variants. Look for the clinical, their effects on the mortality, effects on the transmissibility, and then only we can consider about the vaccination. Thank you.
And a very interesting study has already come with the addition of a specific variant in the vaccine.
Yes.
And the ultimate result was there was no significant change. So
that will happen. Yeah.
So don't be after that giving a specific vaccine against a variant, because then the companies might play some gimmick and saying that our vaccine is very specific against a vaccine. Nothing that sort has come in the studies.
Yeah, with these variants, I always remember the scene in any movie that the villain is standing in the center and there are many mirrors around that. and then they break down every mirror, find out who is the real one. So the corona is making like that.
Yeah.
The variants, they are like that. So we want to catch up the corona, not the variant.
Correct. Absolutely, I agree with
Sure. Sure. Thank you. Thank you very much. Very illuminating talk as well as discussion. I think Dr. Marathi, if you don't have to, if you have anything to say, otherwise we can
I think
close
we have
the
covered
session and
everything.
hand
We have
over
covered
to,
everything.
yeah.
Yeah.
Sure. Thank you.
Thank you.
Back to the organizers. Thank you, Dr. Anand.
Thank you, Nitin sir. Thank you, Sanjay sir.
Thank you, Anand, for an excellent talk.
Thank you, Dr. Anand Kavade sir, for clearing our doubts on the COVID vaccination, and also thanks to our chairpersons. And now we invite our eminent speakers for panel discussion on the difference between the wave 2 and wave 3 medical management. Shall we continue?
Rupali, I am audible?
Yes, sir. Audible. Clearly audible.
So should we start and try to finish it as early as possible? Should we start?
Yes, sir.
Chalo, thank you. Thank you. Now we are into the last lap of our today's webinar, the panel discussion. As per the organizers, it was given to me as second versus third wave of SARS-CoV. But what I have done, I have made it wave first, second, and third, I think, so that we have a better idea what has been we are doing and what is happening in fact. So shortly, as organizers have strictly instructed me to finish it within 20 to 30 minutes as early as possible. Otherwise, they are going to penalize me for it. So my first request will be to Dr. Sudipto sir. Sir, we will be having your opinion regarding the season variant, virus variant, and the testing capabilities as per your opinion. Sir, the first question, in season variation, as per the slide which is visible, first wave started in April 20 to September 20, second in February 21 to June 21. Now December 2nd or 3rd, we started with third wave. It seems almost no month or no day of the year is now spared by the COVID. Initially, maybe 10-20 years back during our H1N1 days, it was specifically July to November to December what we had that H1N1 infection SARS. But now this is has no month or day spared. What is your take, sir? Dr. Sudipta, sir.
Yeah, yes, sir. I think you're absolutely right. I mean, and as far as the data shows, this not only for India but even globally, say Europe, the American continent, there has been no seasonal variation that we have been able to see in any of these waves. And in fact, we are just, in fact, these are just the waves, but we must also remember that even between the waves, there was a constant level of new infections that we were witnessing in India as well as outside. So for reasons still unknown, for influenza is very clear, for the seasonal, but for COVID, SARS-CoV-2, we are still not very clear as to why there is no distinct seasonal variation, or in fact even geographical variation for that matter. So I agree. This is the observation, but we need much more data, much more research into this phenomenon. We don't have an answer right now.
Thank you, sir. Sir, second question associated with this regarding the virus variant. There was some Greek alphabets which were shown in our WhatsApp groups and virus variants also. So fortunately, during first wave, we never had it strike like a bolt. We were all shocked. Second wave, we were prepared. We were well prepared with oxygen, drugs, and everything. Now we were waiting something wrong to go happen during Omicron, but fortunately, it has not happened. That is good thing. Sir, point to note, during first wave, we came to know regarding the virus variant at the end. Like in October or November, we knew it was which viruses were happening. Same thing happened in Delta. When it started in Vidarbha, district, some few districts in Maharashtra, in February 1st, then we had a massive explosion of cases, which went on through March, April, and May. And at the end of May, we came to know we are being hit by Delta. Fortunately, this has not happened in Omicron. The first thing was detected in South Africa, and immediately we came to know what is going to happen in within first 1 or 2 weeks. So looking ahead, say after 4 months now, as on today, say, are we looking at another fourth wave in next June or July? Whether it will be a more milder one as we progress in our academic research and genomic sequencing studies, we'll be able to tell correctly when it will happen, what type of variant we will get, and how we will be able to deal with it.
Yeah, it's a good question. To answer this, I'll just go back to what happened between Delta and Omicron and the time period. During the peak of the Delta wave, there was a modeling study led by ICMR, which has been published. I can share the publication and the summary of that with all of you maybe in the WhatsApp group. But it around this modeling study was done. It came out in around June of last year, 2021, in which exactly the questions that you have just asked were addressed as to the future of the SARS-CoV-2. The modeling, I mean, as most of you would know, modelings are basically done on certain assumptions and certain scenarios. So that publication clearly says that the Delta wave, which peaked in April, May, and it was starting to slow down in June, will continue to come down. I'm talking of June last year, and they're talking of the future. It will continue to reduce number of cases, and the overall COVID-19 wave may reduce. However, provided there is no emergence of a new variant. And unfortunately, that is exactly what happened by October, November. I mean, all of us know in India, at least, cases went down, and then Omicron started coming up in November, end of December. That is exactly what happened. So again, we will use the same our experience and same data, previous data, that we are living through an Omicron wave right now. Hopefully, if it goes down, say by February, March, it should continue to go down unless there is another equally infective variant that comes up later on. Now, however, one difference between last year and now, current day, is the status of vaccination. So June last year, probably hardly 10 or 15% of the total population was completely vaccinated. Today, more than around 60% is completely vaccinated, and 90% at least one vaccine. So vaccine now should play a protective role. And as we had seen throughout that, infectivity might remain higher, but the severity is definitely on the lower side. So this is something that we may expect over the next few months.
Sorry, sir. It is regarding the testing facility. When we started in first wave, as I remember, sir, being one of the GMC's involved faculty, out of 10 districts in our Vidarbha, only one single lab was catering. Only one single lab. Moving on, in next 2 months, from March to April, within 6 weeks, there were 3 labs which were started. And as on today, all 10 districts has 10 different labs. So it is a wonderful thing which has happened. As being witnessing the RT-PCR and the VRDL labs, how they function and how much efforts, manpower, preciseness, specificity, how much efforts are being made by those microbiology people to run those labs, it is fantastic. So government has really done a wonderful job in putting so many efforts to start so many VRDL labs. As we move ahead to second wave and third wave, we have enhanced the capacity of VRDL lab. We are getting reports as early as 6 hours to 12 hours max, not even as everybody is aware. Sir, what is the future now? Are we going to what Dr. Anita was pointing out? Like there was also some starting of Asian dropout kits also when we started Omicron in first week of Jan. In all VRDL labs, some kits were provided for Asian dropout testing. Now, what is the future of testing now? Are we going to test for specific variants of the virus so that we can pick them early and we can take care of them early?
Yes, yes, I agree that testing capacity has increased massively over the last 1 year, 1.5 years. In fact, ICMR has validated more than 100 testing kits, a combination of RT-PCR as well as RATs over the last 1.5 years. As far as genomic testing capacity is concerned, yes, that it still needs to be scaled up. As I mean, since it's a very highly specialized test, as all of us would know, not everyone can do it. But the idea, I mean, as of now, we are still going ahead with testing and symptomatic and contacts. You test and then you isolate and treat. It's still the strategy, and that will remain the strategy over the next 3-4 months for sure. And at the same time, enhance the capacity for genomic testing also. So look for variants. So we'll be able to detect the different variants. So, but then, as I said, as this wave starts to decrease, maybe looking at the data, looking at the clinical picture after a couple of months or 3 months, testing strategies may change then. But as of now, this is what the official testing strategy is and will continue for the next 2-3 months at least.
So it may happen that all the COVID testing will be done by some rapid test, which will tell us patient is positive or negative, and all the VRDL shall be augmented to only conduct the specific genomic sequencing so that we can diagnose them early. Is it a
Absolutely.
possibility?
It may be a possibility, not just VRDL, but there are some other specialized labs also, even private labs also will play a major role in this genomic testing also. Because as I think I heard in one of the sessions that this COVID showed a very strong partnership between public and private institutions. So yes, not only VRDLs, but other labs also can be scaled up for genomic testing. And as you said, RATs and even RT-PCRs for that matter are now commonly done validated by many labs. So they can continue to do that.
Thank you, sir. Thank you, sir.
Thank you, sir.
Sir, my second group of questionnaire shall be directed towards our great clinicians, Dr. Anita Madam and Dr. Kedar sir. That will be directed towards clinical features, treatment, and complication scenarios. So may I start, sir? Dr. Anita Madam? Madam is with us. Dr. Rupali? Any idea? Dr. Kedar sir or Dr.
No, sir. Mostly she has lived.
Okay, doesn't matter. Sir, then we have with us Dr. Sanjay Marathe, Dr. Ashish Satov sir. Those are they are the great people around. One is a pediatrician and one is a physician working since last 25 years in a place where even knowing patient, what patient has or whether patient is able to give us a clear-cut clue what he is suffering from. Leave apart the RT-PCR test. Things are very difficult where Dr. Ashish sir is working. I can really definitely would like to hear, and all of us are here, what Dr. Ashish has to give us his narration over a period of last almost, I should say, 2 years, what is being happening at a tribal place where getting a antibiotic at a proper time is a hurricane effort which he has to make. Only he has access to the best of the people around the world, but to get the access for the medicines, for the blood test or the investigation is the most difficult. And last but most important is the manpower which we requires to work round the clock for these people. Dr. Ashish, please tell us your experience with COVID over last almost 1.5 years and more.
Yeah, thank you, sir. Thanks a lot for the kind invitation. Actually, the major challenge in such rural and tribal areas is of testing facilities. As you know, even tests like RT-PCR is not available. If I'll collect the sample and send it to Amravati, it will take at least 8 to 10 days to get the results. So the major challenge is how to manage the case if the rat test is negative. So most of the cases we have to manage it clinically. Even facilities like D-dimer and CT scan is not available, but that was a boon for us because now it has been proved that D-dimer and CT scan is not at all needed for management of COVID. And with this minimum facilities, the mortality rate in our ICU was just 13.9%, which is one of the best in India, I can say. It all depends on your clinical judgment. And most important thing, what I realized during this pandemic is that if a doctor is ready to examine the patient properly without forgetting the clinical skill, and like I like to elaborate on one major thing, like most of our cases they presented in terminal stage with hypoxia SpO2 less than 88%, like that. And in that case, in most of the cases there was no chest signs on auscultation. So, and as the x-ray was not very conclusive, no CT scan was available, then we empirically thought of probably pulmonary thromboembolism, and we treated it accordingly with oxygen, steroids, and with low molecular weight heparins. And I'm very happy to share that we got very good results out of it. So clinical judgment in the era of today, a lot of diagnostic facilities and these things for rural India, especially for tribal India, clinical judgment still is very important for management of patients. That one way I want to guarantee. Second thing, the issue of vaccination. Like in cities, people are ready for vaccination, they accept it very easily for it, but in rural and tribal areas, people are very reluctant for vaccination. It's very difficult to convince them. Many of time our team went to field for vaccination with all sorts of equipments and drugs, etc. But people refuse for vaccination because of myths, etc. So I think for rural and tribal area, major challenge is intensive behavior change communication programs for improving the vaccination in such areas. And third thing is that we should now come out from the standard pattern of clinical management and investigations and think out of box. Like in our cases, we found many cases of, as I asked the question also, quadriparesis or monoparesis or cardiovascular diseases in our setup. We managed those cases clinically. We found that like hypokalemia, hyponatremia were very common in our setup. And there were very few studies conducted in India who shows hyponatremia or hypokalemia. But we had gone through some review of literatures published by Chinese scientists, and they have mentioned that acute tubular necrosis is common in COVID, leading to hypokalemia and hyponatremia. We could pick up in this situation. And another thing, what we found that hyperglycemia is very common during COVID. In tribal areas, diabetes is very uncommon. And most of the cases who landed into terminal stages, they presented with severe hyperglycemia, though there was no fast history of diabetes mellitus. That is new thing we got it. Sepsis was very common in our setup. Like as I said, no facilities for culture, but from like TLC, the total leukocyte count was more than 15 to 16,000 in most of the cases, though Anita madam has said that leukopenia is common in COVID. And other than these health related issues, non-health related issues are very important in tribal areas, like availability of food, especially to severely mal or under 5 children, to pregnant ladies, because during this pandemic time, The Anganwadis were closed and there were no food supply, home-based food supply to these tribal children. So the severe malnutrition increased from 14% to nearly 20% in our study, in community-based study also. So there are a lot of other issues, especially the effect of lockdown, lack of employment, and it has increased the depression as well as suicide rate in tribal areas. It has suicide rates jump around by 25% during the second wave of COVID. So I'll request all the panelists and the experts in COVID that they should think of. And now the as city people in the cities, they have been vaccinated nearly completely. The third wave will hit definitely to the rural and tribal areas. Still now there are 3 to 4 cases in our ICU. 2 patients, they are in need of ventilators. So, and we don't know whether it is Omicron or it is Delta. It might be Delta, it might be Omicron, as the community is not vaccinated. So rural and tribal areas government should now focus more on such areas to prevent deaths in such areas, because already in such tribal areas, the age-specific mortality rate in the age group of 16 to 60 years is very high, which is more than 400 per lakh population. So every year in tribal areas, more than 2 lakh premature deaths are happening, which is not noticed at all. And COVID may increase this death rate in such areas. Thank you.
Thank you, sir. My second question is to Dr. Sanjay Marathe, sir. Sir, in the first wave and second wave, you are very actively involved in COVID management. Now in third wave, since last almost 3 weeks back, Ministry of Health and Welfare issued pediatric guidelines for pediatric COVID management. Sir, my question is, I have gone through those few days. As soon as it was there is a massive change in treatment guidelines in adult and pediatric. What we have for adult management, antiviral drugs, remdesivir, cocktail therapy, those are not mandatorily being contraindicated for the use in less than 18 years of age. That is one. Then what is your take on this? Then how to manage, say, moderate to severe COVID in pediatric age group less than 18 years?
Excuse me, sir.
Ah.
Anita madam is there. Due to connectivity, they had lost in between for few seconds. Ma'am is also there.
मैडम है तो अभी
Yes.
मराठी से रहेंगे तो ये खत्म कर लेते, बाद में we will go back to Anita madam.
Okay, okay, sir. कोई problem.
Already question is floated in, that's why I was just. संजय सर है? I think sir has left.
हाँ, mostly, sir. Probably.
No issues, no issues. Dr. Anita madam, sorry to not being with you for a few moments. Madam, I have a specific your opinion needed regarding our panel discussion regarding clinical features, treatment modality and complications on these 3 issues, madam. The first part, clinical features, as we see it, clinical features in first wave, second wave, and as we move on to third wave right now, are we seeing less severity of symptoms in comparison with first wave and second wave? As now what we are seeing as a third wave, only throat pain, body ache, myalgia, or pain in throat symptoms. That is one, sir, madam. Second is treatment. What we were in first wave, we were mad. Whatever things were made available, let it be, I should say, oral antibiotics, antivirals, then ritonavir, lopinavir, HCQS, ivermectin, whatever was made available, we were using it right, left to save patients. In second wave, we were more guided by our all research, phase 3 trials. We become more judicious and more careful while selecting the drugs. Now, when we have everything ready with us, Unfortunately, we are not getting patients, critical patients, I should say, to really use our armatorium. What is your take, madam?
Sir, as far as the investigations are concerned, yes, very rightly, as you said, we are seeing a lesser severity of infection and the symptomatology in most of the patients. In fact, majority of the patients are not even requiring any kind of major care. We are able to manage them on the basis of protocols at home front, and that's also just simple symptomatic treatment. Drugs like molnupiravir and remdesivir is being used only when there is an absolute indication to do so, and especially for patients who are at a higher risk of progression of disease. We have not been using it otherwise. Remdesivir, yes, we are using only for those who are critically ill or ones who have an extremely high risk of progression. We can give it for a 3 days dose, like what has been propagated by NEJM. So we could use that. But other than that, majority of the other drugs, I think, have almost been, got out of the treatment modality. And like any other flu-like illness, we have learned to manage it symptomatologically. So I think that has been helping us big time. So you need to unmute yourself.
In our first wave, regarding complications, we were quite like seeing the complications what we used to see in our internal medicine ICUs. But as we progressed to second wave, we had sepsis which were different. We had patients which were deteriorating on third and fourth day of admission. Like in first wave, patients were deteriorating after 1 week. Second wave, patients started presenting early, third or fourth day with severe ARDS. We treated them as per our guidelines with so many drugs. Still, we have very high mortality and sepsis. And not only sepsis, we also had data which shows fungal infection, mucor. Now, mucor, as like it was a big, huge outcry. Like what went wrong? Whether it was the oxygen delivery, whether the reusable mask, whether it was the what we say a non-medical oxygen cylinders being used, and so many theories were made out of it. Like what went wrong? Somebody put it on a clinician's heads. You are using steroids extensively and unscrupulous doses like 500 milligrams or 250 milligrams, and that is making the mucor out of a very huge disaster for us. Now, what is your take on this? And in third way, as we are seeing, madam, since last 1 month almost, the number of admissions are related more with comorbid conditions, related with very high with CKD, end-stage renal failure on maintenance hemodialysis, intracerebral bleed or acute infarct, or patient getting acute MI, or even as surprising as organophosphorus poisoning, patients getting coincidental COVID RT-PCR positive. Now, this is a variety of patients which we are getting, and out of almost, I should say, 80% death right now over a period of 1 month we have. They are in single digits only. Majority patients, those who died, are non-vaccinated. So what is your opinion on this?
So in the first wave, I think we were just not in a position to really handle anything at all at that time point. We were just in the learning curve ourselves. So a lot of it could have been the AKI, the sepsis, some of this could have been just actually missed. We may not have been really competent enough to pick up quite a bit of a thing, at least in maybe in a medical college hospital or in a tertiary care center. These would have been easily picked up. But in smaller setups, it is challenging to go ahead and pick up these kind of cases. Second wave, I think a lot of it actually stemmed up from the lot of use of unnecessary antibiotic. So we started seeing a lot of drug-resistant bacteria. So there was a knee-jerk reaction the minute the CRP goes up. We have all trained to understand and think that it is a bacteremia and it's a bacterial infection. And 3-figure CRPs you don't really see in viral infection as such. So people actually treated with a lot of antibiotics, which probably also led to the counter growth of the fungi. That might have been one of the ways to look at the whole thing. Secondly, we need to understand that Delta by itself probably also had something to do with the mucor. I don't think it was just hyperglycemia or just steroid or just the industrial oxygen. It could have been it could have been multifactorial. So probably all of these also led to the increase in mucor, because even in the first wave we were using steroids, but we didn't see a rapid increase in mucor like we did with the second wave. And thus far, fortunately for us, since we have not really used much of antibiotics, since we really have, it's been a month and a half since we are into the pandemic, and we have not really seen any major concerns as of now. Yes, there are patients who are coming with, some of them who have been a little critically ill and who required oxygen and HFNC. They are coming with a little bit of long COVID kind of symptoms, but none of these are overwhelming, or we have not really seen any major complications coming out of the third wave as of yet. I hope it continues to be in the same way.
Let us pray for the best, madam. Thank you, madam. Thank you.
Yes, sir.
It was great of you. My last leg of panel discussion goes with Dr. Vairakar sir and Dr. Anand Kavade sir. Vairakar sir, there is specific question regarding this strategy making, as you and yourself and Dr. Kavade sir being internationally acclaimed people in today's webinar group. Sir, how do you see India's COVID? What we did in first wave, second wave, and what we are seeing a third wave. We started in first wave after 22nd of March, within 1 month. It was like what in our maybe say 17, 18 years of age, we have never seen a curfew after our teen. But our children were fortunate to see what can happen. How do we see it as a curfew? Complete shutters are down, no vehicles and nothing. Then got many epidemiological advices regarding the buffer zones, containment zones, contact tracing 1:20. We did it well in first wave, absolutely correct. Second wave, all these things were going well, but mere a bombshell of high case burden along with vaccination took away our contact tracing. That is the biggest casualty, as well as the manpower required for curfew and lockdown. It also went off. So whether the second wave was also made so huge because of these things which we couldn't impose, a proper lockdown, proper containments, proper contact tracing, and agreed. Now see, look at the third wave. Since last Diwali, we can say October or November 2021, it is now God's own country. Nobody is doing anything. Everybody has his own will. Only in Mumbai, I have seen, or Delhi at the most, where there are really some bit marshals looking for your mask and fining and something happening. Otherwise, all COVID appropriate behavior is not being followed. That is, sir, what is your take on this, sir? And second, associated with this, sir, there was a very huge and cry regarding the Maharashtra being the worst state in performing the total number of cases and total number of deaths over a period of last almost 2 years. So do you really feel की आपण खूप जास्त प्रामाणिक होतो, आपण चांगलं काम केलं, आपण लपवलं नाही म्हणून आपल्या figures are big, because there are states those who are bigger than us and they may not be well equipped as we are, but we are paying prices, being a very good people, human beings. Sir, what is your take, sir?
So thank you very much for both of your questions. I'll take the question number first. First question first. So as you know that during COVID, this was a new virus and the control strategies were also new. And as you rightly pointed out that even in our lifetime, we never seen any city shut down or anything, right? The first proof of principle or first demonstration came when Wuhan city of 11 million got shut down in China. And then the world realized, yes, we can do it also. And then that's how it was implemented. Then subsequently, as we went on, we realized that lockdown is not only arsenal in our kitty. There are vaccines, there are drugs, there are better case management, there are masks and other things also, and social distancing or physical distancing, which we can sort of apply into this. So that's how sort of it transformed from total lockdown strategies in the first wave to sort of a limited control strategies in second wave. And now we realize that, and of course, Omicron's clinical presentation being mild has helped that we don't require any lockdown or we don't require any control measures. That's the wrong thing. Basically, what I'll say is that we need to evolve as a humanity and as an Indian culture. We really need to follow the strategies of what we can call as vaccine plus. Vaccine, everybody understands, and plus is the masking or the use of mask in public spaces. That we really need to adopt, and mask should be a parcel of our day-to-day life as well. You must have seen the Japanese tourist, even way before COVID-19, wherever you see any masked person, you can definitely say that that person is from Japan, because it's a cultural thing, it's a philosophical thing. It's not the philosophy behind that is that I am responsible for health of people around me, and people around me should not suffer if I am infected. That's why I'm wearing the mask. And that philosophy, we really need to imbibe. I think that's number one lesson I'll say in this part. The second part of the question, and of course, Dr. Kaude can also add on to the differences of management and strategies between all these things. The second part of your question is Maharashtra is highest in number of cases and number of deaths, whether it is due to the sincerity or whether it is due to underreporting in the other states as well. I'll say that there are good examples. Yeah, initially you can say that Maharashtra has a good infrastructure and has upgraded the diagnostics also in that way, and a better case reporting, better deaths also. But it doesn't stop at that, basically. A critical issue in deaths, particularly, I'll say cases are, that's okay, your indicators and all, but particularly death, how you ascribe the cause of death. Whether are you going to, and of course we know that in the public health and in the situation that there are immediate causes of death and there are underlying causes of death, and we have not understood all those things and implemented during the COVID. So either you are likely to get everything associated with COVID, that every death is COVID death, or on the other hand, you may not report it as COVID death, but it could be severe immunocompression or in any severe disease or any other illness that gets to the certificate as cause of death. I think the standardization of cause of death practices in the private sector and in the public sector is the basic need to understand these death numbers. And that's what is my take on that. I definitely, there would be certain underreporting in certain areas and certain geographies as well, but it's very difficult to pinpoint what's the quantum of underreporting there and what's actually the deaths would be. I stop here, and I think Dr. Kaude can add on to these two questions.
Yeah, thank you, Nitin sir. Thank you, Mukund sir. Now I am completely agreement with Dr. Nitin sir. So the two questions, one is regarding the underreporting of the deaths and another is regarding the lockdown. So now regarding the deaths, now clearly one study has recently published by Dr. Prabhat Jha and his group. and they show that the death reporting, actual deaths, they are almost 6 to 7 times more from the India whatever are reported so far. So they have analyzed different data sets. So that is very clear. Even we have experienced that when the number of deaths they are occurring surrounding us, many of our family members, friends, they have lost them. So that is very clear that the death number of deaths they are very high. We are also now studying the excessive mortality in COVID at our center also. So, and we know that there are differences interstate, and that is big since the health is a state subject. I think that differences we have seen in every item. We are seeing the interstate differences in infant mortality, vaccination, immunization, pregnancy care. We have seen those differences. The important part, I think that as a scientific community and as a medical fraternity, we should learn that as we are more transparent in this kind of information or data, that will ultimately benefit us. This is not that we will not get anything if you hide this information. Rather, we will lose. So getting a transparent and very clear information and data will ultimately help us in managing the resources and managing the health system. So that we should understand that everybody in this country as a medical fraternity, if understand that, then I think these differences will be lessened down. Otherwise, these are the differences will remain. And as you correctly say, yes, as a Maharashtra, when I talked this, I think Kerala is also better. Good data is also from some other state also. So these differences will exist unless we identify that this transparency will help us ultimately. The question number 2, the lockdowns, yes. These measures, I think now we should use very judiciously. The importance of lockdown is that as this pandemic is very rapidly spreading, and the first question is now protecting ourselves when there is nothing else. So that's why those lockdowns are there. And another important part of lockdown, I think, when the vaccination was started, initially it was then started in UK and then Israel, and they have done vaccination, phased vaccination, and then lockdown, vaccination, lockdown, like that. And they show that this vaccination plus lockdown, it is very effective in mass vaccination during pandemic. That is very important. When you do because previously there was some strategy how to vaccinate during pandemic. For example, in Ebola, we've seen that there is a ring vaccination. So those, when the case is there, then vaccinate surrounding them. We also seen this kind of vaccination in our cholera and these epidemics. So that has been there, but what to do when such a huge pandemic is there? So that way lockdown has really helped. And there are, I think there are some studies which show that this lockdown, masking and distance has prevented as many as 20 deaths, 20% of the deaths. But yes, that is, and these are the layered prevention we can use now very judiciously based on our strategy, number of deaths, whether they are masked or whether distancing, then how much you can intermingle like that. I think two important, I want to put the things which are very importantly and they are missed. Number one is the integration or the collaboration of the private practitioner. I think government has really missed that. In our state or in our entire country, as the 60%, more than a 60% population is taking treatment or care seeking from the private practitioner, government had literally ignored them in first and second wave. And that has increased the burden and that helps to collapse the system. So should government if allow the private practitioner to treat the patient, right, with all precautions. We have seen that the number of all private practitioners, they are changing their OPD practice, they are doing these setups, they are different setups, and they do that. So giving a good guidelines, allow them to treat. So at least, because we know that our health system, they are not that much, they are very illy prepared for that. So that is one important thing, that they have not collaborated nicely with the private sector. And another important point is this giving the guidelines and then making see, this is basically the health issue. So how much to make this health issue as an administrative issue? That is very important. There is a thin line. When there is a pandemic, there is a very thin line to make the health issue as an administrative issue. And we are making this very completely administrative rather than the health issue. So I think there we have weakened that. So if these things have now, if whenever there is pandemic or epidemic, if you clearly define this, if you take the help and collaboration with the all the health sector, then I think we can still better manage the things like pandemic and epidemics. Thank you.
Sir, thank you very much. One last, very rapid and very quick, true answer from both of you. Sir, since last 200 years, we are getting multiple epidemics. Maybe as we recollect in our history, started with plague, cholera, yellow fever, Ebola, Zika, SARS. Now, Middle East, now COVID. Do you really think humans are going to win, or is God is going to spare us?
Yes, sure. So I think it's a constant struggle, constant battle, and humans are trying to do better than the previous time. As you know that globally all over, we have already started working on how to tackle the next pandemic when currently we are battling the pandemic as well. Like there is an international plan on 100-day mission by CEPI and other organizations to get the vaccines within 100 days of emergence of the pathogen. And how do we do that? It's a different ball game and different money requirement and different partnerships. But yes, we are trying to go ahead on that. Second part is the genomic surveillance and innovations around that. You may know that as you rightly pointed out some time back that Omicron and other variants are to be detected on genomics only. But you know, during this COVID pandemic, how many millions of full genome sequences have been uploaded in the GISET database that has sort of taken over the combined tally of all the sequences in the gene bank as well. So it's an advance. Now we are coming up with a portable genome sequencer where in the field you can within 2 hours you can do a sequencing. So that's the next advance. So it's a constant battle with the nature, of course, and humans. Whether human will win or whether they will extinct, it's a question nobody can answer. But I think I'll say full marks to human ingenuity and planning. We are trying to create more innovations and more armament to our arsenal. Anand?
Yes, completely agree with that. And I think, yeah, we are seeing, so now in last 20 years, we have seen the 4 coronavirus pandemics. So SARS-1, SARS-2, MERS, and now COVID-1, and then other corona also. So I think the virus will evolve, and then we must be prepared for pandemic. So pandemic preparedness is very important, and I think the technology will help us. So really they will help us as these genome sequences. So we can quickly identify the organisms, and then we have seen that we can quickly make the vaccine, and then the measures to control the pandemic like lockdown, masks, separations, we see that we have seen that we can very effectively use this. Now it is up to us that how these various measures can be used very effectively and efficiently to control the pandemic. So I think now this is a step to us that we should be prepare ourselves for the various pandemic, and then how to use these different modalities to prevent and then treat, condemn such pandemic. Thank you.
Thank you very much, sir. It was great to interact with you. Thank you very much. Now I will hand over all proceedings to our Master of Ceremony, Dr. Rupali Madam and Dr. Bhavesh. Thank you.
Thank you, sir. Now I invite the Secretary of APMP Akola, Dr. Prashant Jhamar sir, for vote of thanks.
Hello, I'm audible?
Yes, sir.
Good afternoon to all our honorable speakers, chairpersons, delegates, IMA members, and my colleagues. It's my privilege to propose a vote of thanks and acknowledge the contribution of those who work really hard to make this online event possible and successful. I, Dr. Prashant Jamad, on behalf of IMA Akola and APMPA, extend my sincere thanks to all our respected speakers, Dr. Anita Matthews ma'am, Dr. Anand Kawade sir, Dr. Kedar Toroskar sir, Dr. Sudipta Roy sir, Dr. Ashtaputre sir, and Dr. Garge sir. You spared your precious time from your busy schedule and give us an opportunity to hear your important thoughts and experiences of COVID-19. Sir, your deep and intellectual way of sharing knowledge added glory to this event. You gave deep insight into the topic and revealed some interesting facts about COVID-19. This will surely encourage us in future and will show new path to tackle and fight COVID-19 in next upcoming waves or similar epidemics in future far better way. I am thankful to all respected chairpersons for chairing this session. An event like this can't happen overnight. It requires planning and hard work. I am thankful to team IMA Akola and team APMPA for their solid backup. Special thanks to IMA President Dr. Mahendra Kale sir and APMPA President Dr. Ajay Jhunjhunwala sir for their valuable support. I am thankful to Dr. Jethwani sir, Mr. Dipen Mehta, DG Shield, and their technical staff for arranging such a beautiful online technically sound webinar. I am thankful to Dr. Bhageshri Madam, Dr. Rashmi Ajmera, Dr. Rupali for smoothly conducting today's webinar. I am thankful to our MMC observer for today's session, Dr. Makarand Vyavare sir and Dr. Mukherjee for evaluating today's session. I am thankful to entire audience and delegates for their online participation and congratulate them for getting such a valuable and wonderful information, including etiology, pathogenesis, epidemiology, treatment modalities, even prophylaxis. Last not the least, each and every one I thank from my bottom of heart. I declare that today's program is concluded. Thank you.
Thank you. Thank you very much. Thank you, Nitin sir.
Thank you, everyone.
Thank you.
Thank you. Thank you, everybody.
Thank you, Sudipta sir.
Thank you, sir.
Thank you.
Thank you to all.